however, there were symptoms which could have been had a differential diagnosis of poisoning. Similarly, another area which we could see of that is huge developments and survival rate is very high is rodenticide poisoning, where a lot of thought process has gone in and treatment protocols have been which are unique to the India and probably Asia have been developed. But one area where we could see that there has been some high death percentage, one of the in the cases where the death is very high is OPC poisoning. So probably I request all of you to look into that, and probably as you did a very difficult one has been the death percentage is relatively low. That is rodenticide, which in fact in other states could have been having a very high mortality. But OPC, which relatively in other areas, because certain areas they know that the evening anale in the case vandruvaanga, few people some will come even with the bottle, some may not, and with the smell itself, the emergency or the casualty gets alerted that okay, another case has come. So in that there was we had seen that in certain centers the referral rates were high, and probably during that transit or so the patient got worsened, and the death also is relatively high. So I request the toxicology workshop to discuss on that. And also on one area, another area which I will request is how the coordination between various departments could be ensured, and some method on it. It's more like mind to person thing, but still certain guidelines on how to, because we see increasingly that okay, that is this HOD doesn't talk to the other HOD or something like that, and what happens is that, or maybe opinion get paper vanduchina, okay, let's wait till the next shift or next unit takes in charge. So such things also I request that the team may kindly discuss during the part of day to see that all this great development in the medicine is will bring a good treatment outcome. So thanks for this opportunity, and hope you all have a great day here. Thank you.
Next, we have our respected Mission Director, Sir, Dr. A. Arun Tamburaj, IAS. Sir has conceived this idea of this one-day workshop. He was very interested on conducting this recent trends in toxicology. I request Sir to kindly give us the opening remarks.
Lydia, you're not audible. Yeah, am I audible? You speak in the mic.
Yes, sir. We can hear you, sir.
So, I'm very sorry. I actually wanted to be there today, but unfortunately, I couldn't be there because of some urgent commitments in Delhi. So, this was actually, I think, after when he took over as Commissioner Trauma, it was initially planned to have some discussions across the months. So, every month you can have some consultation on some recent advancements and take it forward. I should actually thank Dr. Reepan sir and also Gyaneshwar sir. I think both of them met me a couple of times, and they're requesting that it's a long pending due that we're not updating our people, though there are a lot of training sessions happening on ground on the recent advancements and deliberating on whatever problems you're facing and how to rectify them. There should be a platform that should be created. So one such start is the this toxicology workshop which you organized today, just targeting on two important things. One is about the rodenticide poisoning, which is very relevant to our state, and the second important thing is about the snake bites. You are seeing the number of increase in the snake bites which keep happening and the protocols which have to be followed. in order to save the lives. You also see a couple of disturbing news items for the past couple of months about snake bite deaths happening in Tamil Nadu, and a lot of uproar following that as well. So this kind of workshop is just to continuously update yourself about the advancements that keep happening, and also getting the feedback from you to see how we can improve from the NHM side. You all know that NHM is funding the Thai requirements, and most of you would be having certain requirements which may not come to our notice. So I actually wanted to be there to discuss with all the ED HODs and all the participants from general medicine and other toxicology departments to get to know your practical problems that you're facing. However, Vineet is there and Lydia is there. You can definitely pass on information. So whatever support you need will be done from our side. As you all know, rodenticide poisoning, Tamil Nadu has been a pioneer and we're doing PLEX for quite some time. And there's also, we have tried to increase the number of institutions to 19. And almost another 6 districts also are planning to increase and improve the supply of PLEX as far as rodenticide is concerned. Also, it is interdepartmental. Agriculture department plays a very major role. Awareness should not be a way by which we keep promoting suicides, telling them that rodenticide is an option. So we should be very careful when it comes to also creating awareness. At the same time, also banning such products is something which already has happened, but in field does not reflect actually. So a lot of complexities on the supply which is already existing, but at the end, when it comes to medical services that we offer after ingestion of rodenticides, already you are aware we have also saved around 64% of the deaths have been averted over the past few years because of use of PLEX. So such deliberations can happen on how to improve the management of rodenticide poisoning can be deliberated today. The second important thing is about the snake bite. In fact, we had also joint secretary from government who came a couple of weeks back to look into the prospects of producing snake venom in Tamil Nadu itself. But however, supply of ASV is not an issue. Anti-snake venom is not an issue. I meant the production of ASV is what the government of India was looking for from India, from Tamil Nadu. So, but sensitizing you on the protocols and ensuring that timely, actually in most of the cases, in fact there was a case which got press attention a couple of weeks back, in which it was told that there was the administration of ASV was not to the tune of the requirements as per protocol. It was very, very minimally, it was a couple of vials were infused and they referred the patient to a tertiary hospital. So that kind of sensitization should happen to all the spokes also about the management by you taking this message after the workshop to all the concerned secondary institutions and the spokes which the hubs will also be taking care of. So I request that all of you make the best use of this workshop, and it's very unfortunate I actually wanted to be there. I think Dr. Eban and Ganesh Roli should forgive me for not being there today. But of course, Vineet is there and Vineet is doing an extraordinary job. So I think he will take it forward and whatever requirements you have from our side, we'll definitely take it up. I also want to propose that we should go for TIE 2.0. We already have the 6 pillars which are very well established pillars of TIE. The management of each and every aspect of TIE should be given focus. So I also look forward to your insights, the ED HOD's insights on this. You can definitely message myself and Vineet as to what requirements you have, how we can organize the future CMEs or workshops in the field of TIE to keep updating ourselves, your teammates as well as the PGs and the other associated stakeholders, so that it can happen at the regional level or the state level. I also look forward to inputs, and I wish to keep, as NHM, I really feel that our need is to keep you updated about the recent advancements. So that is why this week we are having toxicology, and a week after that we're also planning for maternal mortality and maternal child health. So we're planning for a workshop also on that, where all the CMOG centers will be called. So continuously, monthly there should be some activities happening to keep you engaged, so that you are also updated and you also take this field message to your officers and other stakeholders and ensure that we achieve the objective of TIE is realized. So I once again thank Vineet for giving us this opportunity to be a part of you today from Delhi, and also thank Lydia for organizing so effectively. So I have my heartfelt appreciation for Lydia, because single-handedly she pulled off a great show, and I also wish that all of you actively participate and do your best in today's deliberations. Thank you all.
Thank you, sir. Today the sessions will be live streamed also.
So we have the live streaming link. We'll be sharing it with you all so that the junior doctors in the field can also view it live. Also, as per instructions of our project director, we are recording the sessions so that it will be put up for further dissemination. So with this note, I think we should move on to the sessions. The first thematic session today is rodenticide poisoning. I welcome Dr. C. Eapen Sir, Head of Hepatology Department, CMC Vellore, to talk to us about what is unique about Tamil Nadu government protocols, the non-transplant treatment. Welcome you, sir.
Thank you, Lydia, and good morning, friends. I consider it a privilege to being able to join this important meeting today and to address you on this particular topic assigned to me. Before starting, let me acknowledge my thanks to Dr. Arun, Mission Director at Thai NHM, and Dr. Vineet, Commissioner of Thai NHM, for making this workshop happen, and also especially Dr. Narayanasamy, Vice Chancellor of Tamil Nadu, Dr. MGI University, for his constant engagement and support on this important topic, and Lydia and a variety of other important experts who are here in the field. Now, literally, all of us are engaged in looking after patients who consume rodenticide poison, which is a huge problem in this part of the world. And the question is, how many lives saved does it make an important topic? When you think it through, the answer is one. If one life is saved, it's a huge thing. So if you save 50 lives, it's phenomenal. 100 lives. So all of us are engaged. All of you are engaged in that, primarily in the government sector. I appreciate this. At the same time, I'm underlining the importance of this topic. Now, it is true that the survival of patients who consume rodenticide and develop liver failure from a very severe death rate is improving a lot in Tamil Nadu. That's a sense that we're getting on the ground. Is that true, or is it just one sense? Okay, so some data will now come out today, and you can look at that and think for yourself, where have we reached? Second, this is not a problem only in Tamil Nadu. This is a problem also in other states in South India, as well as we know it is there in Maharashtra as well. Some of the states have started implementing PLEX. Many have not. None have done at the scale of what Tamil Nadu does. So I hope and wish that this could be extended in other states where a similar problem exists, and all of you who are leaders in your own field, in your own sections, should take the initiative in spreading the message. Lastly, the lack of access to urgent liver transplantation for the number of patients that we see forced us to look for non-transplant options. So by doing that, that has informed the field in the whole world. In the whole world, this example is informing the field of how treatments can happen without liver transplantation. And then maybe even in the Western world, they may start following this model once the logic comes through. With that introduction, maybe I'll start my talk. So I'll cover in the next 7 minutes what is unique about the Tamil Nadu protocol. Now, first I would like to just say as to, in this journey, how did we get to where we are now, and then what is unique about the protocol. So next slide, please. Okay, in an important study done by the Tamil Nadu chapter of the Indian Society of Gastroenterology, the TNISG, in the year 2019, over a 6-month time period of 244 patients who developed acute liver failure in 6 districts of Tamil Nadu. There are 38 districts now. In 6 districts of Tamil Nadu, only 1 patient, that is 0.4%, could undergo liver transplantation. So it is true that access to urgent liver transplantation is a big problem in Tamil Nadu. Urgent means I need a transplant in the next 2 days. It's different saying I can have a transplant over the next 2 months. So now the person with acute liver failure does not live beyond one week. So it all has to happen within, so that is the challenge. And that is a problem that we face. Next slide, please. Now it's estimated that 50 to 75 urgent liver transplants for acute liver failure happen in India per year. So this is, when you look at it, it's like this aeroplane landing in Mumbai airport, and Asia's largest slum is on the side wall of the airport. The slum dwellers every 2 minutes looking at the aeroplane going in the sky. But in the whole life, he may not get on the plane. So it is just like that, really. The acute liver failure and access to urgent liver transplantation is like this. Access is the problem. Next slide, please. Now, this randomized control trial from 3 European countries established that there is a 10% increase in survival of patients who did not undergo liver transplantation after having high volume plasma exchange, where the predominant cause of acute liver failure was paracetamol overdose. Next slide. So this led to the Tamil Nadu ISG, the TNISG, to bring out guidelines to say what are the indications and contraindications for plasma exchange to treat rodenticide-induced liver damage. And these were brought out as guidelines in 2022. Next slide, please. Within about 3 months, the Tamil Nadu government, the Thai NHM, mostly based on these guidelines, brought out the Tamil Nadu government guidelines, which the handbooks are available here. I can see that, the updated handbook. And so that is something amazing. Tamil Nadu only has got that set up for so much of a public health impact and to rapidly implement that. Next slide. So in 2009, one of the articles on treatment of acute liver failure gave 2 treatments. One was standard medical care, and second is liver transplantation, urgent transplant. As I said, urgent transplantation within the next 2 days. But in the last year, a Lancet review article says now there are 3 treatments: standard medical treatment, urgent liver transplantation, plasma exchange. Next slide. So with that background, what is unique about the Tamil Nadu government protocol? Next slide, please. So this is a picture of George Washington, the first president of America. Now in the year 1799, at the age of 67, after retiring from his president's post, he developed one fever and sore throat and some difficulty in swallowing. 200 years later, this article in the New England Journal thinks that he died of acute bacterial epiglottitis. This is an era when there was not yet a word called infection, inflammation. These are all not yet described. They say germs. These are like that. There's no antibiotic. So one of the doctors felt that we should let out bloodletting. So in a period of 18 hours, 3 times he had bloodletting done to treat this problem, and he died. 40% of his blood was removed. And by the next day, the newspapers all said, you did wrong, you killed him. That remains a perception even now, and maybe it is true. So the treatment that we say is one form of blood purification. Here, they did not do that. They only let out the blood. It's a dangerous treatment in a seriously sick patient. So where did the doctors go wrong in blood cleansing treatment? In the last 200 years after Washington died, Plex is now standard of care for more than 600 diseases. I'll give an example. Neurological diseases like Guillain-Barré syndrome, TTP, HUS, in different organs. But for liver failure, it is fairly new. So we have to be sure about selecting the patients. I must say, after being in this field now for the last 10 years or so, particularly in rodenticide poisoning, many things I am unsure about, and we are learning all the time. So it is not correct to say we know it all, and we should always keep up to date on what are the newest ideas in this field. Next slide, please. So what is new? The European Association Study of the Liver, the European guideline says that for acute liver damage after paracetamol overdose, the treatment of plasma exchange comes in acute liver failure, especially if there is no transplant option. The 2 differences in the Tamil Nadu protocol I've given in blue at the bottom is one, for us, Plex, we have decided that we should do it earlier in the illness. Why not? Why should we wait till the person is unconscious? So we are doing in the face of acute liver injury. That is the first difference, the uniqueness of our protocol. This is the only such protocol in the whole world right now, compared to the European guidelines. 2, we are doing it as the first option before liver transplantation. In Europe, they say if there is no transplant option, majority will get transplant, then they go to plasma exchange. We are reversing that order. Next slide, please. We also thought, what else can we do? So one of these guidelines, which now clearly we are stating, in a person who is not in encephalopathy and has consumed poison, is in liver damage, liver hepatitis or coagulation abnormality, do not sedate. This is similar to the guidelines for snake bite and neurotoxicity. A similar guideline is given by the NHM across India. Next slide, please. Now, just to give a sense of numbers, in this paper, in over a 21-year time period, in 22 countries in Europe, how many patients underwent urgent liver transplantation for paracetamol overdose? I am calculating from that article, it appears 26 patients per year. This with all the resources available in Europe, they can do it for 26 patients per year in 22 countries in Europe. So it's only a small number who can actually access urgent liver transplantation even in the Western world. Next slide, please. Now in UK is a country which is smaller than Tamil Nadu, in both in geographical size and much smaller number of population. For allocating livers for liver transplantation, the country is divided into 7 regions, and one center in the region is where the transplant is done. So if there is a cadaveric donation within any of the catchment area of the region, they will share that liver within the region. But if somebody needs an urgent liver transplantation, they will allocate across the UK, the next liver will come to your center. That's how they work. Next slide, please. In Tamil Nadu, what we've done instead, and that is the protocol which we are being followed now, the aim is within each district to triage the patient who needs plasma exchange. So that as you can compare, there is some similarity with the UK system, but some things are better for our scenario, and maybe that's how it works. As Dr. Vineet mentioned, as of now, I believe 18 districts have got this facility. It's not only the machine. In fact, machine is only one component. It's more about a team and a protocol, how to make it happen. Next slide, please. Now, this appears to be scalable, and as this publication in Lancet showed, that in the years 2022 to 23, 1,237 patients under the Thai NHM scheme underwent plasma exchange. But I think that's not accurate. Everybody may not necessarily be plasma, I'm not sure. Anyway, that's what that means. Everyone may not be having centrifugal plasma exchange, which is the preferred modality which you'd like to do. While in contrast, only 3 patients underwent cadaveric liver transplantation across Tamil Nadu for this indication. A few more patients would have had live donor liver transplantation. I am guessing that data is not there in public domain. I am guessing it is 5. It cannot be 1,000. Europe does 28 transplants in 22 countries per year. So this is the scenario where we are all working in. Next slide, please. Now, this is a photograph when some of our team members got together for a lunchtime, just to say the composition of a team, which I believe is what our state should aim for in each of the centers offering these. So first is, it is not a single person effort, it's a team. The team comprises of 2 sets of people. One is a clinical team, and 2 is an apheresis team. Also, the team comprises of doctors, specialist nurses, and technicians. Now, the clinical team can be, that now depends on each center. For us, it's hepatology at CMC Vellore. It can be physician, it can be a pediatrician, it can be a toxicologist, it can be a gastroenterologist, that will vary. The apheresis team, because it's a centrifugal plex machine, is a preferred modality, should be transfusion medicine. Now, over time, I hope that in Tamil Nadu, this model happens in all centers. And I'm giving an example of, we should clarify the role. The transfusion medicine doctor is not the person to interact with the patient, obtain consent, etc. That is not that person's job. The clinician has no idea about the machine. I do not know anything about the machine. In fact, I hope I can identify the machine. No, I did not know. That's not my role. So there are clearly separate roles. I hope that this happens across Tamil Nadu. Next slide. Now this is my last slide. So what are the unique features of the Tamil Nadu government protocol to treat rodenticide hepatotoxicity? One, this is the world's largest system to triage these patients for urgent plasma exchange. This is the biggest. Two, as I mentioned, in contrary to the current Western guidelines, we say treat liver damage early with Plex. Why do you want to wait till the person is more and more sick? Three, Plex is the first choice treatment. Second option, liver transplant, if accessible. It's a much more demanding question in India, but even in the West is the same, but it's ulta there right now. And lastly, the indications and contraindications for Plex to treat acute liver damage from poison ingestion is the world's first. There is, as of now, no such document. So we are in some sort of groundbreaking area, and I would encourage all of us. There is lots of research to be done. There are many data with all of you, your own centers. It's only a matter of putting our minds together and taking that forward. Thank you.
Chodi, Transfusion Medicine, Coimbatore Medical College Hospital. She also was a state nodal officer for the plasma exchange program. Thank you, ma'am.
Good morning, all. First, I thank you, the NHM and TNHSP, for giving me this opportunity to talk about this topic in front of this August gathering. Firstly, yes, I am Dr. Mangyar Kasi. I am Nodal Officer for Plex, and I am a retired professor of Blood Bank, Coimbatore Medical College. Today, I want to discuss about the hub and spoke model of the treatment we have delivered across Tamil Nadu in treating rodenticide poisoning. Next slide. Before going into hub and spoke model, just a small intro. All of you know that the main content of the rodenticide poisoning is yellow phosphorus. But the patient always mix this with alcohol, and sometimes they mix this with the anticoagulant. So it is our responsibility, who is in the tie, to inquire about whether they have taken the tube itself or along with the anticoagulant, or you have to see the tube, what's the main content, and whether they have mixed with alcohol. And we have received a case who have mixed both rodenticide poisoning and cow dung poisoning, sani powder also. So this is our duty to inquire. And everyone know it's a multi-system poison that affects liver, renal, cardiac, and pancreas. Next slide. Next slide. Yes, the challenges we face and why we have imported this hub and spoke model is the estimation of the phosphorus in the blood is very difficult, and there is no proper antidote. And as Sir has said, only limited access to the liver transplant, and the cost is very high, and the failure rate also high. And the very, very important thing in government setup is the late referral and lack of first aid. The next slide. So before going into that, the case burden of Tamil Nadu, the total cases, this is the available data now. The total cases is 650 to 750 cases per year, and the main chunk is from Viluppuram and Kadalur. And again, the challenge is late referral, lack of first aid, and the toxin is by the time absorbed. Next slide. Next slide. As This is the study from Jan to June 2019 by Tamil Nadu chapter of gastroenterologists. It is conducted over 6 districts among 450 patients. And to our dismay, the age group is 15 to 34 years. That is very important working age group for the poor people in Tamil Nadu. They are 15 to 34 years is very, very important. That is the working manpower in any low income group. The finding is 35% died or they were discharged in moribund state. But 99% could not access the urgent liver transplant. Urgent liver transplant means within 2 days they have to undergo liver transplant. So they couldn't access to liver transplant. So the South Indian gastroenterologists, they have given us the novel treatment, that is plasma exchange, to treat the liver failure so that there is no need to go for liver transplant. So the people in Mumbai, there is no need to go to aeroplane. Just we can treat the liver failure in our government hospital in the tertiary care itself. That is the plasma exchange. And how to deliver this plasma exchange across Tamil Nadu. That model is the hub and spoke model that is delivered across the Tamil Nadu state. Next. So what's a hub and spoke model? It is very simple. It is nothing but, it is like wheel arrangement. The hub is in the center. That is our tertiary care hospital. That is our medical college hospital. And there are multiple spokes. Like a wheel arrangement, there are multiple spokes. And the spokes are multiple levels. The primary health centers are the first level of the spoke. And the headquarters hospital and taluk hospitals are the second level of the spoke. And hub is our medical college hospital. In the primary health center, their role is only to give first aid. In the secondary level hospital, in taluk and headquarters hospital, they can treat the cases without organ damage. Once the organ damage is developed, they have to refer the case to medical college hospital, that is the hub, where the plasma exchange will be done. Next. So, in primary health center, that is the spoke, the treatment, but this is the first aid, whether the case is admitted in primary health center or directly in the secondary level spoke or directly to the tertiary level care. So, all the HOD of medicine, they knew there is no need for me to explain this. So, the first aid should be given in the primary health center, or the assessing of the ABC and the gastric lavage and the oral activated charcoal, all these things. It should be given as a first aid in the primary health center. And also, if the case is directly admitted in the secondary level hospital or tertiary level hospital, this is the first aid. Strictly no sedatives. Next. And few lab investigation can be done in the primary health center. We can do the complete blood count, blood sugar, LFT, RFT, electrolyte, and if possible ECG. And when to refer to secondary level hospital? We can refer the patient, the patient who has landed up in the primary health center will be referred to the secondary level hospital if there is altered blood parameters, and if there is altered LFT, RFT, anything, any altered parameter or leukopenia, any altered parameter, they should be referred to secondary level hospital. And if they want to send the patient for monitoring the complication. Then next slide. Then coming to secondary level hospital, that is spoke. Again, it's a spoke. The same, if directly comes to the secondary level hospital, you have to give the first aid, everything, no sedatives, everything. And you have to daily clinically monitor, and you have to monitor the sensory level of the patient. Then you have to do the serum calcium, and you have to do lab parameter, particularly INR, prothrombin, and you have to see if there is any increase in the liver enzymes. And all the medical managements, as I have mentioned, like NAC and other proton pump inhibitors, everything, it should be given in the secondary level hospital, in the taluk or headquarter hospital. And when to refer to tertiary level hospital? We have to refer the case from secondary level hospital to tertiary care center when the patient has signs and symptoms and laboratory evidence of organ damage and persisting symptoms even after 7 days. we have to refer the case to tertiary care hospital. So, next slide. Next slide. So, in the tertiary care hospital also, if the patient directly comes to the tertiary care hospital, you have to give all the first aid. Or if it is referred from secondary to tertiary care hospital, the patient should be admitted in ICU or toxicology or high dependence unit depending upon the patient's condition. And the flux will be given depending upon the INR and the conscious level. So, INR, the LFT and the conscious level of the patient is very, very important. So, the flux will be determined depend upon the INR, the LFT and consciousness, but it should be determined only by the physician, treating physician. It should not be decided by the transfusion medicine person. So, the role of the transfusion medicine person is to give flux when and where demand arises. So, the INR, the consciousness are very important. Next. Next. So, the treatment protocol, actually, initially, we started following the Tamil Nadu gastroenterologist treatment and the CMC Vellore model. As Shah has said, when it evolved, we started taking up the cases little bit earlier. First, as the guidelines, when we were going for training, the indication was INR should be more than 4, this and that. But when we were evolving with the cases, with the process, so we found out if we take the case very early, when the INR has started increasing and LFT has started increasing, we take the patient little bit earlier, the recovery is excellent. Then we are following the centrifugal method. That's okay. So how we were able to do this? We were given training in CMC Vellore and Department of Gastroenterology and Transfusion Medicine of CMC Vellore. They gave the training for our medicine department, emergency department and transfusion medicine department. We were given hands-on experience in the plasma exchange, and they have trained 6 sub-centers in 3 batches, and CMC Vellore has trained 25 doctors, government doctors, 13 nurses and 11 lab technicians. Next slide. And in the journey, we were selected as Apex Training Center for giving training, flux training to our government hospitals. So, our Coimbatore Medical College Blood Center and General Medicine Department, along with multiple departments, anesthesia, nephrology, all the departments and gastroenterology put together, we gave training during the period of May 2023 to Jan 2024. We trained 169 doctors, 169 nurses, 76 technicians, and totally PSC and hospital is 131. So, now we have trained the people and few centers have started doing flux in the medical college. Next. So, how we have delivered the hub and spoke model across our Tamil Nadu state. So, what's our success story? We have done across Tamil Nadu, flux was done for 1,400 patients and death averted was 64.2% and only 3 patients access to liver transplant. In Coimbatore Medical College alone, we have done plasma exchange for 344 patients and we have discharged 256 patients. Next. So, here I want to say it's a teamwork. Transfusion medicine department, or toxicology unit, gastroenterology department, nephrology department, anesthesia, all the department, we have to work together along with our Tamil Nadu government and NHM Tamil Nadu and experts of hub and spoke. We together worked and brought up this success in Tamil Nadu. Next. And actually the future plan to expand to actually 6 more districts. Actually it is now, by the time I have come here, they have given the Air Force mission to 3 more districts and the training is over in Coimbatore Medical College now for another second set of people. The flux training and the hub and spoke training, it is finished by the time I am here. So these three has been finished already. It is not future plan, the plan is over. Next. Next. So the conclusion is the plasma exchange is cost effective. Next, it is easily accessible. It is easily accessible for the poor patients. And the time delay is avoided, mortality is reduced, and it is an effective treatment. This is Flux. Next. Hub and spoke. Hub and spoke model is a very effective plan for plasma to deliver plasma exchange in the treatment of rat owl poisoning and involving the primary and secondary care center. That is, primary and secondary care center should do the basic stabilization and referral work, and tertiary care center should do hub and spoke model. So plasma exchange is a easily accessible, cost-effective treatment, and that should be delivered through hub and spoke model involving primary and secondary care center, and the specialized procedure like plasma exchange should be done in the medical college. So we have done it effectively, successfully, and we have saved many lives in Coimbatore Medical College, and we are also giving training to all the people. So I wish all of the persons who have come here to carry this message along with you, initiate plasma exchange in your medical college hospital, and spread the message. Thank you.
Thank you, ma'am, for that elaborate presentation on hub and spoke model. I now request Dr. Vijay Alexander from CMC Vellore to make his presentation.
Good morning to all. I'm grateful to the TAI NHM and the organizers for this opportunity. Over the next few minutes, I would like to briefly take you on how to predict response to therapy in patients with rodenticidal hepatotoxicity. Now, this includes patients who are undergoing standard medical therapy as well as patients who are undergoing plasma exchange. Next slide, please. So, we have already been through this. It's a highly toxic compound. Elemental phosphorus is the most common constituent. Occasionally, in fact, rarely we come across aluminum phosphide, zinc phosphide, and anticoagulant-based rodenticides. Ratol is the most common brand that we may end up seeing in and around Tamil Nadu. The next slide, please. By this, I just mean to say that it's quite unregulated and quite easily available. We can go on Amazon and buy a pack of 10, and it's quite cheap. Next slide. So toxicity in liver is delayed by 4 to 5 days most often. Occasionally we have earlier presentations or slightly later presentations as well. Now I have given a few definitions, and I think these definitions would come in handy as we listen to the rest of this talk and the subsequent talks as well. So by uncomplicated hepatitis, so this is in increasing severity of how the patient presents with regards to liver. By uncomplicated hepatitis, I mean that the patient presents with mild LFT derangement, maybe a slightly high bilirubin or slight elevation of SGOT, SGPT, but otherwise the patient is well and there is no other organ involvement. Severe acute liver injury is where there is liver function abnormality as well as coagulopathy. So our INR starts going up. By definition, more than 1.5. Acute liver failure is when severe acute liver injury is along with that, we have onset of hepatic encephalopathy as well. Occasionally, we have extrahepatic manifestations as well, and cardiotoxicity is rare but deadly combination to have along with liver involvement. Next slide, please. So, what is the real problem here? So, when patients develop acute liver failure due to any etiology, and they satisfy the criteria which says they need a liver transplantation is the norm, and that is the standard of care worldwide. Now, the TNISG study highlights the need for non-transplant options for managing liver failure in Tamil Nadu. Dr. Eapen has already mentioned there are roughly about 1,000 liver transplants that happen in India, and most of these are LDLT or live donor liver transplants. Under 10%, So it's around 7.5% of these are for acute liver failure, while more than 90% is for decompensated cirrhosis and chronic conditions, HCC and such. So out of 1,000, we have about 50 or 75 livers going for acute liver failure, and we see that there is a gross mismatch between the demand and the need. Next slide, please. So clearly, there is a need for non-transplant treatment options, especially in resource-constrained settings, not just as a bridge to transplant, but we need standalone therapies which can improve survival in these patients. And this is where plasma exchange comes. Next slide. So this is a seminal study from Amrita Kochi, where rodenticidal hepatotoxicity patients who met listing criteria for urgent liver transplantation were looked at. I'll come to the listing criteria in the next slide, but I just want you to focus on the third column, which is the treatment column, where we see that 8 patients had standard medical care, and none of them survived. So there was 100% mortality in that group. 14 patients required liver transplantation. Of whom 12 were alive at discharge. Next slide. So what is this listing criteria that the study used? So this is MELD score. MELD is model for end-stage liver disease. Score more than or equal to 36. And so that's a very high MELD score we are talking about, and we are talking about significant liver damage. Or if the baseline INR is more than 6 and there is onset of hepatic encephalopathy. Now, I just want you to remember that this particular criteria predicts outcome with standard medical therapy. This does not include patients who are undergoing plasma exchange. Next slide. So acute liver failure is a high short-term mortality illness. Overall, untreated can have poor prognosis. Now, early recognition of the syndrome and who develops significant toxicity is the most important thing in offering timely therapy and is key to obtaining favorable outcomes in these patients. Many prognostic models have been devised to describe the prognosis in these settings. Now, most of these are for selecting patients for liver transplantation, urgent liver transplantation in ALF. The most widely used criteria is King's College criteria. Next slide. So, King's College criteria was first published in 1989. So, it's quite old and it stood the test of time. And it is used to determine indicators of prognosis in patients with ALF. And it helps prioritize the need for liver transplantation in these patients with acute liver failure. It's further divided into patients who have ALF due to paracetamol and due to non-paracetamol. We will not go into details of the criteria per se. Next slide. Now, we have many more models for predicting survival in ALF. So, on the left column, we have static models, by which I mean it is a one time point assessment. And then we have dynamic models where we are assessing the patient, both clinically and laboratory parameters, at more than one time point. Serially, they are monitored. So, on the static group, we have King's College criteria, Clichy criteria, model for end-stage liver disease again, and Kochi criteria, which we just spoke about. Kochi criteria here is etiology specific and refers to rodenticidal hepatotoxicity alone. Alpha score, in fact, it's from AIMS Delhi, and it's a dynamic assessment of parameters at admission and day 3, and different parameters are looked at. Here, I just want to highlight that dynamic models are definitely superior to static models for predicting survival in ALF, because we are not looking at one time point, we are looking at more than one time point, and we have a trend of how things are progressing. Next slide, please. Now, before we go on to predicting survival, it's important to see and select who is the ideal patient for initiating PLEX. And this is where the concept of PLEX eligibility, or who is PLEX eligible, comes in. So, on the left-hand side, we have indications for initiating PLEX, and I am referring to the TAI, NHM, and the TNISD guidelines. On indications, we have if your INR is more than 4, if there is worsening, even if it is not more than 4, but on day 1 it is 1, and day 2 it is 3, or we have a serial worsening on monitoring. And third is onset of hepatic encephalopathy. Now, contraindications we can look at as relative contraindications and absolute no-no for PLEX. So, relative contraindications would be if there is active untreated sepsis, hemodynamic instability, by which I mean inotropic support or vasopressor support, and if they have had a recent bleed. An absolute contraindication as for transplant and any treatment option would be if there is irreversible brain damage, which can be indicated by anisocoria, decerebrate posturing. So we are entering a territory of futility of care. So then offering Plex may not be a good choice here. Next slide, please. Now, how do we predict survival with Plex? So this is the key point of my talk. So here we analyze patients of all age groups admitted with rodenticidal hepatotoxicity and Velo over a 10-year period, and we had about 200 patients, of whom 114 were treated with plasma exchange. We aim to assess predictors of survival in patients treated with Plex who were Plex eligible. So by Plex eligible, I mean patients who had indications and who did not have contraindications, and then fulfill the Kochi criteria, which we just referred to. Next slide, please. So I just want to draw your attention to, so overall we had about 32 patients who fulfilled this very selective selection criteria, both fulfilling the listing criteria as well as had indication and had no contraindication. So 22 were alive and 10 were dead. In that, two parameters stood out. One was presence of hepatic encephalopathy, stood out as a significant factor on univariate analysis, and delta meld. By delta meld, so that's the second red box. By delta meld, I mean between the first Plex and the third Plex, what was the percentage reduction in the MELD score, or the model for end-stage liver disease score. In patients who were alive, it was 44% reduction, whereas in people who did not survive, it was about 7% reduction. So there was a significant difference. And from that, we got an adjusted odds ratio of 0.88, and this was statistically significant. Next slide, please. So from this, we plotted an ROC curve, and we found that decline in MELD by more than 20% while undergoing Plex had 90% sensitivity, 90% specificity in predicting 1 month survival. This had an adjusted odds ratio of 0.88, and the area under the curve was 0.93, which means it's very good. Next slide. I am just coming back to this slide again just to reiterate the point of who is Plex eligible and who would be an optimal candidate for offering plasma exchange to. Next slide. Next slide, please. Okay. So, rodenticidal hepatotoxicity patients with ALI, that is acute liver injury or acute liver failure, who are not on inotropic support may be optimal candidates for plasma exchange. Now, going back to predicting survival, patients predicted not to respond to Plex. That is, you don't have the 20% decline between day 1 and day 3. They may go on to need urgent liver transplantation. Clearly, they are a non-responder group. So recognizing an earlier stage of the illness, like ma'am just referred to, may improve outcomes in these patients. Next slide. Now, why is hemodynamic instability such a concern in these patients? So the concern raised is that they are already on vasopressor support, they are already hemodynamically compromised, and we are going to remove fluid and plasma from these patients, which can then further compromise their hemodynamic status. It can go on to cause worsening shock, it may cause renal dysfunction, so end organ damage like renal dysfunction, we do not know. That is one main concern here. Once the patient has gone on to develop multi-organ dysfunction, inotropic support, we know that they have poorer outcomes. So then the question is, are we already outside the window of benefit, and are we too late in the game? Next slide. So in conclusion, from the data set that we have looked at, we now have a dynamic predictor of survival on Plex, that is a delta decline between day 1 and day 3. If the MELD score reduces by more than 20%, we know that they are very, very likely to survive and will not need transplant. This helps early identification of responders and non-responders, and also it's important to identify this optimal window for Plex so that we can improve our outcomes as well as optimize the manpower and the utilization of things that we use for plasma exchange. Thank you so much.
Thank you, Dr. Vijay. It was a wonderful presentation. I request Dr. Uday Zakaraya to step up on stage and give his presentation.
Can we have the presentation on, please? the slides. So maybe while it's coming on, my job over the next few minutes is to show you the CMC data on native liver survival in the setting of ALF due to rodenticide using low volume plasma exchange. So when we use the word native liver survival, native is our own or my own liver as opposed to a transplanted liver. So let's try to rescue our own liver versus trying to put in a new liver from somebody else. Next slide, please. Vijay has shown you this slide, and I want to highlight what Dr. Mangayakarasi said. Let's try and do it earlier. So for me, and personally, on the left, point number 2, increase in the INR is what is the key. So I've been asked, how often do you check this increase in INR? We are suggesting at least do it daily. You may do it earlier, but at least over a day period, if there is an increase in INR, it tells you that the liver is not settling down. So people have asked me, is it too early? So I say better early rather than late or never. So time will tell us that, but that's an important point, I feel. Next slide. So this is Leenath's work from pediatric hepatology from Velo. This was the initial work which showed. So we looked at all children less than 18 years of age, as you can see, and those who met the criteria of acute liver injury and acute liver failure, and further very sick who met Kochi criteria. None of these patients had access to liver transplant at that point, and if you look on the right of your screen, you can see that the 1 month survival, and here in acute liver failure, 1 month survival is equivalent to lifelong survival. So that was 75% in this small group. This was the initial work which gave us hope that this therapy may work. And this was all low volume plasma exchange using the centrifugal technique. Next slide. Vijay has shown you this. I'm highlighting it again. When expanded to include all adults, and of them 32 of these fulfilled the very sick Kochi criteria, which otherwise none of them would have survived with standard medical therapy. And here that number of survival, 1 month survival, was now close to 70%. And Vijay showed you as a predictor, an easy predictor was the bilirubin fall of more than 20%, which had a 90% sensitivity and specificity to predict survival. Next slide. With this, Dr. Kausala, who spent some time, 1 year with our unit, she's from Sri Lanka, and she, along with the rest of the team under Dr. Epan and Ashish Goel, looked at a meta-analysis looking and seeing whether plasma exchange actually improves survival in acute liver failure. And as you could see the forest plot, it was favoring Plex, and when looked at carefully, it was in a group with a single etiology. So either single etiology like rodenticide or Wilson's disease, when you looked at a single etiology with Plex, it certainly favored Plex. So this is just to show you overall that Plex, in our experience, does have improved native liver survival in ALF. Thank you. That was my last slide.
Thank you, sir. I now request Dr. Ashisha Janila to make her presentation, please.
Hi, good morning everyone, and I'm Ashisha from Hepatology CMC, and thank you for this opportunity. So I'll be presenting our data on role of plasma exchange in acute liver failure, and the etiology we are looking at is hepatitis A related ALF. Next slide, please. So as already said, that there is plasma exchange does improve survival in acute liver failure. However, there are no studies looking at its role in acute liver failure due to hepatitis A. Now, as already stated by the previous speakers, patients who are hemodynamically unstable, we may be too late in the game. So in this study, we also looked at patients who were hemodynamically stable, not on inotropes, with HIV-ALF. Next slide, please. So now this was a retrospective multi-center cohort study, including 12 centers across India. Next slide, please. So these are the centers from whom we have data from. So we have Tamil Nadu, we have centers from Kerala, we have centers from Haryana, AIIMS Delhi, and Kochi Amrita. So overall 12 centers from where we recruited data. Next slide, please. Next slide. So the aims of this study was to compare liver transplant-free survival in hepatitis A-related acute liver failure in patients treated with PLEX as compared to standard medical treatment. We also wanted to identify an optimal window to select patients for plasma exchange in this group. Next slide, please. So this is the flow of patients in our study. So overall, hepatitis A-related ALF with 234 patients. Out of these, there were 84 patients who underwent plasma exchange and 150 patients who underwent standard medical treatment. Like I said, we also looked at a hemodynamically stable group or the PLEX eligible group who were not on inotropes. So that were 158 that you see on the left side. Out of these, 54 patients underwent plasma exchange, while 104 patients were managed with standard treatment. Next slide, please. So this is the baseline characters in the 234 patients with hepatitis A-related ALF. The first column is overall, that is all the patients with HIV-ALF, and the column on the left side are patients who are hemodynamically stable, not on inotropes. So the baseline parameters were well matched between both the groups. We can see that bilirubin, enzymes, INR were all matched between the groups. Ammonia, however, was higher in the group that underwent plasma exchange. Next slide, please. Now looking at severity, we looked at various parameters like MELD, SOFA. Certain hepatitis A specific scores like alpha and ALFSG were also looked at. Here again we see the most important thing was patients who were on mechanical ventilation was different between two groups. Patients who fulfilled King's College criteria was also more in the group that underwent plasma exchange. Next slide, please. So details of plasma, the previous slide. So details of plasma exchange in the 84 patients with HIV-ALF. As already pointed out, most of them underwent centrifugal plasma exchange, low volume. So many centers also did standard volume, that is 74% and 24%. As per the Velo protocol, we give low-dose steroids for these patients. As we can see, line-related and transfusion-related complications were quite low. Next slide, please. So this is what I would like to draw your attention to. The first bar graphs are all the patients with HIV-related ALF. So survival was not different. As we can see, it was 70% versus 65.3%. However, when we look at the group on the left side, that is 96.3% survival with plasma exchange as compared to 77% with standard medical treatment with a significant p-value was noted in this study. Next slide, please. So this is just to highlight that this is the largest multi-center series on experience with plasma exchange to treat HIV-ALF. Overall survival was not different between the groups. However, the group which was hemodynamically stable, not on inotropes, showed better survival with plasma exchange, that is 96 versus 77.9%. This group may be the window where we might catch patients for plasma exchange. Thus, I conclude with the next slide. So as I said, there may be a role of plasma exchange. As per the study, improved native liver survival in HIV-ALF patients not on inotropes with plasma exchange. Thank you.
Thank you, Dr. Ashisha, for that presentation. I request Dr. Santosh Kumar to kindly come and make his presentation, please.
Good morning. I think the task given to me this morning is to discuss about the outcomes that we've analyzed from a large cohort. This included Coimbatore Medical College, led by Dr. Mangekarasi Madam, and the CMC Vellore team. So we have evaluated the performance of low volume plasma exchange both from a public and private sector hospital. Next slide, please. So I think my speakers ahead of me have already dealt in detail about the evidence that we have so far showing that low volume plasma exchange improves transplant-free survival. However, the studies that have been done and shown so far are from a single center and the numbers are small. So what we hope to do is evaluate the impact of plasma exchange treated patients with rodenticidal hepatotoxicity from two large cohort from Coimbatore and Vellore. Next slide, please. So it's a retrospective study. As mentioned earlier, it is from Coimbatore and Vellore. And we collected data from hospital records from admission to discharge. The timelines of data collection from Vellore, it was between 2017 to 2024. And from Coimbatore, it was between 2022 to 2024. And inclusion were patients with rodenticidal hepatotoxicity who underwent PLEX, and patients excluded had other treatments or incomplete records. Next slide. I think Vijay had dealt with this definitions and measurement of patient severity in detail. I'll just run it through. So uncomplicated hepatitis is a patient who's got hepatic dysfunction, that is LFT abnormality. Acute liver injury is when there is INR elevation more than 1.5 on top of that. Acute liver failure is when the same patient develops encephalopathy. And King's College non-paracetamol criteria is used to stratify who's a high-risk patient and who will require transplant. And I think Vijay also showed about the Kochi criteria where MELD is more than 36 or INR more than 6 and with hepatic encephalopathy, which is a condition with absolute fatality. Next slide. So I'm just showing a different version of the protocol that we are using. This was published in Journal of Clinical Experimental Hepatology. So we prefer to use low volume plasma exchange. We prefer to use femoral line. We prefer to use low dose steroids. We prefer to use centrifugal plasma exchange technique. And we, in our center, use prophylactic antibiotics during plasma exchange. And as mentioned earlier, we avoid sedatives and prevent unnecessary transfusions for the sake of line insertion. Next slide. I mean, this content has been shown again and again. I just want to briefly mention into the contraindications because hemodynamic instability and active sepsis are contraindications as per the Thai NHM for rodenticidal hepatotoxicity when we are considering plasma exchange. Next slide. So going on to the results, just to give an idea, there were about 360 patients from both centers. So Coimbatore had 230 and Vellore had 130. And just to highlight, these were young patients, median age was 28 years, and majority were men. Just to say that these people were not having underlying psychiatric illness or past deliberate self-harm. So these were mostly impulsive act. majority did not have any underlying psychiatric illness or past deliberate self-harm. And in this study cohort, 98% had ingested yellow phosphorus. Next slide. Next. So to assess their severity parameters before plex, as we could see, the median bilirubin was 4, which is elevated. The INR was 2.36, again elevated. The creatinine was in the normal range, and MELD, just to give an idea, normal MELD will be between 5 to 6. So here the MELD median is 22, and the interquartile range is also quite high, 13 to 31. Next slide. So while we tried to categorize them as different syndromes, majority were acute liver injury or acute liver failure, and a small fraction, less than 20%, were uncomplicated hepatitis. And 15% of them satisfied King's College criteria prior to plex, and 20% of them satisfied Kochi criteria. So this King's College and Kochi criteria meant that these patients had no possibility of survival when they were treated with plasma exchange. Next slide, please. Going through what was the type of plasma exchange and the steroid treatment given during in between these two centers. So majority, 82%, had centrifugal type of plasma exchange. Steroids were given in 71.4% of patients, and prednisolone was the preferred steroid in Vellore, and dexamethasone was the preferred steroid in Coimbatore. Median sessions were 3, so most patients received 1 to 4, but the median plasma exchange session was 3. And the volume of exchange per session was 1.6 liters. The bottom of the slide, just to highlight, to show patients who came late, that is when plex was initiated late, that is because they are already gone on to ALF. So when patients presented early, that is between a median of 4 days, they were mostly in acute liver injury or uncomplicated hepatitis. So again, to highlight that patients from the spoke have to reach the hub early rather than late. And majority of the patients after plasma exchange showed a good decline, a median decline of 22.7% in their MELD. And Vijay already had said, if the MELD declined by more than 20%, there is a great chance of survival. Next slide. So going on to the outcome, which is the focus, among the 360 patients, we had 239 patients surviving, which meant about 67.3% survival, which is a good outcome. And among various severity categories, we could see when the pre-plex syndrome was acute liver injury, close to 80% of patients survived. And in the pre-plex syndrome of acute liver failure, we had close to 50% survival. Among patients who fulfilled Kochi criteria, where we know the fatality is 100%, we had 40%, nearly 40% survival. And in King's College criteria satisfying patients, we had close to 31% survival. Next slide. Next. So going back to the Thai contraindications, we noted among patients who had Thai contraindications, the outcome was poor compared to patients who did not have Thai contraindications. So the bottom two, we have tried to exclude patients who had Thai contraindications, and then we saw the Kochi criteria fulfilling patients from 40%, their survival improved to 50%, and the King's College criteria satisfying patients from 30%, their survival improved to 42%. So if you choose the right patient, that is a patient without hypotension or active sepsis, then the survival in these particular subgroup is very good. Next slide. So this is a Sankey diagram just to show the patient flow. As we could see, while the patient was admitted, they could be uncomplicated hepatitis, but as their course in the hospital, some became from uncomplicated hepatitis to acute liver injury. Similarly, some acute liver injury progressed to acute liver failure. What we found is the worst syndrome, if it was uncomplicated hepatitis, obviously majority do not die. In acute liver injury also, we had a significant amount of patients going on to survive. And in acute liver failure, close to 50% of patients survived. What was interesting to notice, when the acute liver injury did not progress on plasma exchange, we had 93% survival. So we need to catch them early and do plex so that we have a good survival. Whereas when the patient progressed to acute liver failure, the survival was not different from another acute liver failure, which eventually was about 42%. Next slide. So I'd like to conclude with the last two slides. So patients coming late who had acute liver failure on presentation had relatively poor outcome. Therefore, it is important to catch patient early. And majority of the patients did not have any underlying psychiatric or comorbid illnesses. So these are patients who, if we get them back on track, they could potentially go back to a normal life. Next slide. And we did salvage a significant proportion of patients from both centers with plasma exchange, and patients who had satisfied Kochi and King's College criteria, which are all almost death sentence otherwise. And patients who had Thai contraindications at the outset did perform poorly compared to a patient who did not have. And we were able to salvage a significant proportion of acute liver failure, which is a very fatal condition, which is a success story of low volume plasma exchange. And when acute liver injury did not progress with plasma exchange, these patients did very well with plasma exchange. Next slide. Thank you. Thank you.
Thank you, Dr. Santosh, for your presentation. Now we will be breaking for tea for 10 minutes, and by 11:30 we'll have to come for the next session. The next session will be on sharing of experience on plasma exchange for rodenticide poisoning by government medical college hospitals. Thank you.
இந்த சைடு பாரு. இப்போ இதுல வரலடா.
Welcome back. Shall we start the session? Okay. So now I invite Dr. David Pradeep, HOD General Medicine, sir. Balamurugan. Okay. Dr. Balamurugan, General Medicine HOD from Madurai Government Rajaji Hospital, to deliver sharing the experience on Plex for rodenticide poisoning. We welcome you, sir. The stage is yours.
Pleasant morning to all. Here it's a great privilege to share the experience regarding the therapeutic plasma exchange at Madurai Medical College and Government Rajaji Hospital. And I am presenting this on behalf of my head of the department, David Pradeep sir, who could not come today. So this is a summary slide. So it's the therapeutic plasma exchange started from November 22, from the first day of it started in our college also. Initially the emergency medicine was in charge. From March 2023 till date, Department of Medicine is in charge, and it's coordinating with transfusion medicine, nephrology, medical gastroenterology, all coordinate for the smooth implement procedure. And next slide, please. Yes. So the agenda for today, just I will be sharing the experience based on the statistics provided from Department of Transfusion Medicine, General Medicine, and finally few lessons learned and take-home messages. Next slide, please. So this is the statistics from January 2023 to till April 2025. Next slide, please. See here you can see the month-wise patients who underwent the therapeutic plasma exchange. Totally in 2023, 97 patients were subjected to Plex. And the survival rate in the year 2023 was 40% survive, and this is the total cycles and how many patients recovered. You can see the patients who recovered were less than the people who died. This is in 2023. Next slide. In 2024, the number of patients who required therapeutic plasma exchange came down. That is only 62 patients, but you can see the recovery rate was better in 2024, and the mean Plex cycle per patient was 2.87, and survival rate increased to 53.22. Coming to 2025, next slide. Yes. Here you can see only 10 patients have been admitted for Plex in this year, and you can see the survival rate is very much better. It is 70%, and there were no Plex was done in February. So this is a very rare event in Madurai Medical College, and you can see that the survival rate is increased and Plex per cycle is the same. Next slide. So I have summarized the data. You can see that 2023, the average number of patients per month who underwent this therapeutic plasma exchange is 5.1. It came down to 2024, 3.1, and you can see this year it's only 2.5, and you can see the survival rate is slowly but steadily increasing. So this is a comparison. Next slide, please. So this you can see from 23 to 25, This is from the transfusion medicine data. You can see the total people who underwent PLEX was 169. Patient recovered was 79. Death was 76. And the survival rate is now 46.74. And you can see here in Madurai, apart from low volume PLEX, there was a conscious decision to also use standard volume PLEX in some of the patients. So I will tell about that later. So this is the summary slide for transfusion medicine. Next slide. So this is the data from general medicine. Next slide. So here you can see the total number of patients just from February 24 to March in 1 year. 263 patients of rat killer paste poison were admitted. This is the number of poisoning patients were admitted, male 162 and female 101. Next slide. And you can see the patients who are shifted, that is, who develop some symptoms which may warrant him to go into. So 115 patients out of 260 were shifted to toxicology ward, and out of that 59 patients didn't have any indication, where PLEX was indicated in 56 patients. Next slide. And you can see, as already pointed out, the most common age who have consumed more poison or who come late is in between 20 to 29 years. So if we just take less than 39 years, they contribute to about 80% of patients who are needing the PLEX or who will have the severe disease. Next slide. And this is the PLEX indicated cases, male, female. You can see in very younger age, females dominate. So when it is less than 20 years, most of the patients who come with severe disease is females, but after that, it is equal sex distribution. Next slide. And here you can see, among these 56 patients, only for 40 patients PLEX was initiated, and most of the patients were in 20 to 29 years. Next slide. And here sex distribution. Again, you can see the number of females or more when the age comes less than 20. Apart from that, you can see relatively equal male, female. So this is 40 people were subjected to PLEX in the last 15 months. Next slide. And here you can see the outcome. So the outcome in the 50%, it was 50% people recovered and 50% died. And you can see the most deaths also occurred. 16 deaths among the 20 deaths occurred in that age group of less than 29 years. Next slide. So this is the summary. So among 263 patients from January 24 to till date, there were 263 patients who were admitted with rodenticide poisoning. 36 people died. Among the 36, 20 were the people who underwent PLEX. So if you consider the whole mortality, it is 15%. 15% of rodenticide poisoning, whether subjected to PLEX or not, they die. Next slide. So this is what I want to highlight. So 124 patients among 263 patients were referred from these districts. And these districts don't have PLEX in their medical colleges. And you can see 35 patients were referred from Sivagangai. And the Sivagangai Medical College or in Dindigul Medical College, there is no the facility for PLEX. Even within Madurai, 42 cases. So these are the number of cases which we get from other districts. Next slide. And you can see when they come within Madurai, direct admission at Madurai, the mean time is only 2 hours. But when they come referred from other GH, it takes up to 3 days. So many times when he comes, he is in acute liver failure, or he will come in encephalopathy, or he has been discharged, went home, then again brought. Because it is delayed, that was not properly sensitized, or they thought he is normal, but he comes with a great delay. So this tells that we need to have PLEX in all districts. Next slide. So what we did in Madurai is, from 1 March 2023, the NHM protocol or the Indian Society of Gas was followed, but the outcomes were not satisfactory. So in 12/6/23, an internal meeting with general medicine nephrology was, and they slightly tweaked the protocol. So next slide. So we made the, next slide please. So even the rising enzymes, we didn't wait for INR go to 4. So even rising enzymes individualized based on the quantity taken. So even rising enzymes, even before INR was 4 was considered, and even some of the patients, based on the various studies available that time, standard volume plex also was used. And based on that, we found that outcomes were better. Next slide. And these were the thing which was formed in 2023 March. So a dedicated team consisting of postgraduates and assistant professors. So the team initiated plex within 1 hour of admission, and the indication is present. Within 1 hour it will be started. All MD postgraduates were trained in central venous catheterization to ensure timely vascular access, and the emphasis was on early initiation and intensified plex, I will say what it is, and also there was a monitoring of lactate, pH and INR, and the initiation of CRT, especially in patient with hyperammonemia and hyperlactatemia, was very much well received, and many patients after CRRT, then they came to plex and many of them survived. Next slide. And these are some of the take-home messages. It is still common. It is available in many stores. It is, as already pointed out, in Amazon, even today it's available. And many places it seems to be very toxic to rat also. So people want it. So it is still very much available. They are hoarding it. The incidence is falling, there is no doubt. But regarding the plasma exchange, after the availability of plasma exchange, the mortality has considerably fallen to the extent of up to 70% of the patients who already pointed out in various criteria survive. Next slide. And with individualization of the treatment and sharing of the new knowledge, mortality is better, especially patients with encephalopathy where the plex was prolonged duration. We have 3 instances where patients were given plex for prolonged periods. So where the renal function was normal but patient was in encephalopathy, they fared well after the prolonged plex. And according to our institution, hypotension has the worst prognosis. And when they have hypotension and renal function, the SLED and the CRTT was used after the expert opinion from the nephrology. And when we use that appropriately, even that hypotension could be managed better. So the take-home message is the transfusion medicine, anesthesiology, medical guys, if they work as a team, there is a winning. There is always a win, and nearly 70% mortality reduction with this plex is very considerable. As pointed out by the first speaker, even 1 death is a bigger thing. Thank you. Thank you for the opportunity. We have, and I also request that if any other further studies, we can include Madurai Medical College also. We have a lot of cases and we are also willing to be part of it. Thank you so much.
Thank you, sir. Thank you for sharing your valuable experience on using this therapy for managing the rodenticide poisoning. Your insights will undoubtedly benefit our community healthcare professionals to enhance the patient care in future. And now I welcome our next speaker to share the experience. Sir, we'll have a discussion at the end, sir. So the session is not completed. Yes, sir. We have time for that. Thank you. So now I welcome our next speaker, Dr. Mangaya Karasi, Plex Nodal Officer, retired from Coimbatore Medical College Hospital, to deliver a sharing experience on Plex for rodenticide poisoning.
Good morning, all. I am here to share our experience. with respect to transfusion medicine department. I am sharing how my experience in initiating the program and in maintaining the program and what are the difficulties we have faced. So I am not going into the treatment part. So it's not my job. I am talking about the experience we faced as a blood bank person. Oh. இங்கே தான் போல So our experience started with our training in CMC Vellore in 2022. And our CMCH Coimbatore Hospital, blood bank persons, medicine department, and emergency department medical officers, nurses, and lab technician, we went for training in CMC Vellore. And we were given training by hepatology department and transfusion medicine department. And there we were given about hub and spoke model of treatment and also about hands-on experience on plugs. And hub and spoke model was well explained to us in CMC Vellore. And we were well explained about the primary care, secondary care, tertiary care, and the plugs training was given to us. And next. This is our experience in CMCH Coimbatore. After getting training, we started plugs in January 2022. So, first, it's only 94 cases. Totally, the statistics has increased and the cases taken for plugs has also increased, and it is a number of cycles and it is the percentage of the person who were discharged. This is our census in Coimbatore Medical College Hospital, our blood bank census. And here I want to mention about 3 important cases where we met with success. As Saktivel, 30 years old, he consumed 2 tubes. His INR is 5.73. He was with hepatic encephalopathy and coagulopathy and 3 cycles of Pluxidine. And he survived and he was discharged on 25/9/23. Second case, he consumed 3 tubes and his INR is 6.6 and the bilirubin is 8.2. He was also with hepatic encephalopathy and coagulopathy. He was intubated and 3 cycles of Plux done and he was discharged. This is case 3, 23 years old. She consumed 4 tubes, 4 full tubes. And bilirubin is 6.3 and INR is 5.3, 4 cycles of Plux done and she was discharged. Why I am mentioning these 3 cases? Because with increasing, this is a starting INR value. So with increasing INR value and increasing liver enzymes, so without Plux, only we have to go for urgent liver transplant. But with 4 cycles of Plux, the patient has survived and we discharged. So along with the training given in the CMC Vellore and with our experience, we have been selected as Apex Training Center. Already I have mentioned in the warning. And here we are giving training to all the people belong to entire state and general medicine, anesthesia, nephrology, gastroenterology and our blood center. All the faculties were involved and a dedicated meticulous training was given to the people. And the training period was between May 2023 to Jan 2024. And now again the second session of training was also over. because I retired, but now the second session of training was also over. The general medicine department will talk about the primary and secondary level of treatment, and they will talk about the hub and spoke model of delivering the treatment. And anesthesia department, they gave training about the vascular access, how to keep the vascular access sterile, like that. They were giving that training. And nephrology person, he was kind enough, Dr. Arul, who was transferred from Madurai. He will compare the centrifugal flux and the membranous fluxus, and he used to say that centrifugal fluxus is superior than the membranous fluxus with respect to ratol poisoning and plasma exchange. And gastroenterology, they also gave the training, and we gave training in plasma exchange for all the technicians, staff nurses and the medical officers who attended the training. And we have trained 169 doctors, 169 nurses and 76 technicians, and altogether PSC and Taluk Hospital 131. And our awarded accolades were, we were given a state award, our dean received a state award for, from the Tamil Nadu chapter of gastroenterologists, and there was a, I think Morning Ipansa has there is a publication in Lancet, and our Honorable Health Minister, he has inaugurated the training, and a state level handbook on poisoning is released. Please everyone get that handbook. It is very, very useful. Everything is given in that handbook. Our dean is receiving the award in 2023, and in 2025 again our Tamil Nadu chapter of gastroenterologists, they awarded for saving the young lives. Now this is very important thing. These are all our experience. Now what are the challenges we have faced? I want to discuss in depth. First, because we are the one first initiated this plasma exchange for ratol poisoning. Already we had one centrifugal apheresis machine in Coimbatore. We received it in 2016 for other medical conditions like Guillain-Barré syndrome, myasthenia gravis, etc. So we used that machine for plasma exchange for ratol poisoning. So we have started very earlier, and our technician also well trained in plasma exchange already. So we have started doing the plasma exchange very earlier. But the program initiation was very difficult because plasma exchange for ratol poisoning is a novel treatment, and there is a programmed treatment. So to sensitize the clinicians to use plugs for ratol poisoning was initially difficult. So the program initiation was little bit difficult. Why I am telling this? Because there will be people who have come from other districts who are going to receive the equipment also. So please get sensitized with the program, the plugs and the rodenticide poisoning, and the program initiated by the NHM and Tamil Nadu government, and also about the hub and spoke model of the treatment. So program initiation was initially very difficult because sensitization was not there. Now it is very easy. So sensitization is necessary. Then it's not top problems. Top-down approach is necessary. First, our administrators should be sensitized. That is our government and NHM. They should sensitize our head of the institute, our dean. So in CMCH Coimbatore, once our dean got sensitized, and I think I have to thank gastroenterology Tamil Nadu chapter, because after the state level award from in Trichy in 2023, Madam got sensitized, and until now she is giving a full support for the plugs for rodenticide poisoning. So first, head of the institute, the dean should be sensitized about this program in all the medical colleges, because it's a novel treatment. You have to initiate that program once you have received the equipment. So once our dean got sensitized, unwavering support she gave us. So top-down approach is needed. Then second, equipment. First we started the program with our old equipment, then we received the new equipment. What I want to tell NHM is the CAMC and the repair and the fund needed, what to do, because if there is a small repair, we have to shell out up to 2 lakhs for a very small repair. So it's very difficult for a government hospital and the head of the institute to spend money for the repair. So what I want to convey, the equipment CAMC should be borne by the distributor for some time. Something should be done for that, because it is very, very difficult. So Lydia, please note it, but for equipment CAMC, it should be done, something should be done on our side, because it is very difficult. Even a very small problem, you have to shell out 1 or 2 lakhs. So regarding CAMC, repair and the fund, that should be clarified, because now the old equipment still it is under repair, we are not able to do the repair. Then third, consumables. The consumables, you need a plug kit, you need the W1 catheter, and initially the problem what we faced, but everything is settled now. We will fix the Plex program. For the W1 catheter, our PG, medicine PG, he has to go to nephrology department. He has to wait for a day or half a day to get that W1 catheter for plasma exchange. But our toxicology chief and our HOD medicine, they have discussed, and now they are purchasing in, I think by medicine department, and they are keeping it in toxicology ward. These are all the practical problems we have faced. I think it will be everywhere in the government institute. Who to purchase the Plex kit, who to purchase this W1 catheter, so what availability of it, supply of it. So these are all the ground level problem. So we were purchasing the Plex kit, and toxicology department is purchasing the W1 catheter. What I feel, some single ownership, a single owner should purchase the Plex kit, W1 kit, and they have to keep it continuous supply and uninterrupted supply. This should be made. And manpower. Manpower. So what we have planned, the transfusion medicine department has to do plasma exchange. But all government hospital, they have only 2 TANSACS employed technicians. We don't have any permanent technician only, we have 2 technicians. So because it's a high-end procedure, the technician should be trained well, and constantly we have to send the data to NHM and to whenever it is needed. So definitely a data entry operator is needed. All the problem I will put in front of you, whatever it is possible for you, you please do. So data entry operator is needed, and it's a high-end procedure. A lab technician should be well trained. I will share my experience, how I tackled this problem. We had 2 technicians. They were well trained in plasma exchange. They started doing this, but suddenly what they started telling, ma'am, we have a regular routine work. We have screening work, we have to do grouping, cross-matching. Apart from that, how we can able to do this? So they started a problem. Then I approached the distributor, and he employed the lab technician, and he is paying some money, and now I have a dedicated lab technician for plasma exchange, but he is sponsored by distributor. So I heard that few centers he was doing, so we demanded, I don't know whether it is correct or wrong, and we are doing that, because regular lab technician in the blood bank, I think everybody will be agreeing, only 2 persons are there. It is very difficult for them, because they will have up to 4 o'clock they will work, and again they have to. So I tackled that problem like that, lab technician problem. And training the lab technician, even though we are training, but the hands-on experience, loading the kit, unloading the kit, the troubleshooting of the equipment, he should learn it. So what I did, I asked the company technical expert to come and train our technician. So once you get trained in the Apex Training Center, then you, the transfusion medicine person, get the responsibility to call the technical expert of the company, whichever equipment is supplied to you, ask them to train your lab technician for loading, unloading, troubleshooting of the equipment. So that's how I tackle that problem. And the procedural problems to the patients and to the equipment, air locking, so many problems are there. Everything your technician should know and we should also know. And ownership of the program. These are all the problem I faced and I corrected. Our team, it's not I, our team corrected. So the ownership of the program, we should be very, very clear hereafter. The transfusion medicine person should do the plugs. But the demand should come from the person who is treating the patient. We should not meddle with the patient. They should decide. They should tell, you can do this and that. Our team, we have to go and do the plugs, that's all. So this should be clearly defined. So that thing you have to take care of. I am here discussing only the ground level practical problems. Then regulatory acts. All our transfusion medicine person will be confused about the regulatory acts. And I discussed about with the drug authorities. Actually, we should not do the therapeutic plasma exchange or plugs in blood bank. We should not do in the blood bank premises. It should be done in the toxicology or ICU or a high dependence unit. Our technician should go and do. And if you have a machine there, it's good. Otherwise, the machine which is in our thing, it should be properly transported with a lift or some smooth road. You have to do. And we should not do the plasma exchange in blood bank premises. But only transfusion medicine person should do the plugs. And the indication should come from the physician. So, and regulatory acts say that the blood bank should get the AFSS license. We should get the license. There is no need for the physician or treating person to get the license. So we have to get the license. Few suggestions to the administration. We should get uninterrupted plugs kit supply, because we faced difficulty from 2024 Feb up to this year. So we have started the program. See, you are going and starting the program, and you are sensitizing the transfusion medicine, clinician, dean, everything, and the public is also sensitized. So they will start coming. What will you say to the public when your kit is not supplied without interruption? So you should make sure that, because again I am telling, these are the problems we have faced. So there should be uninterrupted plugs kit supply. And the next thing, in the government setup, a tender will be over. Then I think Lydia will be knowing. The tender was over by last year, June. And I think the tender was, again the new tender, now I think March or something. So up to this time, the dean of the institution, she has to buy the plugs kit, but it's what I can say, it's really troubleshooting for her, because without TNMSC rate contract, how a dean can purchase, no? So there should not be any, these are all the problem we have faced. So avoiding delay after completion of the tender tenure. And there are so many equipments in our government setup. We have, I think in the market, we have spectra aptia, Fresenius, and Humanitics. 3 types of equipments we have. And a few government hospitals, they have the Humanitics. 1 or 2 hospitals, they have Fresenius, and a few hospitals have spectra aptia. So we have to, I think, you have to utilize all the equipments. Few equipments are just not utilized, and we have to form a plugs team, and we also maintain a plugs team. It should be a state level plugs team. So you have to keep plugs team state level. they have to discuss about the problem, because we were left alone, because we were the pioneer in starting in government, and we were doing, people were sensitized, patients are pouring in, but the problems we were facing about the Plux kit supply and the repair of the equipments and the delay in the tender tenure, these are all very difficult. So what I feel, you have to form a state level Plux team to discuss all the problems so that the program is running smoothly. And the SOP should be displayed everywhere, in the ward, everywhere. And I think our HOD medicine will talk about it. This Plux for the rat poisoning should be included in CMCHIS, and it should be meticulously planned. And if it is included in CM insurance scheme, I think it will even, we can do better. And the program should be, sensitization of the program at all levels should be done. And this is the last point I want. The success for our center is, we have a coagulation lab in our blood bank, and it is sponsored by NHM hemophilia thing. So we have a rotum in our blood bank. So it was easy for us immediately before we get a report from pathology department, we can able to say PT, APTT, INR, fibrinogen. Even we have done factor 8 assay in our blood bank. So it was very easy for us. So, and the treatment is also not delayed, the component therapy, whatever it is. So it is very, I feel it is very important to establish a coagulation lab in all the transfusion medicine department. So I am asking you this. That's all. Thank you.
Thank you, ma'am, for your comprehensive overview on Plux therapy for rodenticide poisoning, which is truly informative. Now, I would like to invite the next speaker to the stage to share his valuable insights and experience on Plux for rodenticide poisoning, Dr. Raj Chandrasekhar, HOD sir from General Medicine, Stanley Medical College.
Ladies and gentlemen, good afternoon to everyone. So at the outset, I would like to thank the organizers for having me here. I think I should thank NHM for having taken a good initiative workshop on the rodenticide poisoning and snake bite. I think I must congratulate Mangai madam for bringing out a lot of the pitfalls, deficiencies and lacunae in our system, which I think the previous speaker and myself are not going to speak. It's better that like you have enlightened the deficiencies. This will help us to make the project better and can deliver a quality care to all our patients with rodenticide poisoning. I'm not here to talk about these, the pathophysiology and other things, but please remember that it's a systemic protoplasmic poison. Many times we'll be talking about the liver, but sometimes we forget the other system, cardiovascular system, the renals, kidneys, and of course the other systems as well, other than your liver, you've got GIT and other involvement. Please remember that we do see in a place in Chennai, in Stanley Medical College, that is one of the prominent referral unit for patients who have consumed rat killer poisoning. And I'll project some of the stats also, but before that, please remember that we have encountered many patients with multiple organ dysfunction. So that is also another thing which we need to remember. Of course, in our hospital, most of the patients, we had delayed presentations, and many of them, they have consumed the dosage, the toxicity, the toxic lethal dose is very much important. Many of them consumed more than 10 grams. The plasma exchange was initiated at Stanley Medical College during the month of September 13th, 2022. So this is the age group. So many of the people were between the 20 to 40 years. I'm sure I may have some overlap with the Madurai team. So please remember, these are all the very young people, between the age group 20 to 40 years. And less than 20 is 24%. So again, that can give us some idea about how much of I mean, the social stress they may have, and that end up in culminating in ending their life, making a suicidal attempt. So that's a very important thing. Like these are all the vulnerable group of patients what we have encountered for the past 4 years. So many of them were males. Males outnumbered the females. They accounted for around, this is a 4-year statistics, 55 to 63% of the cases were men. So this is the month-wise cases. So except if you see the dip during the green one, so you could see. So obviously that is because of during the COVID time. And we didn't have any kind of seasonal variation kind of thing. Invariably, we'll be getting around 40 to 45 cases every month. So that was the trend, what we had seen so far. So I'm having some doubt whether the pointer is working or not. So most of the cases were referred from other districts. So if you see this, Kadalur accounted for almost 30% of the cases, followed by Viluppuram, and Kallakurichi 15%. And from Chennai, like they presented a little bit earlier. Within 3 to 4 hours, the people were consumed poisoning. So Chennai, we had the early presentations. And of course, the Pondicherry and other districts, adjoining districts also had a significant number of people. But now the referrals are coming down, fortunately. And this is the 2021 picture where we had majority of the people were from Kadalur, Viluppuram and Kallakurichi. And the same picture was there in 2022 as well. 2023, it continues again. And this is the 2024 picture. So majority of them were from Kadalur, Viluppuram and Kallakurichi and Pondicherry. So this is the clinical presentations. Though the patients have been referred from the adjacent districts, majority of them were asymptomatic. So almost 87.7% of the patients were asymptomatic. That's the biggest challenge. The patient comes to you with no symptoms, and you know pretty well that the patient is going to deteriorate in another couple of days, and the patient might die also. So that's a very difficult, challenging situation for a clinician to tell the patient that the course of the possible course of the illness, the possible interventions which we are going to take, and the outcome. So that is more important. Because the patient and patient's attender can easily say, அவர் வரும்போது நல்லா தான் இருந்தார், நடந்து தான் வந்தார். So that's a very common thing which we encountered in our IMCU. So that puts a lot of pressure on the clinician, the treating physician, the point of care physician to explain the possible course of the illness. That is more important. That was the initial presentation when these patients arrived at our hospital. Of course, majority of them, they had many symptoms, GA symptoms over a period of time. Abdominal pain, jaundice, bleeding manifestations, and the altered mental status. Few of them presented with hypotension. So that's what I said, 5% of the group among the 2026 cases since 2021. So 5% of them, they presented to us with hypotension. Please remember, the same, the phosphorus can affect the heart also. It can result in similar kind of the toxin-induced injury to the heart, can result in myocardial depression and can result in hypotension. They might go for multi-organ dysfunction, presented to us with elevated renal parameters, again with hypotension. So these are all some of the things which we need to remember. Oliguric AKI, they accounted for 5% of the patients. Why I am saying all these things is, these patients were taken up for the one in the symptomatic hypotension group and one in the oliguric AKI group. Many of them were taken to SLED. So after the plasma flux is over, we continued with sled, and we have been quite successful also. So that is the thing, practical point which we can get from these kind of cases. The time of presentation is, of course, because of the late referral. Many of them were presented to us after 24 hours to 72 hours, because they have been referred from the adjacent district. The problem is most of the patients have been referred to Stanley Medical College hoping that they'll get a liver gets transplanted. So once they come to us, the first question they ask us is, when are you going to replace the liver? That is the question. So we had a challenging time, because that is one of the center, many people they knew that Stanley is one place where the liver transplant is being taken place in large number when compared to the other hospitals in Chennai. So from 2022, September 13th, till date, we have had 350 cases who underwent plex. That is roughly around 17.3. The time for the initiation of the plex is, from the conception of poisoning, is 3.37 days. That's a huge time. People were talking about the early plex. But if you see this, the average time for the initiation of the plex is 3.37 days. Already the damage is done. The chance of revival or reviving an organ is the less possibility. Of course, once the patient is initiated on plex, the peak serum bilirubin, SGOT, SGPT, INR, and APTT, it comes down slowly after the third day. So that is the common observation which we have said. Then we plan to taper the sessions, plex sessions. I just wanted to know from the learned audience, we have done around, by average, 3 to 4 sessions on each patient. Today also we have a patient. The 4th session is going on right now in our hospital. We rarely went beyond 7. So I would like to know, because my vehicle got a freak accident, I could not join you on time this morning. Of course, Lydia knows. If somebody can enlighten, how many cycles would be the optimum cycles a patient can undergo? So if there are any evidence, please enlighten us. So we hardly gone beyond 7. So that too 7 is because of various pressures, including political pressures. We have done some up to 7 numbers, 7 sessions. So by average, we do 3 to 4 on each patient. Once the level peaks down, once the peak level comes down, starts tapering the values, we stop it. So that's what we do. So this is the number of total rat killer paste poisoning and the death. We have got around, since 2021, we have got 356 deaths out of 2,026 cases. Of course, if you could see that the incidence is coming down slowly. So the 2022, we had 130 deaths. So after the plex is being initiated, we could see the obvious dip, almost more than 60-70% decrement in the rate of death. 132, immediately in the next year, it came down to 52. Thanks to NHM for that wonderful initiative. And in 2024, the total number of deaths were 39, and 25 till date, till March, the total number of deaths were 6. So this is the case fatality rate. Again, it's not a very happy moment to say that it's one of the preventable cause of death, where we talk about the the case fatality is coming down slowly over a period of time. Of course, with various measures, including the awareness on rat killer poisoning. So till 2022, we didn't have much awareness about this rat killer poisoning. Of course, again, thanks to NHM, the Gastroenterological Society, and the initiative. And in fact, like we were happy to know that we brought in this kind of the increase in the number of cases of referral cases, particularly with rodenticide poisoning to Stanley Medical College. We brought this to the notice of Honorable Health Minister. And of course, all of you know how the Legislative Assembly has passed a bill on banning these rodenticide poisoning. Of course, overall, the people who are at risk of dying, the people with high MELD score, patients with high serum bilirubin, patient present to us, quickly they go from grade 1 HE to grade 3 and 4, and hypotension. So these are all some of the poor prognostic parameters what we have seen. And I need to, as I already alluded to, I have to submit that the majority of the patients, they have underwent 3 to 4 sessions, not more than that. So I think the treatment part of it, I'm not going to talk about this. All of us know that. Yeah, the indicators were already been dealt with. Yeah, so these are all some of the challenges. So it's very difficult for us to include them in the CMCHS. Even if we do the sessions on time and we do other supportive measures, investigations, and getting opinion from all the people, when we subject it to the pre-auth and approval, we hardly get 2,000, 2,500. In fact, we would have spent more than that, 5 times the value what we really get. We would be spending around 11,000 to 12,000 on each patient, excluding investigation. And we end up with getting just a meager 2,000 rupees. And patients who are referred outside Tamil Nadu, we had again a lot of challenges. The late presentation, as I already told you, they come with a lot of complications. And delayed complications. So delayed complication, not only the hepatic, the fulminant hepatic failure, the other system involvement, the cardiac and renal complications. Of course, the bleeding complications were some of the delayed complications which we have encountered. I think one of the presenters from the delegates, they asked about what are all the complications the patient possibly can develop during the procedure. So we have seen a lot of patients with tetany-like picture. So maybe because of the hypocalcemia, that's why we give magnesium also. And after each session, we also give calcium gluconate also. So that is one of the complications which we have seen. But my question remains, this is a very bustling question. Out of these patients, 2,026 cases, 356 people have died. So remaining around 1,700 patients, they came to us with the hope of getting a liver being transplant. We advise discharge from the hospital when their serum bilirubin, SGOT, SGPT, and the other coagulation factors are coming down, and the patient is hemodynamically stable, not requiring inotropes, with all other organ support were withdrawn, and the patient is able to take care of himself by taking his own feed. But from my colleagues from medical gastroenterology, we have seen 1 or 2 patients were being really gone to the MGE and they registered for the liver transplant. So we know pretty well that There is no antidote for rat killer poisoning. So this is only a supportive measure, and it's in fact whatever the plex we do is, it's a bridge to liver transplant. But ultimately, majority of the patients or most of the patients, they didn't have that kind of thing. So that is a very, again, another thing that may open up a Pandora's box, but anyhow, so I just brief, the patients, number of patients who have really gone to the medical gastroenterology for the workup of liver transplant. So these are all some of the ongoing research activities which are happening in Stanley Medical College with regard to the rodenticide poisoning. There are many success stories. So here is a 14-year-old girl from Tiruvannamalai. She has consumed rodenticide poisoning and landed up after 3 days with multi-organ dysfunction. She came with hypotension. She came with elevated renal parameters. Of course, there was features for fulminant hepatic failure. She was managed with all the routine guideline-based protocols, and she underwent 4 cycles of plasma exchange. She was improved. There are so many patients who are with us who can give the testimony that how the patients can come through this ordeal and how the plex was helpful to majority of the patients. So with this, I end my talk, and I thank my dedicated physician team, my paramedics, nephrology department, medical gastroenterology department, and the faculties from the transfusion medicine. Thanks for your attention. Thank you.
Thank you, sir, for your outstanding contribution, which sheds light on the nuances of the plex therapy through your case studies and expert analysis. So, and it's more commitment towards the evidence-based practices. Now, I would like to invite the next speaker, Dr. Gayatri, to share the future prospects of rodenticide poisoning and the cost of plex challenges and the way forward. Thank you, ma'am.
Good afternoon, everyone. Thank you for this opportunity. So first, the cost of the plex we are going to do. What is this? Because from morning we are seeing the lectures on how plex had improved the outcome in rodenticide poisoning. So what we can do? That one. Okay. So plex is basically done using a machine. So what are the ways, methods we can do to reduce the cost of the plex? Sorry. So one thing is the requirement of an equipment. So this equipment which is available in the market is cost around 50 to 60 lakhs per machine. So what are the ways? What are the ways we can reduce the cost? Mangekasi ma'am had briefly explained what are the challenges we are facing. One thing she told us an interpreted kit supply. So that can be overcome by reagent rental. They can keep you kit supplies to us. And another one more thing is we can develop a locally manufactured instrument, locally designed instrument, so that whether the cost can be reduced much. So what are the expenditures we generally face with an apheresis? First is the hardware cost, like the apheresis machine I told you. And second one is the procedural cost, that is the kits associated with this. So over the few slides, I'll be explaining how we can overcome this one, with the help of a locally designed equipment. So as Epan sir had explained, centrifugal plex is improving the way in therapeutic plasma exchange. And these are the various machines that are available in the market. And when you want to develop a machine, what are the things one has to take care of? First, the machine should be portable. As ma'am said, it may not be always in blood, ICUs, it may be in ward also, or you can do in the HDUs. So that time it should be portable. And second thing, it should have a monitor. Monitor basically means what are the things you are going to input to the machine and how the procedure is being running. Everything should be monitored. So with the help of a monitor, you can visibly see that one. And next thing is a panel. Panel is nothing but the sensors and the detectors, which I am going to explain later, so that you can place the kit which is available to overcome the procedure. And next one is the centrifuge unit, because basically we have told that centrifugal plex is nothing but a separating a component. So with the centrifuge unit only, you will know how you are going to separate. For that, the machine should have a properly functioning centrifuge unit. And a few other hardware components. Hardware components is nothing but an IV, like IV pole also to hang your replacement fluids or IV fluids. So all these things we have to taken care of when you are trying to make a machine. And when we are trying to develop a locally designed machine, the primary concern is the safety of the patient who will be undergoing the plex. So what are the ways that can affect during the plex? One is the extracorporeal volume. What do you mean by extracorporeal volume? Is nothing but the amount of blood that is outside the body. Suppose I connected to a patient and he is bled so much outside the world and outside the body, and he may land up in a clinical instability. For that, there should be a check. And second is the anticoagulant, because the blood is coming out. Once it comes out, generally we will clot. So for that, not to clot in the circuit, we should have an anticoagulant. As well as inside the patient also, it should be anticoagulated. So we have to check on a anticoagulant ratio. And another one thing is the centrifuge. As I told you earlier, the centrifuge must work properly, because otherwise you can't have correct component separation and you don't have the desired one. And another one thing is a collection system. If there is a block in the collection system also, you might face problem while doing the procedure. And another one thing is a leakage. Suppose the kit is problem and the patient is bleeding through the leakage, he may exaggerate and he may go into clinical instability. So these are the few problems that will face during a machine is being connected to a patient. So what are the existing machines that tell us about how to overcome these problems is using the help of these sensors and detectors. These are few of the detectors and sensors that are being available in the market. But while designing the machines, we have to make sure like we are having these sensors and the pumps and the valves to make sure the system is working properly. And one more important thing is in the centrifugation unit, where you can see, as I told you, it should function properly. If it is not functioning properly, it cannot separate the components easily. So there should be an adequate sensors, like the centrifuge quality check should be ensured using the help of the sensors that is available in the centrifuge unit. This is about the hardware problem, like what are the hardware we have to take care of when developing a machine. This is one thing is the extracorporeal volume, which I have explained earlier. And we move on to the procedural cost, that is the apheresis. It is also a major expense we will face because it costs around $15,000. So what is this apheresis kit? This is a disposable single unit kit. It comes with a set of bags and other tubings that goes all over the sensors and detectors, which I have described earlier. So what we have to be careful of when developing a tubing system, it should have an plasticity. Plasticity is nothing but flexibility, because it is going into all around sensors and this thing. So it should have an flexibility to go on this without any breakage, and it should not have any leachability, and it should be totally leakage proof, and it should come in a closed system, because if the patient is in a closed system only, the aseptic precaution will be maintained. If it is in breakage, the patient may prone for infections. So in a nutshell, with all these sensors and tubings, all this makes the criticality in making a machine. So when you want to develop a machine, we have to think all this once. And one more thing is, this is a multi-purpose instrument, like the markets, whichever is available. When you are going to the machine, like want to develop a machine, we have to think whether to make it as a single purpose or multi-purpose. It's a large question. I'll leave it up to the team to decide and look upon whether to have a single purpose or multiple purpose. And the last, I want to discuss about two main laboratory aspects. One is the INR. From the morning we had seen, INR is the deciding factor to decide whether to be plexed, to be proceeded or not. But you should know that INR is more prone to errors, like because it can go into the pre-analytical error, analytical or the post-analytical errors. So it's better to enroll in an equi and make sure you are doing the test correctly, so that when you are deciding on plex, whether you have done correctly for that patient. And next one is the von Willebrand factor. You know, von Willebrand factor is an extremely expensive test. Even though it is not included in the algorithm, it can help us in understanding the pathogenesis of the disease. In same similar, with the help of the in-house reagents, we have have an affordable rate one Willebrand assay, so that you can keep it in the back of mind, like this test is available. So in the future, if you want to develop a new algorithm, you can also include this von Willebrand factor. Thank you for this opportunity.
Thank you, ma'am. So now we will have the question and answer session to open for questions. Another mic.
Sir, flux therapy kits are not available. So, for a long time, we are struggling. In Tirunelveli. Tirunelveli, Mike. So, professor of transfusion medicine will highlight.
Thank you, sir. Ma'am, we have a hemonetics, ma'am. We don't have spectropsia, so we have only hemonetics machine, and kits are not available for the past 8 months, ma'am. Kits. Yes.
Just a small introduction for everybody. Let us take up this suggestions or question and answers, what a few inputs we'll take from all of you. But the role given for me is to draw an action plan, state action plan. So when we want to arrive at a state action plan for the rodenticide poisoning and with whatever we would like to conclude, we should look at 3 parts of our existing program. One part we have initiated, we have commenced, we have implemented. There is an existing scenario. From the existing scenario, all of you have come to take part, represent and deliberate. Second part is your gaps, challenges. You call it gaps, challenges or deficiency, whatever word you would like to use. Going forward, we should bring certain changes which will form as an action plan. So this is the very important objective of this meeting. One half of the meeting is about all rodenticide. Second half after lunch is all going to be about the snake bite. Both the parts, our aim is to look at where we are and where we should go. In order to go, there has been already a lot of points which has come, which has been passed over to me. And to start with, from Tirunelveli, they said about the issues. So the issues are certain issues are getting repeated. So you can also be specific about even the same issue. So coming back to Tirunelveli now, is it the kit or what? So like experts can actually help to make it more specific. Pass the mic over.
I am Dr. Suresh Khanna, Salem Medical College, sir.
Yeah, I think Tirunelveli I want to understand, then we can come to Salem. Tirunelveli, you was trying to say something. Regularity of kit supply has already come as an issue. Yes, sir. Uninterrupted supplies has come.
Yes, sir.
To be more specific, you can even tell us, you can help us out.
Yes, sir. We don't have the TP kits for the past 8 months, sir.
You call it as the PP?
TP, therapeutic plasma exchange kit. Plex kit. Plex kit.
Okay, last 6 months.
8 months, sir.
Now, let me understand this process. It is through TNMC, no?
Yes, sir. Yes, sir.
Now, why this regularity isn't there? Why it is not established? Since it is a centralized procurement from TNMC,
Yes, sir. It is.
What is missing
The
where?
manufacturer has. They were importing the kits, sir, but now they have set up a manufacturing plant. It seems so. We
Where?
are not getting any kit for the past 8 months.
Earlier they were importing. Now they say they have started a unit
They
themselves.
have some problem with license or something.
Okay, so there is a license issue. Is it the same? If it is a license issue for Tirunelveli, it should be the license issue for other places also. What is the fact?
Sir, the fact is different, sir.
Wow.
TNMC has given the rate.
Madam, use the mic.
TNMC has given the rate contract for now Spectra Optia, sir. It has given a rate contract for the apheresis machine Spectra Optia, but what they are having is Hemonetics machine, and it is not in the TNMC rate contract.
So the machine is not compatible.
The machine is not in the TNMC.
Exactly, the machine is not compatible with the kit supplied by TNMC.
TNMC. So
How many places across Tamil Nadu have similar issue? Madam சொல்ற அந்த ஒரு particular spectro opiaன்னு சொல்றாங்க. That is the supply of TNMC. அது இருந்தா இந்த பிரச்சனை இல்லைன்னு சொல்றாங்க. அப்படி இல்லைன்னா எத்தனை இடத்துல it is a different make? சேலம்ல என்ன மெஷின் பேர் சொல்லுங்க? ஸ்பெக்ட்ரா.
In Salem blood bank sites hematinics we having, but the problem is it is in repair, sir.
Okay.
But the rate for repairing is very high, sir.
Okay. Now I understood the point. We'll summarize the point and go to next point. That is, Spectropia is the equipment supplied by TNMSC, but there is also another equipment called that Emetopia, whatever you're saying, which is not serviced. There is some issue there. So this is the common issue for places. How many places we should know now are having this problem? In the particular supply சொல்றீங்கல, என்ன சொன்னீங்க?
Hemanetics. Hemanetics.
Hemanetics.
Span company, sir.
Okay.
Sir, and another thing.
It's a band company, yeah?
It's not span.
Okay. So
the thing is, why the Spectropia has come in the TNMC rate contractors, it has low volume, low extracorporeal volume. So the adverse effect for the patient is less. So they have selected it in the TNMC, I think, in the
for the right reasons. Now the trouble with the other one.
It has a large extracorporeal volume, so they may get a patient's adverse effect. That's why it is not included in that, according to the technical specifications.
So,
but they have the machines, so they are not getting.
See, they have the machine. The repair cost is huge, and it has got also the technical specification wise. It has a problem with a large extracorporeal volume. We'll note down. We have to take. Yeah.
This is a point more from the transfusion medicine, which is not my territory, but I'm explaining that we think the preferred choice of the brand should be Spectropia. So any new equipment should go in that direction currently, till we have within India made equipment. Hemonetics is not looked upon in favor because it's an inferior brand for this is what we do. So we should move towards getting equipment of that, and then the kit follows with it.
So it is a policy. You are helping us. All of you are contributing for a policy decision out of this meeting to document why Spectropia is preferred, and the other one we have to phase out or replace. That's all. That's it. I think that finishes. Anything? Yes.
One minute.
Yes.
So we are all very happy to see the advances and improvement made in this field. But as a small, simple clinician, there is still a need for manual plasmapheresis. Please, because one of the important reason for the delayed presentation is the late referral, non-availability of the equipment, but still this technique does not require anything except there should be a blood bank which can constantly supply the plasma, and there is one technician which can help in drawing the blood, and one nurse to monitor the hemodynamic status, and one dedicated clinician. This I have practiced when I was in government service, even in our IMCU. Even after I became one of the general outside practitioner, I have given this kind of a treatment where I could get an appreciable response. All that you need is you have to keep removing some of the blood and allow the blood to stand still till the plasma gets separated as much as possible. After some time, about an hour or so, you can still get the supernatant plasma that you can discard and replace transfuse back the same blood in the form of a packed cell, and you can substitute the removed plasma either with the saline or with the fresh frozen plasma. Till we get all the centers are equipped and trained across the Tamil Nadu, this is a small humble suggestion to the learned audience.
Now, picking up cues from what sir is asking, shall we take another decision as a group here that ideally spectropia should be there, and where they have the trouble with the other machine, will all the clinicians agree at least till alternate supply is made, they should be able to go by this conventional method of manual plasmapheresis. Is that a viable option, or you are agreeing or disagreeing? Please pass the mic and please give feedback. கொஞ்சம் வேகமா mic கொடுங்க.
So good morning, sir. So when this machine was not, I'm Dr. Namita, currently in MMC. When this machine was not available, we were doing it with our regular HD machines, sir. So Plex, initially we started in Stanley with a HD machine in the nephrology department. So maybe if the Plex machine is not available with the existing HD machines, only thing is the filter differs from the regular dialysis machine, dialysis. So that I think is also available through the TNMSA. So maybe that can also be.
So exclusive hemodialysis machine is a better option compared to you are showing this manual plasmapheresis?
I leave it to the experts. That is one
No,
other suggestion.
let us get opinion so that quickly we'll finish this point and go to the next.
Madam is telling another component. So what Dr. C.R. sir is telling is, as he has rightly said, before all these gadgets came into existence, sir was even for our GPS and all, we are regularly using that thing. But now the question is, when the facility is available, today I think around 18 and 19 centers are there, and cross-referral is accepted with 108 and other things. We'll leave it to the audience to take that call. And regarding Dr. Namita's madam's call, in fact, sir, even in our GH at MMC, we started only with HD machines, only because we had already, I think, sir, I think HD machines are there everywhere, now even at the taluk levels.
Yeah.
So only the question of filters that matters. Maybe madam can throw some light, because we used to do that. When plasmapheresis machine came also, when it is not working or kit was a problem, we used the HD machines, and our dialysis technicians are already well versed with using that. So the technicality was also solved. And also, in fact, when we are discussing with Dr. Heepan sir, we were doing 24/7. So for us, human resource was not there, because HD technicians are available already. So in case of challenges and restriction of kits, we have one more option of using HD machine, only the kit has to be used at different kits.
Sir, in our place, sir, we are doing at HD machines only, sir. The problem is uninterrupted supply of the plasma filters. So only the monopoly, the supplier, sir, the Seth Implex one company. So last 3 months back also, the supply was very poor. I discussed with Lydia madam also about the supplier. Anybody else's supplier is there. Sometimes he is supplying without the adapter also. That is the problem. So if some of the centers are still going with HD machines, why can't it be available through the TNMSC and uninterrupted supply of plasma filters along with the uninterrupted supply of human albumins? It will be very useful for the rat killer pest poisoning, sir.
Uninterrupted supply of plasma filter plus uninterrupted supply of human
albumin, sir. Sometimes it's
human albumin. Okay. I think if everybody is agreeing for that, places where we have the issue with the machine, we can go. Sir, Epen sir, please. You have heard everything now, so you can summarize it.
Not the last one, I'm sure this will continue only, but I'll just give you my perception on this. Actually, I'll say another wording of this. Plasma exchange can be done by two mechanisms of separating the plasma from the cells. That is, one is by the centrifugal technique, and the other one is by a membrane filter technique. So this HD machine will come under the membrane filter technique. Now it is true that hemodialysis machines are available everywhere, so why not use it? That is the one way of looking at it. Now we believe that from the analysis done so far, that the centrifugal plasma exchange provides more survival benefit than HD machine, that is membrane plasma exchange, in liver failure. Now, it's still early days. However, we published our data set on that in a syndrome of acute and chronic liver failure, where clearly we found a survival benefit. We think it is something to do with the flow rate of the processed blood. Centrifugal machine allows a lower flow rate. For example, about 50 ml per minute, while with the hemodialysis machine, that was around 150 ml per minute. And that is our hypothesis. Now, there's a recommendation from one international society that the centrifugal machine is the preferred machine for liver failure. But it's still early days. We are still learning on this journey only. So that is my opinion. That is, in liver failure, it appears that centrifugal plasma exchange could be superior to the HD machine, that is the membrane one. And it may be something to do with the flow rate. So if the flow rate can be kept low with the HD machine, then maybe we'll achieve the same answer. So that is where that starts. That's my opinion.
So the point coming here is HD machine, something is better than nothing. So where alternate viable option in those places, we can go for HD machine, provided we keep the flow rate low. That is the learning lesson coming out of Dr. Epen sir. So if that settles the issue for everybody, we can move to the next point. So instead of manual plasmapheresis, better option is your HD machine with the flow rate kept low. That should be the decision point. Is that fine for everybody? No, let me hear everybody from behind. அவருக்கு மைக் கொடுங்களா சாருக்கு. நமக்கு நல்லது இந்த டிஸ்கஷன், நம்ம குயிக்காகவும் போகணும், அதே சமயத்தில் அடுத்தடுத்த பாயிண்ட் போயிட்டே இருக்கணும்.
Manual is not recommended in the era of
yeah, let's not go back to the earlier systems because now things are improving and advancing.
Regarding the flux centrifugal, as sir told, it is better with the liver failure. If 2 units are available, we can use it. But the issue is the kit supply has to be addressed. That is the problem.
இல்லை அதுதான் அந்த பாயிண்ட் நாங்கள் ரெசல்யூஷனில் கொண்டு வந்துடலாம் சார். அதாவது அன்இன்டர்ப்ரெட், நான் எழுதியிருக்கிறது ரைட்டாக தப்பான்னு சொல்லுங்கள், அன்இன்டர்ப்ரெட் சப்ளை ஆஃப் பிளாஸ்மா ஃபில்டர் அண்ட் த ஹியூமன் ஆல்பமின் கரெக்டாக சொன்னாங்க. அந்த பாயிண்ட்டும் சேர்ந்து தான் வரும். அந்த பாயிண்ட் சேர்ந்து தான் இந்த ரெசல்யூஷன் பாயிண்ட். ஸோ இட் இஸ் நாட் ஓன்லி HD machine is okay alternate option. The flow should be low as per the scientific evidence. Number 2, there should be uninterrupted supply of plasma filter slash means and human albumin. The point is freezed now. Okay. Next, new points, new ideas.
Sir, from Madurai Medical College.
Yes.
I'm the transfusion medicine department.
Yeah.
The guidelines, present guidelines, low volume plex for 3 cycles for 3 consecutive days. So let us say in many cases we are encountering the rebound of initial preplex values, lab parameters or clinical values. In those instances, what we have to do? We have to go for the standard volume plex, or we have to increase the number of cycles to 4 to 5. And another question is, what about the replacement fluid utilization? Does albumin have a role in as a replacement fluid? And third point is, if a patient have in 2 cycles he has a citrate toxicity, he is not tolerating citrate as an anticoagulant, can we go for a heparin? In what way we can do that? And also the another question, the prognostic marker indication, can we add leukopenia and thrombocytopenia as an early indicator for toxicity or clinical severity?
சார் இப்போ ஒன்றும் இல்லை, உங்களுக்கு ஹெல்ப் தான் பண்ணுறேன். ஐ எம் நாட் த கிளினிஷியன் டு ஆன்சர். டைட்டிலில் ஒன்று ஒன்றா சொல்லிவிடுங்க. இப்போ ஒரு எத்தனை ஐட்டம் எடுத்து பேசியிருக்கீங்களோ ஒன்று ஒன்றா சொல்லுங்கள். ஃபஸ்ட்டு என்ன டைட்டில்?
For the plex, low volume plex, 3 consecutive cycles. What we have...
இல்லை நீங்கள் டிஸ்கிரைப் பண்ண வேண்டாம். ஒரு ஐட்டம் ஹெட்டிங் சொல்லுங்கள். ஃபஸ்ட்டு என்ன ஹெட்டிங் என்ன?
Low volume plex in 3 cycles at 3 consecutive days.
Low volume
plex versus standard volume plex.
Low volume plex and
3 days for 3 consecutive days.
Versus என்ன கேக்குறீங்க நீங்க?
Standard volume plex, more cycles, 4 to 5 cycles, sir.
ஓகே, எனக்கு அது புரிஞ்சிச்சு. அடுத்த டைட்டில், அடுத்து என்ன டாபிக் எடுத்திருக்கீங்க?
Albumin as a replacement fluid.
Albumin as a replacement fluid.
What role does it play in radicular positioning phase?
சார் ஒவ்வொன்றா முடிக்கலாம் சார், ஒவ்வொன்றா முடிக்கலாம்.
ஓகே.
டாக்டர் ப்ளக்ஸை பொறுத்த வரைக்கும் நீங்கள் வந்து ஃபிக்ஸடாக 3 சைக்கிள்ஸ் தான் வச்சுக்கணும், லோ வால்யூம் தான் வச்சுக்கணும், அந்த மாதிரி இல்லை. அதாவது நம்ம வி ஆர் ஆல் எல்லாருமே இந்த எக்ஸ்பீரியன்ஸிங் ஸ்டேஜில் தான் இருக்கோம். நான் வந்து என்னோட எக்ஸ்பீரியன்ஸை வச்சு, எங்கள் டீமோட எக்ஸ்பீரியன்ஸை வச்சு ஐ எம் டிஸ்கஸிங். நாங்கள் ஈவன் ஐ திங்க் ஸ்டாண்டியில் சார் கேட்டார், நாங்கள் அப் டு 5 சைக்கிள்ஸ் வரைக்கும் நாங்கள் போயிருக்கோம். அதே மாதிரி வி டோன்ட் கோ அதை நீங்கள் மெயினாக ஐஎன்ஆர் அண்ட் சீரம் பிலிருபின் வச்சு நாங்கள் போவோம். இன்கேஸ் நீங்கள் சில சமயத்தில் வந்து அவர் ஃபிசிஷியன் வந்து லியூகோபீனியா இருக்குன்னு சொல்லிட்டு அதை இண்டிகேஷனாக கொடுத்தாலும் வி வில் டேக் இட். அதே மாதிரி த்ராம்போசைட்டோபீனியா அந்த மாதிரிலாம் இருக்கும்போதும் வாட் எவர் நீங்கள் வந்து வாட் இஸ் த இண்டிகேஷன் கிவன் பை த ஃபிசிஷியன், அதுதான் நம்ம இண்டிகேஷன் ட்ரான்ஸ்ஃபியூஷன் மெடிசனுக்கு. நம்ம வந்து அதை டிசைட் பண்ணுறவங்க நம்ம கிடையாது. இண்டிகேஷன் இஸ் பை த ட்ரீட்டிங் ஃபிசிஷியன், நம்பர் 1. நம்பர் 2, நம்பர் ஆஃப் சைக்கிள்ஸ் வந்து 3, ஈவன் 5, அது வந்து இட் பேஸ்ட் அப்பான் யுவர் ஐஎன்ஆர் வேல்யூ, சீரம் பிலிருபின். நீங்கள் சீரியலாக அதை பண்ணிகிட்டே இருக்கணும். த டே 1ல் பண்ணி அதோடு நிறுத்திடக்கூடாது. சீரியலாக பண்ணிகிட்டே இருக்கும்போது வெதர் யுவர் பேஷண்ட் ஹாஸ் ரெஸ்பாண்டட் டு த ப்ளக்ஸ், அது வந்து நீங்கள் அசஸ் பண்ணுங்கள். ரெஸ்பாண்ட் பண்ணுறாங்க அப்படின்னா யூ கண்டினியூ. மேக்ஸிமம் நாங்கள் வந்து 5 சைக்கிள்ஸ் வரைக்கும் போயிருக்கோம், 7 சைக்கிள்ஸ் வரைக்கும் போனதில்லை. இஃப் இட் இஸ் நாட் ரெஸ்பாண்டிங் டு யுவர் ப்ளக்ஸ், தேர் இஸ் நோ யூஸ் இன் கண்டினியூங் த ப்ளக்ஸ். 2. தேர்ட் வந்து வெதர் இது வந்து லோ வால்யூமா, ஸ்டாண்டர்ட் வால்யூமா, ஹை வால்யூமா, அதை இண்டிகேஷன் வந்து அந்த ப்ரோட்டோகால் வந்து நம்ம வென் வி ஸ்டார்ட் லோ வால்யூம் ஸ்டார்ட் பண்ணோம். பட் எங்கள் சென்டரில் வந்து வி ஹவ் எக்ஸ்பீரியன்ஸ்டு எல்லாமே லோ வால்யூம், ஸ்டாண்டர்ட் வால்யூம், ஹை வால்யூம் எல்லாமே வி ஹவ் எக்ஸ்பீரியன்ஸ்டு. ஸோ நீங்களும் உங்கள் கிளினிஷியனும் உட்கார்ந்து பேசி சார் ஐ ஹவ் டிசைடட் டு டூ திஸ் ஸ்டாண்டர்ட் வால்யூம் அப்படின்னு சொல்லி, அண்ட் ஆல்சோ பேஷண்ட்டோட கண்டிஷன். ஸோ ஐ ஓன்ட் சே ஹானஸ்ட்லி, ஐ எம் சேயிங் ஸ்ட்ரிக்டாக ஐ எம் நாட் ஃபாலோயிங் அந்த இனிஷியல் இருக்கு இல்லைங்களா, ஐஎன்ஆர் ஈக்குவல் ஆர் மோர் தேன் 4, அதெல்லாம் வி ஆர் நாட் ஃபாலோயிங். ஒன்ஸ் சீரியலாக ஐஎன்ஆர் பண்ணும்போது இட் ஹஸ் ஸ்டார்டட் இன்க்ரீஸிங் அப்படின்னாலே ஏர்லியாக நாங்கள் ஐஎன்ஆர் கண்டிப்பாக பார்த்தோம், பிலிருபின் கண்டிப்பாக பார்த்தோம். ஸோ வென் இட் ஹஸ் ஸ்டார்டட் இன்க்ரீஸன் வி ஸ்டார்டட், அப்போ வந்து ரெக்கவரி ரேட்டு வந்து ரொம்ப கிரேட்டு. நீங்கள் உட்காந்து என்கஃப்ளோபதி வர வரைக்கும் இஃப் யூ வெயிட், ரெஸ்பான்ஸ் வந்து இல்லை. வரும்போதே இது என்கஃப்ளோபதியோடு வருதுங்கிறது வேறு. பட் நம்மளே உட்காந்து வெயிட் அண்ட் வாட்ச் பண்ணி அது என்கஃப்ளோபதி போகிற வரைக்கும் நம்ம வெயிட் அண்ட் வாட்ச் பண்ண வேண்டாம். ஏர்லியராக சீரியல் இன்க்ரீஸ் இன் ஐஎன்ஆர் அப்படி வரும்போது யூ ஸ்டார்ட் டூயிங் இட். அந்த வால்யூம் அண்ட் ஆல் யூ கேன், இது ஒரு ட்ரீட்மெண்ட் தானே டாக்டர். யூ டிஸ்கஸ் வித் யுவர் கிளினிஷியன் அண்ட் யூ கேன் டிசைட். ஸோ வால்யூம், இண்டிகேஷன், வேற என்ன கேட்டால் இது அண்ட் சைக்கிள்ஸ் ஆல்சோ நீங்கள் டிசைட் பண்ணிக்கோங்க. நாங்கள் வந்து டெய்லி பண்ணோம் டாக்டர், ஆல்டர்னேட் டேஸ்லாம் பண்ணல, டெய்லி. ஹீமோடைனமிக்லி ஸ்டேபிளாக இருந்ததுன்னா வி ஆர் டூயிங். ஹீமோடைனமிக்லி ஸ்டேபிளாக இல்லைன்னா கூட யூ ஆஸ்க் யுவர் ஃபிசிஷியன் டு கரெக்ட் தட். ஏன்னா நாங்கள் ஐ திங்க் ஃபியூ கேசஸ் வி ஹவ் டேக்கன் இட், அது அவங்க வந்து அந்த நார ட்ரிப்பு அதெல்லாம் போட்டு கரெக்ட் பண்ணிவிடுவாங்க. கரெக்ட் பண்ண உடனே நம்ம பண்ணிக்கலாம். ஹைப்போடென்ஷன் வந்துச்சு பண்ணவே இல்லைன்னு விட்டுறக்கூடாது. as soon as they have corrected it, we can start doing it and we can give results. அப்புறம்
மேடம் இந்த பாயிண்ட் முடிஞ்சிடுச்சுன்னா ஃப்ரீஸ் பண்ணிடலாம் பாயிண்ட்டை. இப்போ நீங்கள் சொன்ன பாயிண்ட் வந்து படி மேடம், the low volume plex versus for 3 days versus standard volume for many more days அப்படின்றத அவர் ரைஸ் பண்ணாரு. மேடம் has clarified that it all goes by a serial assessment which you do daily basis, including your INR and all that. So only based on that you make a decision. And you also mentioned you don't go beyond 5 days. ஸ்டாண்டில் இருந்தும் ஒரு எக்ஸ்பிரஸ் பண்ணியிருக்காங்க. ஸ்டாண்டில் இருந்தும் இஸ் there optimal cycles for a patient up to 7 நோட் பண்ணியிருக்காங்க. So the number of cycles is coming again and again from different people now. So if this is what you have conveyed, let us hear from Dr. Eapen sir and freeze the point and go to next. Because we'll have to move on. Yeah.
Okay. I must say we are all learning, and I'll just convey my thoughts on it. One is there is currently no study, randomized study comparing low, standard or high volume. There is no study in the world like that. So we do not know the answer. So currently the protocol we recommended low volume because that seemed to work. But there is no study right now comparing standard and low volume. So I suggest, as madam said, each center there is a team. This is like doing liver transplant. One man cannot do liver transplant. Everybody one team. And together you decide what is best for you. So that is my stance on it. The protocol remains recommending low volume. If Madurai mentioned that we found standard volume was better, that's the way to go in your center. When you have sufficient number of patients, please analyze that, please publish it. That is your responsibility. Then we move ahead. That is how only we can move ahead. Secondly, how many cycles should we do? Usually we are worried about line sepsis the more we keep. So there is one narrow window when we can do things well. Beyond that, the window goes off. Secondly, problems are local, either bleeds or local thrombophlebitis, line-related problems. Usually we are saying keep it to 3. The odd patient we have also done till 7. But this is from different cause of liver failure. But always the concern is line sepsis. So I think it's okay. The current guidelines is good enough, I feel. Aim for 3. Then it's up to us to decide. The team has to decide, should I stop with 1? In some patients, we don't go beyond 1. We had some bad indicators. In the odd patient, we may go up to 5 or 7. So I don't think we will change that. So both these do not change. The current guidelines remain. Lastly, should we give albumin as replacement or not? Now there are 3 replacement fluids possible. One is fresh frozen plasma, 2 is albumin, 3 is normal saline. For example, let's say a neurological condition, Guillain-Barré syndrome, there is no fresh frozen plasma. But in liver failure, invariably there is coagulopathy, INR is prolonged. So the recommendation by the American Society for Apheresis is, please replace with fresh frozen plasma. Why? Because this coagulation gets corrected. So thereby, if it is possible, FFP may be the better option. But I know that for various reasons, different centers have different protocols there also. Some people, some centers would like combination of FFP and albumin. I think we'll leave it like that. So the current protocols, I believe, is okay. There's no need to change that, I think.
Sir, is it necessary to stop the plex once the value starts coming down, sir? We are giving 2 or 3 cycles of plus and the INR and the LFT starts coming down. Is it necessary to continue or you can stop and watch, sir?
Yeah, sure. That's a good question, sir. So what Vijay Alexander presented today morning was, if the MEL score became less than 20% reduction, the ROC curve is very high. It's already published. So you can look at that data and apply it for your own patient to say, if it is high, I do not need to do any more. But what happens the other way around? Did not reduce. Then what should I do? I do not know the answer about that. And I know it's death. I am aware of that as well. I do not know the answer. What from Madurai the doctor had asked, we are using a low dose steroid as well. We found by starting that along with this treatment protocol, a rebound of hyperbilirubinemia became less for us. Okay, that's been our experience at Vellore, at CMC. I'm not saying that is correct. It is just that that's been our experience. So all patients we give a low dose steroid also specifically to try and prevent a rebound hyperbilirubinemia. The dose, we published that. We are giving 10 milligrams of prednisolone. Suppose tomorrow we are starting plex, from today we start that. And how long to give it? In Rodenticide, we will stop it once we finish the plex. So we may give it for another 2 days or so. Like that, that's what we do.
So in Tamil Nadu, many patients are presenting to us late only, sir. Late, after 3 days or 5 days with the LFT raised and PTNR raised. Is it correct guidance to start plex at that time or? Sir?
So let me explain that. All of us are familiar. 20 years ago, we all have our own family, somebody had heart attack. And they're going 200 kilometers to go to a center to do heart attack treatment. But now we know that must be something wrong will happen on the way. Somebody will become more sick. But now increasingly when TAI NHM provides within a district, common sense tells me that you will start getting people earlier and start getting that later and later will become lesser and lesser. Okay? And that's already starting to happen. We are in the middle of this big war happening actually. We are all soldiers in that, I think, in a way. So that's bound to happen. So increasingly we should be doing it earlier. Now should we do it when it's all late? That's where these guidelines guide us. It's only guidelines. The team locally has to make these important decisions, which are life or death for the patient. So should we do or not? These guidelines guide you. Guidelines are absolute contraindicated. Let me ask you a question, sir. Somebody got unequal pupils. Liver transplant possible. Should I do liver transplant?
It's contraindicated.
I probably will not, because anyway it's unequal pupil. Should I do plasma exchange? The guidelines say no, because it's too far in the game. Pupils are not unequal, okay, but patient is very sick. Should I do or not? Again, guidelines help us. But I believe increasingly, when you provide district-wise, this will become less. Because you are now providing that 200 kilometer travel is no longer there. I'm only traveling 50 kilometers, as an example.
Yes.
Sir, I would like to share one...
name of the institution?
Government Ramnathpuram Medical College, sir.
Okay.
But this observation was made from the previous institutions where I worked, sir. I worked in Tirunelveli, Thuthukudi, Thiruvarur, Tanjavur. And what I observed was, we are all along talking about the liver cell failure and then plex. That happens after 4 or 5 days. But the initial death, sudden cardiac death in rodenticide poisoning occurs due to arrhythmias, sir. Most of the cases are missed. So my personal suggestion would be at least 8-hourly ECG should be made mandatory to just observe at least whether there is any arrhythmias and then sudden cardiac death. And most of the times they were speaking about the hypotension and hemodynamic instability. That is, yes, that too in very young patients without any comorbidities. The cause will be cardiac. This is what, I mean, this is my observation from various institutions.
Mike, last lo kudunga.
My question to Dr. Apen sir. I'm from Nagapattinam Medical College, sir. Intraplex hypotension, sir. It's a very common problem we face when we substitute plex. How long should we wait? How do we resuscitate? When do we restart plex, or should we abandon the procedure? That is number one, sir. Second, after 1 or 2 cycles of plex, we face sepsis. What do we do then, sir? Do we stop the procedure or we treat the sepsis and then resume the procedure of plex? What do we do, sir?
Thank you. We are actually looking at people who are very seriously sick, and the treatment also is a little dangerous treatment. Though it doesn't look like that, that's a reality. So I told about George Washington, the first American president. Within a day, the American public said the doctors killed the patient. So let me ask some provocative question. Can anybody put a court case saying we did not do liver transplantation? The court judge also will rule it is not feasible, urgent liver transplantation. Will anybody put a court case saying we did not do urgent plex? Now that is not so easy for the judge as well, because it's possible to do plex. It's not like urgent liver transplantation. Okay, I'm just asking as awareness comes. So we are in this territory only. So it's an important question. So that is just a thought I just want to share with you to say. So intraplex hypotension is in the territory of transfusion medicine primarily, not so much the clinician. So I'm just sharing how our expertise is to say. Now, generally in a person who's critically ill, we can cause more harm. So I don't think we should be causing hypertension to happen. I am aware that one particular machine is more prone for intra procedure, which is hemodynamics. It's something to do with extracorporeal volume, some problem is there. While this spectropia is more like on Mercedes-Benz car, nothing happens. It goes very smoothly to say, but at much more expense like in the Mercedes-Benz car, okay to say. So as a statement, not good to do not good to a hypertension. What should we do? Should we stop or not? I am inclined to think I will stop. But I must say I am not competent enough in that. I do not know the answer on that question. Two is if there is sepsis, which comes down to the question from Madurai, the doctor asked as well. Sepsis is the concern always. So can we continue doing more and more sessions? Our concern is sepsis. So that's why we are pulling it out, the line as well as soon as possible. Because the moment the person turns septic, again the game is over, match is over. We may not survive. So if there is sepsis, the guideline says is a relative contraindication. We cannot do. It's difficult to diagnose sepsis. The person is sick. Fever is part of macrophage activation syndrome criteria, which also happens in some of these patients. So these are some difficulties which we face there as well. Let me share another one point here. One of the publications we sent to Indian Journal of Critical Care Medicine. They rejected it with a correct observation. They said, your patients are not critically ill. So first we felt sad, then we felt happy. The happiness is, we are treating rodenticide poisoning with plasma exchange before they become critically ill. That is the correct statement. So that is the window. What you ask, sir, when are we doing late? So they are accusing, not rejecting your paper saying, your patient is not critically ill. I like it. That is the patient. That's the window. So window is to do it early. Now critical illness is a vague definition. Who is critically ill? There is no good definition like that. But it's true, the window is earlier and earlier, and then try to do it without doing harm. We may be doing harm. For example, if somebody develops hypertension, then should we stop? Maybe I may stop, like that. I just sharing my thoughts.
Present we are using this Kochi's criteria, sir, for using plex. The INR of more than 4 and encephalopathy, these things are on the criteria for taking up the case.
Okay,
is it right time to relax these criteria?
So let me clarify that again. Kochi criteria are criteria to list for liver transplantation. Kochi criteria is not criteria for plex. The plex criteria by the TAI NHM and the TNIC are different, which are only 3. That is INR more than 4, serial worsening INR, or any encephalopathy.
Yes, sir.
But we use Kochi criteria for us to easily understand for survival benefit. In that study, none survived when they were given only standard medical therapy. Now it looks like 40%, 50%, 60 or 70% with Kochi criteria are surviving with plex alone, to say. So it allows us for comparison of survival.
Yes, sir.
So that is not criteria for initiating plex.
Yes, sir. In this criteria also, the INR is more than 4 and patient on encephalopathy. Till that time, do we need to wait, or some centers showing that earlier plex will give better outcome like that?
That's correct. So the second criteria is serial worsening INR. Suppose INR is 1.5 today, and tomorrow became 3. As an example, we can do plex. That's what the criteria is. So answer is yes, we should do it earlier. We should relax the criteria.
Yes, sir. Thank you, sir.
We should relax it provided you are confident that in your center, I can deliver this without doing harm.
Yes, sir. Yes, definitely.
Now, at CMC Vellore, we reached there only after the many years. Initially, we are also, it took us 10, 12 years to reach where we are. That's the answer.
Thank you.
Sir, I have a question for you, sorry. Sir, do you have any data on the follow-up of the survivors of plex? So any 1-year data, or has anybody needed liver transplant after plex, after surviving plex from the acute crisis?
Yeah. Now remember, thank you, Dr. Namit. Remember that rodenticide poisoning is only one cause of acute liver failure. Acute liver failure is well studied world over. If somebody survives 1 month, they'll survive for life. I give an example. We may hear some stories. Somebody says, even within our family, during pregnancy, this person became very sick 30 years ago. Now she is fine. So the person who survives acute fatty liver pregnancy or HELP syndrome, later on is quite well. So they did not go on to chronic disease. Which is yet another mysterious question. I almost died. Now I am very well for 30, 40 years. We do not understand that well. But if we cross one month, in any ALF, I will live well for life, generally.
Regarding the intraplex hypotension, there are options to correct the hypotension, sir. You can and that's why sir is telling, when the extracorporeal volume is high, you will face the hypotension. So in the market, only 3 brand companies are there. One is this Haemonetics, which has extracorporeal volume is more. So that's why we are not using it. Another one is the Spectroptia. Another one is Fresenius. These 3 are the centrifugal method hemonetics we can use for we cannot use for pediatric case also. But this spectroptia and Fresenius, we can use it for pediatric case also, and the extracorporeal volume is very less. So you won't get this intraprocedural hypotension often. In this centrifugal low extracorporeal volume, you won't get intraprocedural hypotension. Even if you get the hypotension, you have the options to correct. One. Number two, regarding the replacement fluid, as sir has told, the FFP is the first choice. But in blood bank, if you get a patient with a negative blood group or with AB positive, if you want to do 3, 4 or 5 cycles, we won't have enough for FFP. At that time, we discuss with the clinician and we give a FFP because we don't have what to do. So we will give FFP, albumin, and in the ratio that maintains these are all the experiences I am sharing. If you don't have enough plasma, then first itself we will plan how many cycles we are going to do, depending upon the INR and everything. So we will, depending upon the FFP stock, we are doing. And another...
Madam, just one suggestion. Like with your experience, you are able to tell various scenarios where you will find intraplex hypertension. I understood. The question raised is well taken. How to handle intraplex hypertension. So what Lydia will do is, the concept is taken. What are the important parameters or important judgment to be made? Yourself and Dr. Epen sir can contribute as part of the notes, and that we can circulate to everybody. So as you think more, you'll think more and more and tell more. So probably it will be very useful if we put it in writing and give, so that will also be part of the revised action plan. That is more for clinician help. But clinician concerns are raised here. So the concept is well taken, intraplex hypotension. It's okay. Next point. Any other new point, you please come forward so that lunch is, I am between lunch and all of you. Then all of you should not திட்டக்கூடாது பிறகு. ரொம்ப முக்கியமான தவிர்க்க முடியாத ஒரு நல்ல பாயிண்ட் இப்போ பதிவு செய்ய விரும்புகிறேன்னு சொல்கிறாங்க மட்டும் சொல்லுங்கள், so that we can close.
Actually, one of the interesting future of this plex is, I think Dr. Epen sir will also agree, how it works, how plex improves the morbidity and mortality. Still, there is no correct answer. I hope I'm right, sir. This has been already discussed before. So in that case, suppose if somebody comes with history of injection of 2 tubes, Madam was mentioning few cases, where it is more than twice or thrice a toxic dose. So in those high dose cases, can we start early? So that is a very, because today our people, they are not, nalla 2 tube, 3 tube, korayama saapran. So in that case, can we try that? As sir was telling, we don't know the right answer for many questions. So if some center can even start, because at least one advantage in government services, cost is not a very major deciding factor as compared to CMC and other private. So we can even think on those lines whether early, because sir was also mentioning, can we start early? So if somebody takes twice or thrice a toxic dose, is there any usefulness of starting it early?
Thank you. I'll give my point. I fully agree with what you say. There are many unknowns and should be. However, so far, plex is not viewed as a treatment to remove the poison from the body. It seems to work once the person gets liver damage. That's what the publication so far show. So that means, suppose somebody came today, took poison 4 hours ago. LFT is normal. Should I do plex? So as of today, we are not using it as a plex removal therapy. We say consider doing gastric lavage, consider doing charcoal. That's what the stance we are taking. The American Society for Emergency Medicine, this year's guideline says for massive paracetamol ingestion, and there's a definition of massive, plex can be considered. But there are no publications using that in that scenario. While there are publications of plex to treat paracetamol-induced liver failure. So what you said remains a question for research. That's my stance on that. It's like equivalent of saying massive paracetamol injection. What about massive, like that, etc. That's my stance. So we do not know how it works, but it appears to be having an anti-inflammatory effect. Let me ask a provocative question again. Do we need such a severe poison to kill rats in Tamil Nadu? Why not we recommend konjam milder poison kodunge? It's a very serious question. Suppose we say instead of rat poison, we have this trap. But the rat trap also will catch human beings. We will say, we will not need it. Because why? It's too much. So that is yet another, it's not mandate of this audience, but surely there's some action needed from that angle as well. Is such severe poison needed? Konjam milder potukalame.
So the last point is a very valid point, sir. Public health point of action. We can document here to say that the rat toll, that whatever poison that is circulated very easily, why not make it, why not scientifically we have something done to make it less toxic for human beings and reasonably toxic for rats. Other point, reasonably toxic for rats and less toxic for human beings who come with poisoning. அதை நோட் பண்ணிக்கிங்க. It's a very good point. I think we have to call the respective collaborating departments for that. Earlier also we did the same thing. I remember Lydia and all, we had called the stakeholders. It is time to call to work on that line. It cannot be dismissed of this point. This point has its own validity, more cost saving for us in the long run. அதனால் இது நம்ம தொடர்ந்து இது விஷயமா என்ன செய்யணுமோ ஸ்டேக்ஹோல்டர்ஸை கூப்பிடணுமோ அதை நம்ம கூப்பிடலாம். So, yes sir.
Sir, this is from Thuthukudi Medical
பசிக்கலன்னா நல்லா கேட்கலாம்.
Sir, we are registering rat killer paste under CM Health Insurance. And government is sanctioning 9,000 rupees for rat killer paste poisoning. So we have been purchasing filters under the CM Health Insurance, but the cost is around 15,000, sir. Is there any possibility of increasing this amount to 15,000?
Point well taken. 9,000 is in the CMCHS and the filters you are buying with that, but you need at least a revision up to 15,000.
15,000.
Only point is, அவரோட ஒரு single person opinion மற்றவங்க யாரை கன்கர் பண்றீங்களா? All the hands are up. Well taken, sir. We go to the last. Sir, yes.
First thing, suicide is an impulsive act. Suicidal attempt is an impulsive act. Something like பரீட்சை எழுதுற மாதிரி பாஸ் பண்றவன் செத்துறான், ஃபெயில் ஆகறவன் வந்து பழச்சிடுறான் சார். So the most of the time the poison is coming from the road sideல தான் வருது. It is not a agriculture store houseலயோ இல்லை இங்கிருந்து எடுக்கிறது இல்லை. So most of the rat all poison எங்கே வாங்குறாங்கன்னா முக்கு கடையில் தான் போய் வாங்குறாங்க. So அமேசானில் படித்தவன் தான் மேடம் போய் வாங்குறான். என்னுடைய இதை எடுத்துக்கிட்டோம்னா இது முக்கு கடையில தான் வாங்கிட்டு வர்றாங்க
சார். இது எல்லா பொட்டி கடையிலயும் விற்கிறாங்க சார். 5 ரூபாயில இருந்து 10 ரூபாய் 15 ரூபாய்.
அதை ரெடியூஸ் பண்ணணும். அது வந்து பப்ளிக் ஹெல்த் ஆக்டிவிட்டி நம்பர் 1. நம்பர் 2, வாட் எவர் இட் இஸ் செட் அண்ட் டன், some amount of N-acetylcysteine should be used at the point of contact இருந்து நம்மகிட்ட வர்றதுக்குள்ள is it possible to give, because most of the cases are 108 தான் வருது. So N-acetylcysteine may be given. See, the role definitely is there as a hepatoprotective. ஒரு பிரைமரி கேர் ஹாஸ்பிட்டலுக்கோ அல்லது வந்து செகண்டரி லெவல் ஹாஸ்பிட்டலுக்கோ அல்லது டெர்ஷரி கேர் வர்ற டைமுக்குள்ள if there is a program to give N-acetylcysteine, because it's a very harmless drug, no adverse reaction seen. So அது ஒன்று நம்ம டிசைட் பண்ணி it has to be administered at the earliest. ரெண்டாவது பாயிண்ட்
அதான் சார். மூணாவது என்ன சார்?
மூணாவது பாயிண்ட் வந்து ரிகார்டிங் த இது வந்து இந்த சிஎம்சிஹெச்எஸ்லேருந்து இந்த ரேட்டாவில் வந்து எடுத்துட்டு ஸ்டாண்ட் அலோனா எவ்ரி பேஷண்ட் காஸ்ட், ஒரு பேஷண்ட்டுக்கு 3 சைக்கிள் போட்டோம்னா கம்மிங் அரௌண்ட் 40,000 rupees பக்கம் வருதுங்க சார். ஸோ நோவேர் இட் இஸ் பீயிங் காம்பன்சேட்டட். ஸோ இது ஸ்டாண்ட் அலோன் பட்ஜெட் ஏதாவது கொடுத்தீங்கன்னா
9,000 15,000 ஒரு பாயிண்ட் நோட் பண்ணியிருக்கோம். இன்னொன்று வந்து 3 சைக்கிள் இன்க்ளூசிவா சொல்றீங்க, 40,000 சொல்றீங்க. அந்த பாயிண்ட் புரிஞ்சிச்சு.
அதுல வந்து ஸ்டாண்ட் அலோன் பட்ஜெட் கொடுத்தீங்கன்னா பெட்டரா இருக்கும்.
அதான் ஸ்டாண்ட் அலோன் பட்ஜெட் புரிஞ்சிச்சு சார். இந்த ஒரே ஒரு பாயிண்ட் மட்டும் பப்ளிக் ஹெல்த் பாயிண்ட் ஆஃப் வியூல 108ல N-acetylcysteine கொடுத்து டேமேஜை குறைக்கிற டேமேஜ் கண்ட்ரோல் மெஷர் நல்லதுன்னு சொல்றாரு. ஒப்பீனியன்ஸ்?
Sir, it is already in the guidelines, sir. The guidelines that we published, it has that NAC.
Have we implemented in 108? Yes. That's the question. The question is, it's in the guideline, I agree. Is it time for revising it to ensure that it is available in 108 ambulance?
Maybe we'll have to stress again.
இப்போ 108 ஆம்புலன்ஸ்ல இருக்கா? அது அடுத்த கேள்வி.
108ல இருக்காது சார்.
நம்ம 108 எக்ஸாம்பிள் சொல்றாரு, டிரான்சிட்ல அது கொடுக்கணும்ன்றாரு. டிரான்சிட்ல கொடுத்தாங்கன்னா டேமேஜ் குறைக்கலாம்ன்றாரு. எனக்கு புரிஞ்சிச்சு.
பிரைமரி கேர்ல கொடுத்து அனுப்ப சொல்லணும் சார்.
அதான் பிஹெச்சிலயே வைக்கணும், 108ல வைக்கணுமா?
பிஹெச்சியில் போட்டுட்டு அனுப்பலாம் சார்.
பிஹெச்சியில் வைக்கலான்றீங்க டாக்டர் விஜய் சொல்கிறாங்க, பிஹெச்சியில் வச்சு போட்டுட்டு ட்ரான்ஸ்ஃபர் பண்ணலான்றாங்க. That may be a recommendation. Everybody agrees for that?
Yes, sir.
Right. But how many cases a PHC medical officer will get per month? Anybody has got any idea on it? இப்போ ஸ்டாக்கிங் அடுத்த இஷ்யூ வந்து டு ஸ்டாக் த ட்ரக், அதுக்கு வந்து சொல்லணும். சொல்லுங்க சார். Okay. So there will be a way to calculate because it's a liver protecting thing.
Paracetamol poisoning நம்ம யூஸ் பண்ணலாம். அதனால it has a multi purpose.
So documentation அந்த பாயிண்ட் கொண்டு வரலாம். PHC-ல டாக்டர் விஜய் சொன்ன மாதிரி PHC-ல will stock it. Shall we wind up now? Sir, அப்புறம் யாரும் திட்டக்கூடாது, லஞ்ச் முடிச்சுட்டு திருப்பி வந்துடலாம். Let's start what time, Vijay? 2:15. 2:15 time hours we will be back here. Okay, thank you.
So with the sub-theme National Action Plan for Snakebite Envenomation, let's invite Dr. Ajit Shivale sir, Joint Director NAPSE, Government of India, New Delhi, to give an overview on NAPSE.
Thank you, and it's hard to get a session immediately after the lunch. So again, we'll be starting with the snake bite session, and first of all, I would like to thank Directorate of Health, Tamil Nadu, and NHM department for organizing this very important consultation on snake bite prevention and control. We always look for the states to take their own lead in terms of the health programs. And yeah. So is it okay now? Yeah. So we are thankful that states, especially like Tamil Nadu, are taking the lead in snakebite prevention and control activities in the country. Tamil Nadu is one of the first states to make it snakebite as a notifiable disease, and you have also organized the consultations today, plus the protocols and IEC materials you have already prepared and shared. So we would like that as Tamil Nadu, in terms of like you were discussing about the rodenticides poisoning, you should also lead in terms of the preparation of the state action plan and the implementation. So I will share you about the progress which we are undertaking under snakebite prevention and control program. This is very new program, just launched 2 years back. We had several consultations, and based on that, it is being implemented as a centrally sponsored scheme under NHM, and we will be shortly having a centrally sector scheme also. Next, please. And I would also like to thank our NAPSE stakeholders, National Action Plan stakeholders. Majority of them are from Tamil Nadu. Mr. Ganeshwar, the Dr. Mohan from CMC Vellore, Raghunandan sir. So the stakeholders, and Dr. Shakti is also here. So all these stakeholders are contributing for the activities across India, and if they are already part of the state team, I don't see any reason why Tamil Nadu will not be able to develop a good state action plan. So just to see you, this is just a snapshot of medically important species in the left side and the number of envenoming cases across the different countries. We can see that although India and the nearby countries like the other countries like Australia and New Zealand, they are having similar type of prevalence of medically important species, but we have large number of the envenomings. Majority because the health systems are not much that responsive enough to save the lives. Rather, the transport systems needs to be improved. So many challenges are there in terms of snakebite prevention control. How much cases really burden is in India about snakebite cases and deaths? The reported burden is very less as compared to what is actually occurring in the community. If you see the average snakebite cases as per CBHI is just 3 lakhs, and average snakebite deaths which are reported only 2,000 to 3,000. But the estimates for the deaths in snakebite just recently concluded ICMR study, they are estimating more than 40,000 deaths. The previous estimates were over 58,000 deaths annually. So 58,000 is very huge number, and that is why this issue needs to be taken very seriously. If you see the surveillance system, it has needs, we all need to report all the snakebite cases which are coming to the the health facilities. At present, it is being reported under Integrated Health Information Platform, and we are getting the line listed data on cases and deaths. And just this month, we are developing a separate dedicated website or data portal under this IHIP for snake bite, where the data of the snake bite victims, we will also align with the data which we will conduct from the snake bite rescuers apps which are developed by different people, and we can align that data about the snakes which are detected by the rescuers and the snake bite victims data, so that the timely actions we can identify the high risk areas. So that thing is under development. We have developed 2 phases of that particular data portal. Next, sorry. It's not moving. Okay. So this is just a snapshot of cases reported. Tamil Nadu, if you see, it is just after the West Bengal, Andhra Pradesh and Maharashtra. So Tamil Nadu is one of the leading state in terms of reporting of the snake bites as well as the prevalence of the snake bite cases and deaths. This is just a snapshot of what actually this left side shows cases, right side shows deaths. Just lower down you can see the Karnataka, Tamil Nadu being the highly forested, the low altitude areas, they obviously have and good reporting system, mainly that is the reason I see for reporting of the cases and deaths. What is important just to show this map is that we are just identifying high risk districts, but at state level you need to find out high risk blocks and villages. That means the blocks which are contributing to more than 50% of the cases or deaths in your particular state. And then target interventions. If you see the cases and deaths district wise, I cannot, Theni is the one of the, I hope I am pronouncing correctly. So that is the which showing highest number of deaths and cases. There are some Tirupuri and I cannot read those names, that above Krishnagiri. So these are the particular districts, but you need to go further down, drop down, and really need to find out if there are high number of cases. If some particular facility is reporting high number of cases but very no deaths, then what is the reason? Is it a reporting issue? If some facility is reporting both high number of cases and both high number of deaths, what is the reason? So there are always different reasons. I hope the epidemiologists are there in this particular group. I don't have that time, otherwise we would have discussed those different scenarios. The major issue which as a country we are facing this, only very few are actually reaching the health facilities. Most of them are seeking the traditional faith healers. So we need to sensitize these traditional faith healers, and for that you need to collaborate with the tribal health department of and the department, Panchayati Raj department. And another issue is about the poor ambulance and pre-hospital care. Very few victims reach timely. We investigated few of the deaths in Karnataka and the Madhya Pradesh. Almost out of 11 out of 15 did not reach in time. So mainly this is the one of the reason for deaths. And there is another reason that few of the victims which are bitten by range restricted species, Malabar pit viper or green pit viper, for which the current antivenom is less effective. So we have also made plan for this particular issue. You must be pleased to know that to address this issue, we have prepared a national action plan for prevention and control of snakebite envenom in India. The objective is to halve the deaths, to reduce the deaths by half by year 2030. This is as per the global action plan. India is one of the first country to launch this particular action plan. We had extensive consultation in this regard. All these ministries, especially the two ministries, Ministry of Health and Ministry of Environment, Forest, Climate Change. These are the two key ministries. Apart from other ministries, they are involved in this. And we have highlighted the roles and responsibilities of each department. This is available on NCDC website. So I forgot to mention, I am from the Center for One Health NCDC, where we work only for intersectoral coordination between medical, veterinary, forest and other sectors. So this snake bite also needs to be addressed by One Health approach. That means health sector cannot do it alone. We would require the help of Panchayati Raj, tribal health, animal husbandry and agriculture. So based on this, every state, including the state of Tamil Nadu, has to prepare a state action plan. So these are the snapshot of the meetings. So sorry, this is the budget we provide under the National Health Mission. So we provide budget for one training of medical officers, ASHA, ANMs, meetings for the health, agriculture and Panchayati Raj institutions. We request that you use digital technology whereby you can map, although we are ourselves developing a snake bite app, you can use that. And drugs ASV should be there till PSC level. I hope the program officers are all aware about these things. These are the activities we have envisaged. Two things I want to mention, that there are two key activities. One is the regional Venom Center. As I mentioned, current polyvalent antivenom is addressing only big four. So we are preparing a regional, rather strengthening the regional Venom centers as a part of central sector scheme. So those Venom centers will be located across different regions, and they will pull the venom of that snakes which are prevalent in that particular region, and the manufacturers will prepare the antivenom for those particular species so that it becomes very effective. Second thing is that any snake bite victim should receive almost the 90% of neutralizing dose, and that's why we have made mandatory that a medical officer must give 10 dose vials if he suspects the envenoming. So that is the two key points by which we can save the lives. And also we are envisaging a poison information centers across India. Fortunately for Tamil Nadu, you have the best CMC Vellore Poison Information Center, which I will be visiting tomorrow. And you can take the support of that center to develop similar centers in medical colleges or district hospitals. Next. Sorry. So these are the standard treatment guidelines. This is a protocol which must be there at all health facilities. I have seen your IEC material, which has been excellently developed with the help of your stakeholders. But we have also developed audio, films, videos, and the IEC material. This is freely available on NCDC website. You can go through it and use for the need in your community. At the national level, notification has been done in few states. Obviously, the idea is that all the snake bite cases should get reported. Unless and until we have actual burden, we will not be able to know what is to be done in which areas. So this is what we are going to each state to train the people. Most important thing is we have to investigate each and every death. We have developed a verbal autopsy form, and we can exactly find out what is the reason behind each snake bite death. If we get the reasons, we can understand what is the issue with that particular district, what is the issue with that particular PSC, that area. So what is the reason? Is it a transport issue is there? Whether victims are going to the faith healers, which faith healers, what advice they are giving. So that particular thing can be captured, and then you can direct those things. We have made a checklist of these particular things, emergency drugs, what should be there. So this checklist should be evaluated by program manager at district level and monitored, so that all these investigations, equipments and drugs should be there at PSC, CSC and district hospital level and needs to be monitored, and most neglected part is the morbidity and disability of snakebite cases. So that also has to be addressed by the district hospitals. We have framed guidelines for that. NGOs are very, very key. I think Ganeshwar Madras Crocodile Bank is one of NGOs. There are many NGOs are already working for sensitization. You need to take the help of these NGOs so that where government cannot reach, these are the flexible organizations which can reach and address this issue. So this is what I particularly request to all the stakeholders. Recently in Karnataka, we had this workshop on state action plan. So where we have called almost 28 departments just to highlight, just to frame these roles and responsibilities of different departments for snakebite prevention and control, what actual department that should do in coming 2 to 3 years, so that the role by 2030, reducing the deaths by half, can be achieved. So I request that within next few months, please organize this consultation. What needs to be done? First, you need to analyze what is actually your burden, what is the gap, where is the gap. So gaps in terms of whether people are not getting first aid, whether they are not getting ASV, or they are not reaching the health facilities timely. Then secondly, first you have to identify the sectors. What funds are there currently? You have the funds for health sector for under NHM, but whether wildlife department can support the trainings of rescuers, the snake rescuers. So these needs to be seen. And after the identification of the earmarked funds, you need to find out the burden of snakebite cases, actual burden, because this is very, very underreported, grossly underreported. Most of the deaths generally occur in the community. So need to find out the burden, which are the blocks and villages, I am again repeating, which are contributing more than 50% of deaths. These will be the high risk areas which will be targeted for trainings of the medical officers and health workers, and also the NGO participations, so that we can make it as a movement. Only then this issue of reducing the deaths by half can be achieved. So this is how we have framed the indicators. This will be part of your state action plan. This will be actually the interventions which will be undertaken in these high risk areas. Some of the issues which relate with the safe agricultural practices, because we have seen that there are particular practices like in the rainy season, if somebody is filling the gaps with the mud, those farmers are getting bitten. So you have to find out which practice in that particular village is responsible for the biting incidents. So accordingly, those practices needs to be added. And if there are issue with the availability of anti-snake venom, I think in the morning it was mentioned that there is no issue about Tamil Nadu availability, so that is a good thing. And once this action plan is prepared, then you can send it to us, we can review it, and then it can be implemented in the states based on the all expert inputs. But what is important is that if you prepare action plan, you need to have a short-term, medium-term, and long-term indicators year-wise. What I can see for Tamil Nadu is that we can have a strengthen your Venom centers which you have in as a Urula or any other center. You can expand the network of your poison information centers through CMC Vellore. Most importantly, you have good IT systems. Ensure the digitalization of the snakebite cases and deaths. Also, you have map out the hotspot where actually snakes are being rescued, especially the venomous snakes. And few of the states like Odisha, they have established a snakebite treatment centers, and they have formed a dedicated team which have been trained, especially the medicine department, emergency medicine departments, so that you can set up. So we also have a snakebite helpline 15400, where if person calls, he get to know where actually he can go for anti-snake venom treatment, or so that also can be piloted in the Tamil Nadu. So we have highlighted the role of wildlife department at the state level. So this he can use. So this is for the, I think, the different roles and responsibilities. I will not detail out because this will be covered in the state action plan workshop, which you can organize. But the take home message is that at national level, the various states are in terms of various development phases. So in terms of snake bite prevention and control, Tamil Nadu is one of the state which is having one of the highest burden. It is also leading. It has the resources, institutions, expertise, which are already working in this field. But the real need is that you need to have a structured plan. And the structured plan, you can take it based on the national action plan. At the national level, we are ready to support from the NCDC side in the whatever in terms of provision, the technical support, as well as the facilitation with the other departments of Government of India. So, and first of all, thank you for this is very importantly and timely organizing this workshop. I wish best success of this workshop, and possible constructive points and recommendations should come out of this workshop for snakebite activities, so that they can be at least be implemented by different departments, not only the health departments. So thank you.
Thank you, sir, for that very insightful presentation on NAPSA. We now go on to the next presentation by Dr. Jambugulam Mohan from CMC Vellore. He will be presenting on snakebite management, a clinical perspective.
Good afternoon, everyone. So given the limited time, I'll try to summarize all the aspects of snakebite management. It's a very vast topic, you all know that. So of the 310 species of snakes in India, 66 are venomous snakes. Of these, we know that 4 snakes are very important, also called the big 4 snakes, that contributes to major number of snake bites in India and snake bite related mortalities. So we know all these 4 snakes which are distributed across in India, every part of the state, every part of the country. So snake bites can lead to what is called a snake envenomation, snake bite leading to envenomation, which is of 3 types. So the venom can have a local effects by injuring the local tissues at the bite site, or it can cause what is called a systemic envenomation. So it can be neurotoxic envenomation where neuromuscular junctions will be involved, hemotoxic envenomation where coagulation pathway and vessel wall will be involved. Fourth type is a myotoxic envenomation where skeletal muscle fibers will be involved. So most of the clinical features will be non-specific in majority of the victims, which arise immediately after the snake bite, which are all related to the anxiety. So they can have palpitations, sweating, tremors, nausea, vomiting, abdominal pain, and various non-specific symptoms initially. So on examination, they can have tachycardia, tachypnea, elevated blood pressure, cold extremities, and sometimes paresthesias also they can present with. So mostly related to the anxiety. Next. Can also indicate complications like uremia, acute pituitary intracranial bleeds, and anaphylaxis, which may appear later. Next. So going on to the discussion about each type of envenomation, local envenomation, where local tissues will be involved secondary to the venom that is deposited. So first one is local reaction, where in this picture you can see characterized by presence of swelling, redness and warmth of the right lower limb. This is commonly seen in vipers, commonly Russell's viper and saw-scale viper and other types of vipers. Local effects are characteristically absent in crate bites. So important complication that one should look for and monitor is compartment syndrome, where patients can have intense pain, abnormal sensations, or a cold, pulseless, immobile limb, which need to be carefully monitored and managed appropriately. So the treatment mainly, which commonly followed, is administration of empirical antibiotics, Maxwell ointments, and other treatments, which are all not useful, should not be done. Most important treatment method, most important management option here is just to elevate the limb and wait and watch for compartment syndrome. Next. Next type of local envenomation is necrosis, which is also called dermonecrosis, which is early dermonecrosis, where if you carefully see, you can see faint bluish bruising at the bite site, which can easily be missed. Next. So you can see in this picture, a 42-year-old man bitten by a snake developed this early dermonecrosis, which is very, very characteristic of Indian cobra bite. And sometimes in Russell's viper also we can see, which tells you that there is a significant cytotoxins that are released that is causing local necrosis, which may worsen later. Next. So in the same patient, the early dermonecrosis has evolved on the subsequent days, and later he required surgical debridement, which is very, very typical of Indian cobra bite. Next. So next we are moving to systemic envenomation, neurotoxic envenomation. We all know that cobra bite and crate characteristically cause what is called descending symmetric neuroparalysis. Next. So where neuromuscular junction at each muscle groups will be involved in a descending manner. That means patients develop symptoms in a sequential manner, starting from head to toe. The first symptom would be, first sign would be development of ptosis involving eye movements, pupils, and followed by other neuromuscular junctions of muscle groups will be involved in a sequential manner, in a descending manner. They develop this neuroparalysis, which is very, very characteristic of this neurotoxic snake bite in India, caused by cobra and crate. Next. So in this picture you can see child with progressive descending neuroparalysis, developed muscle weakness, and you can see the broken neck sign. The neck is falling, head is falling off the bed. Next. So in this picture, next. So patients can develop ptosis to start with, then followed by diplopia, blurred vision, followed by dysarthria, drooling of saliva, dysphonia, and dysphagia, and neck, respiratory muscle weakness. Finally, limb muscle paralysis can occur. So in a descending manner, this is very, very characteristic of these syndromes. So which is characteristic caused by crates and cobras. And Russell's viper in South India alone specifically causes just a mild ptosis, which never progressed to complete neuroparalysis. So that means syndromically it's very, very clear that cobra and crate causes only neurotoxic envenomation, descending symmetric neuroparalysis. They do not cause hemotoxic envenomation, whereas vipers, Russell's viper and saw-scale viper, predominantly causes hemotoxicity. They do not cause neuroparalysis, except Russell's viper, which can cause mild ptosis. Next. So differences between cobra and crate induced neurotoxic effects that we already learned. Next. We don't have a slide mover, right? Is there? Okay. This only. Oh. Okay. Sorry. Okay. Okay, so differences between cobra and crate induced neurotoxic effects that we all know. Cobra typically affects the postsynaptic neuromuscular junction, nicotinic, postsynaptic nicotinic neuromuscular junction receptors it will involve, whereas crate affects the presynaptic neurons. That is the difference which we all should understand. So because of this, cobra bite causes early development of neurological features. In postsynaptic neuron, when it is involved, there is a complete displacement of acetylcholine from binding to the nicotinic acetylcholine receptors. So early development of neurological features can be seen, whereas in crate, presynaptic neurons will be involved. So there is a delay in causing presynaptic neural damage. So onset of symptoms also will take time. So sometimes 30 minutes to 16 hours it can take. So that is why crate bite, you don't see any local inflammation, no neurological features at the time of presentation. Sometimes it may take 12 to 16 hours to develop. So that is why all these snake bite victims should be admitted for 24 hours monitoring. Respiratory paralysis also same way. Cobra can cause early respiratory paralysis. Crate can cause delayed paralysis. Time to recovery in cobra bite, since it's only competitive inhibition at postsynaptic nicotinic acetylcholine receptors, so recovery is going to be very, very quick within 1 to 24 hours, whereas in crate bite, there is a complete damage of presynaptic neurons. So the neuronal regeneration is required to recover this neuromuscular weakness. So it takes 4 to 72 hours or much more than that sometimes. So response to neostigmine also, we know that in cobra bite, since it is a postsynaptic neurons are involved, acetylcholine levels are already adequate. By giving neostigmine and atropine, you can reverse the neuroparalysis. Whereas in crate bite, presynaptic neurons are completely damaged. There is no acetylcholine that is available. So neostigmine and atropine, there is no role in established crate bite. Next. Sorry. Okay, next moving on to the hemotoxic envenomation, which is characteristically caused by all the vipers that we have, both vipers, typical vipers and pit vipers. So they can have obvious clinical bleeds, where they can have mucosal bleeds like gingival bleeding, epistaxis, subconjunctival hemorrhages and hematuria. Skin can show evidence of petechiae, purpura and ecchymosis. And major systemic bleeds also, sometimes they can present with intracranial, intraabdominal, gastrointestinal bleeding. Sometimes they can present with subclinical coagulopathy without any evidence of bleeding, which is what we pick up by doing what is called a 20-minute whole blood clotting test. So, and also presence of derangement of other lab parameters. So coagulopathy is typically caused by vipers, and sometimes Northeast India we have red-necked keelbacks also can cause coagulopathy. So you can see in these pictures patients having obvious bleeding, gingival bleeding, ecchymosis and hematuria. So another important complication very specific for Russell's viper in South India is a developing thrombotic microangiopathy, which characteristically seen 72 hours after the bite, always overlaps or follows resolution of the coagulopathy. Once the coagulopathy is resolved, then they can develop this important complication called TMA. So clinical features, they can have pallor, jaundice, dark urine, hypertension and oliguria. Cystocytes on peripheral smears are present. You can see in this picture presence of cystocytes. Pathophysiology is unclear. Adam TS13 levels also normal in these victims. So that is why there is no role of any plasma exchange or FFP transfusion. Only supportive treatment is what advised. This is a rare complication that is only seen in patients with Russell's viper bite in South India. So next one is a myotoxic envenomation, where patients can develop muscle aches, muscle swelling, passage of dark brown urine and acute kidney injury, which is typically seen in patients bitten by sea snakes, and sometimes Russell's viper also can cause significant rhabdomyolysis. So acute kidney injury and shock also important complications secondary to the snake bite. Shock can be multifactorial, vasodilation, loss of urinary sodium and water, acute pituitary bleed, myocarditis, MI, VACC leading to significant blood loss, all can contribute to shock. Shock in turn can cause acute kidney injury, which is again caused by various other reasons. So patients who have rhabdomyolysis, that is causing myoglobin related injury, immune mediated glomerular damage, venom can directly cause kidney injury. So there are various mechanisms by acute kidney injury also can occur. So snake bite may not be a witnessed event. So painless nocturnal bites by crate, especially while sleeping on the floor, which will go unnoticed. So victims are not aware that snake bite has occurred. So sometimes these painless painful bites may be mistaken that it may be from a thorn or a sharp stone and may be ignored in the initially. Especially children while playing get bitten by, develop some pain and come and tell parents ignore it. Even doctors also ignore when they bring the children. So And children, especially later, if we ignore, they suddenly present with rapid cardiovascular collapse and unconscious state. So very, very important, any unknown bite that comes to our clinic, we should admit and monitor minimum for 12 to 24 hours. Any bite. So, and also suspect a snake bite in an endemic area, especially in our region. If anyone comes with unexplained seizures, loss of consciousness, unexplained systemic bleeding, sudden onset of cardiovascular collapse, acute flaccid paralysis, or acute kidney injury. In all these settings, please consider snake bite as a differential diagnosis, along with other differential diagnoses. Unexplained abdominal pain also. So initial management, admit all patients for at least 24 hours since envenoming can be delayed, especially in crate bite. Perform primary survey, airway, breathing, circulation, and other assay. Resuscitate and stabilize those who are unstable, and reassure those who are clinically stable. So history 7 points should be considered. Where were you bitten? When were you bitten? What were you doing when you were bitten? Where is the snake that bit you, or what did it look like? How are you feeling now? These all questions will guide you and try to understand what is the patient's status and how the snake would have looked like. So this kind of questions will help you in arriving at provisional diagnosis. Are you on any medications or recreational substances, especially anticoagulants, aspirin? Those can interfere with laboratory tests and 20-minute whole blood clotting test. And also, do you have any pre-existing cardiac or renal or health issues is very, very important, especially when we are going to consider antivenom. Antivenom reactions can lead to sudden cardiovascular collapse. So next is go on to the examination. To examine for the local envenomation, look at the tourniquet, any ligages, any wound incisions, any cauterizations, any application of herbs, all those you can look for, any blistering, bleeding, any left out fangs, snake fangs are there that we can look for. Okay, look for raised vertical tender streaks over the limb suggestive of lymphangitis. Examine for regional lymph nodes which will be enlarged due to the venom being distributed to those nodes. These are the retained fangs that are present in one of the victim, which is a case report. So next, go on to examine for systemic envenomation. Neurological envenomation, check the extraocular muscles, ptosis, pupil size, symmetry, and also assess the ability to open mouth, protrude tongue, and also look at is there any pooling of saliva in the mouth, and examine the gag reflex also. Examine muscle power and reflexes, and ask the patient to lift the neck off the bed to assess the neck flexor power. And also do these simple bedside tests to assess the neuromuscular strength. So one is single breath count, number of digits counted in one exhalation. Usually it should be more than 30. If it is less than 30, it is abnormal. Breath holding time, breath held in inspiration, which should be again more than 45 seconds. And try to see whether he is able to complete one sentence in one breath. So these parameters, bedside tests, will help you whether this patient is going to develop impending neuromuscular weakness. And examine for coagulopathy now, hemotoxic envenomation. So measure the blood pressure in a supine and seated position and check whether there is any postural drop in blood pressure. Again, that will tell you if there is a significant drop in systolic, diastolic, may tell you that patient may be bleeding into the in large cavity, so he may develop immediately shock he may develop. Examine nasal, oral cavities for mucosal bleeds. Look for subconjunctival hemorrhage, retinal bleeds and papilledema, and also look for any features of intracranial bleeding. And also examine cardiorespiratory system for any pericardial effusions or hemothorax. And examine the abdomen, look for any retroperitoneal bleed or any adrenal hematomas if there is a loin tenderness. Also examine the skin for presence of petechiae, purpurae and ecchymosis. So next is after resuscitation, after performing this survey, you do the simple bedside test that is called 20-minute whole blood clotting test, and trying to see whether patient is having coagulopathy, or also called a venom-induced consumptive coagulopathy, where you take 2 ml of venous blood, put it in a new, dry, long glass tube, keep it straight and leave it for 20 minutes. At the end of 20 minutes, then take it out and tilt it for 45 to 90 degrees and see whether the a solid clot has been formed or not. So in this picture, you can see here, the first one is blood is collected. Second picture, solid clot is formed. At the end of 20 minutes, it's a normal coagulation. There is no VICC. There is no venom-induced consumptive coagulopathy. Whereas third picture, the clot is very, very loose. It's friable. It is breaking away and coming out of the edges of the glass tube. So that tells you that there is a coagulopathy or venom-induced consumptive coagulopathy. So constructing diagnosis is very important at the end of history examination and this 20-minute WBCT, so that you can anticipate what complications this patient may develop. So if patient comes with local reaction, coagulopathy and neuroparalysis, think of Russell's viper. If local necrosis and neuroparalysis, think of Indian cobra. No local effects, only neuroparalysis, think of crate. Crate doesn't cause no hemotoxicity, no local inflammation, only neuroparalysis. Local reaction plus coagulopathy and no neuroparalysis, it could be undifferentiated viper. So this syndromic diagnosis is very important so that you can anticipate what are the complications that patient may develop and you can follow up. So treatment, the most important one is anti-snake venom. So these are the 4 standard indications to administer anti-snake venom. If anyone presents with shock, with snake bite with shock, presence of spontaneous systemic bleeding that we discussed, any type of bleeding. Third is uncoagulable blood. Those who do not have spontaneous bleeding and you have done 20-minute WVCT, which becomes positive. Fourth is presence of neurotoxicity. Any sign, any early sign, even a ptosis that you are going to pick up is an indication to consider anti-snake venom. These are the 4 standard indications that are mentioned across the guidelines. But sometimes there are certain indications like rapidly progressing local swelling. Suppose within 6 to 12 hours, if a local swelling at the wrist joint progress to involve the entire limb, and absence of other indications, you can consider anti-snake venom. So that is not a very, very hard or a standard indication that is not mentioned in guidelines. But these are the 4 that you should follow and remember when to give anti-snake venom. So initial dose always starts with 10 vials of ASV. If patient has coagulopathy, like Russell's viper or a saw-scaled viper. So treatment endpoint is you want to restore the blood to be coagulable blood. Blood should clot at the end of ASV. That is the endpoint you are going to look for. Second is if there is a patient having neuroparalysis, again start with 10 vials of ASV and the endpoint is improvement of neuroparalysis. So across all the current guidelines, this is what we are following. We are going to give it 10 vials of ASV to start with. So olden days, if you look at the standard treatment guidelines, low dose, high dose, that is there. But this is what currently followed everywhere. So try to stick to the same. How we have arrived at this 10 vials, that is all big discussion, which is a very, very estimate of, actual dose that is required. So, but across everywhere in India, this is what followed now. So 10 vials to start with. Always give intravenous, avoid IM. Don't give any other routes. Same dose for adults, children and pregnant lady. Whoever it is, the number of vials that you are going to start it is 10 vials of ASV. Repeat administration. Once you give the 10 vials of ASV, you wait for at least for 2 hours so that ASV has to act. By end of 2 hours, if patient is having still bleeding or any worsening of cardiovascular signs, then you again repeat the 10 more vials of ASV. Or if patient has come with a neuroparalysis, neurotoxic envenomation, if the neuroparalysis worsens 2 hours later, again you can give 10 more vials of ASV. So minimum time that you are going to wait for the response of ASV is 2 hours you are going to wait. If there is no response, you administer again 10 more vials. Or if the 20-minute WBCT alone was positive, but no other features, so you give 10 vials of ASV. So if only 20-minute WBCT is positive, no other features, no other indications to give ASV, you are going to wait for 6 hours, not 2 hours. 6 hours later, you are going to repeat again 20-minute WBCT. If it is still positive, you give 10 more vials of ASV. If it is negative, you are not going to administer ASV. So maximum number of anti-snake venom vials should be administered if patient has coagulopathy with neuroparalysis, that is viper envenoming, it is 30 vials. So 10 vials, 10 vials, 10 vials. If it is a prominent neuroparalysis, no hemotoxicity, maximum number of vials that you are going to give is a 20 vials, 10 and followed by 10 more. Again, this is standard across the guidelines, current guidelines that we are following in India. So always monitor for early anaphylactic reaction secondary to the ASV. So anaphylaxis is very, very important in Indian anti-snake venom that we have can contribute to 50 to 80% of the time reactions can occur based on the Sri Lankan studies and Indian studies. So it is highly, highly allergenic. So that the first reaction that can happen is a anaphylaxis which occurs within minutes, 5 to 10 minutes. So once the ASV started, doctor should not leave the patient, should stay in the ward and closely monitor for any development of these reactions. The first sign of anaphylactic reaction is developing itching, then followed by urticaria, nausea, vomiting, abdominal pain and diarrhea, life-threatening shock, bronchospasm and angioedema. At early sign itself, we should pick up and immediately give adrenaline. Do not wait for the further hypotension, shock and angioedema. Second reaction is pyrogenic reaction that can occur after 1 to 2 hours later. So fever, they can develop rigors, vasodilation, sometimes with severe hypotension, and the management is only supportive care with antipyretics and IV fluid resuscitation. So how to treat anti-snake venom related allergic reactions? These reactions can be preventable? So one is, we should know when to give ASV that we already discussed. And another important one is, whenever we see snake, sometimes common practice is just give ASV. Don't even want to see whether it is a non-venomous or a venomous snake. Don't even want to see whether this patient has a standard indications. So without these, please do not give empirically anti-snake venom, because it is a highly, highly allergenic, can lead to severe anaphylactic reactions. So these snakes, which are all non-venomous snakes that we know, sometimes can be misidentified as this venomous snakes and unnecessarily anti-snake venom being administered. So anaphylaxis, treat always earliest sign, suspend the antivenom administration immediately. IM adrenaline, most important step, 0.5 mg IM should be given. High flow oxygen, antihistamines, glucocorticoids should be given, inhaled bronchodilators, IV fluids, and anaphylaxis can recur after 12 hours later also. Sometimes it is a biphasic reaction. Again, you have to treat like a first one. So pyrogenic reaction, again, supportive care. So how can we prevent these anaphylactic reactions? One is treatment we have just discussed. How do we prevent it? So based on Sri Lankan randomized control trials, pre-medication with injection adrenaline 0.25 mg, 1:1000 dilution subcute, that is IM for the treatment of anaphylaxis. For preventing subcutaneously, if you can give 0.25 mg adrenaline, 10 to 15 minutes before administration of ASV, significantly reduce the number of anaphylactic reactions in that study. So that is why it has become a part of WHO guidelines and standard treatment current guidelines that every time when we give ASV, it has to be pre-medication has to be given with injection adrenaline alone. So no hydrocortisone, no antihistamine should be given. In that study, adding these medicine has actually reduced the efficacy of adrenaline. So adrenaline is a very, very important pre-medication to be given in every time when we administer anti-snake venom in Indian setting. So only those who have uncontrolled hypertension or recent intracranial bleed should be avoided. But most of the time, irrespective of the age, most of the time it is better to give adrenaline so that we can prevent these anaphylactic reactions. So next other treatments is a neostigminotropin, which we already discussed in patients with established cobra envenoming, unknown bite with a prominent neuroparalysis. Somebody comes with a neuroparalysis, you don't know whether it's what bite it is. You can always try with neostigminotropin. And if it is established crate, you should not give neostigminotropin because it's not going to work. So this is the dose of neostigminotropin, which we can again discuss later. So additional treatment, surgical debridement or amputation for skin grafting for significant local cytotoxic envenomation due to cobra envenoming can be considered. Fasciotomies are rarely justified. Be careful. Making a diagnosis of compartment syndrome is a very, very difficult diagnosis. We need to use a separate machine for that and measure the intra-compartmental pressure carefully. And after that only we should make the diagnosis. The problem is these patients who develop this compartment syndrome already having significant coagulopathy. If you take them for surgery, they will have a significant bleeding and which can lead to death of the patients on table. And it's very, very difficult to manage. So please be careful when you make diagnosis of compartment syndrome, and fasciotomies are very, very, very rarely justified. Those patients who have undergone these fasciotomies, most of the time surgeons were involved, not the medical team. Surgeons tend to make the diagnosis quickly that it's a compartment syndrome and tend to take up them for surgery. But remember, these patients can have a significant bleeding that can be detrimental to the patients. So nowadays, fasciotomies are not done at all because compartment syndrome diagnosis itself is not properly made. So the final one, pre-hospital care. Before even patient reaches the hospital, what to be done? So universally approved elements is, one is once a patient is bitten by snake, reassure the victim. So that will slows down the heart rate, reduces the venom spread, immobilize the victim of the limb, either a upper limb or lower limb, put a splint both the sides gently tight and immobilize it. Again, it slows the venom spread. Remove the rings or bangles that are there around the bite site. Prevents the tourniquet effect. Next is avoid interference with the bite wound. So basically by trying to cut it, trying to suck it, application of herbs should not be done, which can prevent again infection and increase the venom absorption or increase bleeding. But there are some practices that have tried other parts of the country like pressure bandage immobilization, pressure pad immobilization, which are not, one is practically it is not possible for our country, and even the evidence also, the quality of evidence also very, very low. So hence we do not follow other methods of pre-hospital care to reduce the spread of the venom. So tourniquet, these are the other hazardous first aid practices that are still being followed in various parts of the country. Like 90 to 98% of the South Asian snakebite victims still use sometimes tourniquets, associated with the risk of severe local damage including ischemia, necrosis and gangrene. And making local incisions at the site of the bite, attempts to suck the venom, use of snake stones, and topical installation of chemicals, herbs and animal excrement should be avoided. So most important one as part of pre-hospital care is immediate transport to the hospital, which is very, very important. That has been studied in various parts of the world, especially in Nepal. They have studied where by using what is called motor vehicle assisted volunteers. So volunteers having motorbike have carried these victims of snake bites and reached hospital immediately, where timely administration of ASV was done. So they compared before usage of these motorbikes and after usage of motorbikes to see the number of deaths due to the snake bite. So in that, there is a significant reduction in the snake bite mortality. So before that, they had 10.5% of case fatality rate to the snake bite. But after introduction of these motorbikes, volunteers, it became 0.5% case fatality rate. Okay, so final one is referral mechanisms. Once you see at a community level small hospital, before referring, you have to ensure that certain things are done. One is, if someone has shock or hypotension, unrespond to the fluids, if it is a small center, please refer. Flaccid quadriparesis with respiratory failure requiring ventilatory care, you have to refer. If there is a severe local necrosis or signs suggestive of compartment syndrome, you should plan to refer the victim to the highest center. If the requirement of ASV is high, 20-minute WBCT is still positive and you have already given enough dose of ASV, 30 vials, then again it's better to refer to highest center. Persistent bleeding after giving adequate amount of ASV, still you have to refer. Or if there is a progressive paralysis or respiratory difficulty where he needs a ventilator support, you have to refer. Any development of complications like kidney injury with reduced urine output, signs of cerebrovascular accident, coronary syndrome, and any anaphylaxis that is not responding to the adrenaline, repeated dose of adrenaline, anaphylaxis is not responding, it's better to refer. So these are the instructions that to be followed. Inform the patient, inform the hospital doctor who is going to receive, give a proper referral letter and send them. And if you have already started ASV, complete the ASV, then only refer the victim. Do not start the ASV and refer, because on the way you can develop severe anaphylactic reactions which can become very difficult to manage. Always stabilize vital parameters before referring. Arrange ambulance. Don't send it in a two-wheeler or other modes. Better to arrange an ambulance, and preferably with the presence of a healthcare worker. Put him in a left lateral recovery position so that he will not aspirate. Continue the other supports while referring the patient. Okay, finally, outpatient review. Once you manage and when they come for follow-up, monitor for late antivenom reactions which can occur 1 to 2 weeks later, which can be managed with antihistamines and steroids, low-dose steroids. These are the complications they can have on an outpatient basis on long-term musculoskeletal, neuropsychological, renal and endocrine. So one patient has developed persistent hand pain, which we made a diagnosis of inflammatory flexor tenosynovitis. So important one is they can have musculoskeletal, second is psychological. A lot of patients go into depression, post-traumatic stress disorder. So very, very important to address that problem and try to get a psychiatry evaluation also. Endocrine problems, like they can have a late onset chronic pituitary insufficiency sometime because of the pituitary bleed. So those are the things. Sometimes they can go into chronic kidney disease also, that also need to be monitored. Okay, just to summarize, bites from venomous snakes can result in bleeding, paralysis, long-term disability and death. Remember, 20-minute WBCT is a simple bedside test to screen for and monitor coagulopathy, assess vital parameters and initiate resuscitation measures if the patient is clinically unstable with signs of bleeding, shock, paralysis or respiratory distress. Intravenous antivenom is recommended in patients with those indications that I have mentioned. So these are my references. So the last point is, I work in this CMC Poison Information Center. Just to tell you that poison centers can play an important role in guiding public and doctors also in terms of related to snake bite, in terms of identification of the snakes, in terms of what are the indications of giving ASV, and any complications related to the snake bite management can be addressed and guidance can be obtained from poison centers. So this is our number, toll-free number. Anyone interested while managing, you can always call this number. Thank you for patient listening.
So thank you, sir, for the detailed presentation. So since we are running short of time, we'll start with the panel discussion on case studies. So I welcome our moderator, Professor Dr. C. Radhendran, to invite the panelists and presenters from HODs of General Medicine, Pudukkottai Medical College Hospital, Tirunelveli Medical Hospital and Tirunelveli. In the meantime, if the presenters not submitted the PPT, can submit the PPT for presentation.
Good evening. We are running short of time. So I request the panelists to come to the stage. Professor Balamurugan, Professor Namita and Professor V. Rajendran. And also the case studies presented by the HODs of Pudukkottai, Tanjavur or Tirunelveli? Tirunelveli and Dindigul. Please. So it is only a kind of their experiences. Please come. Any bite until otherwise proved should be regarded as a venomous snake bite. With that introduction, I call your name, sir?
Dr. Joseph.
Dr. Joseph.
A very good afternoon, one and all. On behalf of General Medicine Department, Pudukkottai Medical College, I am here to share our experience in the snake bite management. Slide, please. Yes, next slide, please. Yeah. It's the statistics in Government Pudukkottai Medical College. This is the last 6 months statistics. So the male patients are totally 148 and female patients 93, of which only 2 deaths occurred. So both are neurotoxic snake bite, and the patients came late presentation, caused the death of the patients. So during rainy seasons, the number of cases were high compared to the January, February, March. The case loads are relatively less. So you have selected 2 cases for presentation that were saved by our medical team in Pudukkottai Medical College. Next slide, please. The first one, so 13-year-old boy referred from nearby GH on November 1st, 2024 with alleged history of snake bite over right leg at 9:20 a.m. for further management to our Pudukkottai Medical College Hospital. On arrival, patient arrived at 11 o'clock in the morning. So on arrival, the patient was conscious, oriented, and bite marks present. He had local swelling and tenderness, abdominal pain and vomiting present, but no history of bleeding manifestations or no regional lymphadenopathy noted. So vitals were normal and on arrival. Next slide, please. So we checked WBCT. It was more than 20 minutes on arrival. So 8 vials of ASV was started immediately, and the WBCT remained prolonged even after 6 hours of administration of ASV, and cellulitis is also progressing. So another 10 vials of ASV was administered to neutralize the venom and to arrest the progression of cellulitis. And the patient had prolonged PT and APTT, both are more than 2 minutes on admission, but the renal parameters were normal. Urea is 25 and creatinine 0.9 on admission. Next slide. The next day, the patient developed acute renal dysfunction. Urea from 25 to rise to 251 and creatinine from 0.9 to 4.3. So the acute rise in renal parameters within a day, and urine output significantly decreased, and his parents were informed about the need for renal replacement therapy, but initially they were very hesitant to accept hemodialysis, but later on after repeated advice, so they gave the consent for hemodialysis. Next. So from 4th to 10th, the patient underwent 5 cycles of HD, and then renal parameters were started falling. In the meantime, patient developed severe anemia. So on admission, his hemoglobin was 13.5, and it is decreased to 4.8, and the next day, so 3.8. So severe decrease in hemoglobin, and patient developed thrombocytopenia also from 2.5 lakhs to 55,000, and the LDH levels are very high, and serum fibrinogen levels is reduced, and there's a mild increase in hepatic parameters, liver enzymes also noted. So the venom-induced consumption coagulopathy and thrombotic microangiopathy was suspected based on this clinical laboratory parameters. Next slide. So the RFT started improving from 10/4/2024. That means after the completion of 5 cycles of HD, so the renal parameters were started improving, and the hemoglobin also started to rise. The supportive measures continued along with the broad spectrum antibiotics and packed cell transfusion. When you have severe anemia, so we gave on packed cell transfusion also. But peripheral smear showed microcytic hypochromic anemia with the eosinophilia. Actually, no cystocytes seen. Next. The USG abdomen was done on the prior to hemodialysis. It showed grade 2 MRD with a minimal ascites, and patient showed signs of improvement from 11/11. And appetite and urine output, all the parameters, including RFT and CBC, improved, and the urine output became normal by 13th, and cellulitis almost subsided on 17th. So the patient was discharged on 18/11/2024 with the urea of 41 and serum creatinine of 1.3. Almost all the parameters come to normal. Next slide, please. So the diagnosis was poisonous snake bite with a hematotoxicity, acute kidney injury, thrombotic microangiopathy, query venom-induced consumption coagulopathy was made. Next. So treatment, totally 18 vials of ASV administered. Initially we gave 8 vials, followed by 10 vials, and 4 units of FFP also transfused. because patient had prolonged PT and APDT on admission, which became normal after FFA infusion. So the 5 cycles of HD performed, 1 unit of packed cell and broad spectrum antibiotic and supportive care given. Next slide, please. So with the continuous care and appropriate management, the 13-year-old boy was saved from multiple lethal complications, so likely Russell Viper bites. This is an investigation chart. So this abnormal values are in the red in color. So the hemoglobin from on admission it is 13.5. It's fallen to 4.8, 3.8. Then it started improving after some time. On discharge, the HB rose to 9.8. And this urea creatinine also became normal after the initial rise. And this sodium potassium, so the potassium, so maximum 5.4, it also became normal after hemodialysis. And the PT APDT also became normal. Next slide, please. This other investigations done. Next. This the boy was saved by the timely management. So next slide, next. We move on to the next case. This is a 40-year-old female patient, again referred from the nearby GH, Arandangi GH, with the alleged history of unknown bite over left foot on 19/3/2025, that means last month, around 3 a.m. at her home. It's a typical crate bite, early morning bite. So she had a difficulty in breathing and drooping of eyelids and difficulty in swallowing, and patient was taken to Arandangi GH. So in view of respiratory distress, patient was intubated there itself and referred to Pudukkottai Medical College Hospital for further management. So on examination, patient arrived at 6:30 a.m. in the morning. So patient was drowsy and she was connected to ventilator, already intubated in Arandangi GH. She was connected to the ventilator. GCS was 10/15 and the vitals were relatively stable and SpO2 is 100 on endotracheal tube. She had ptosis and pupil size is normal and reacting to light on either side. And she had left foot swelling, tenderness and warmth plus, and other system examinations were normal. Next. So the diagnosis made was the unknown bite, so probable neurotoxic snake bite with the respiratory distress, and she had left foot cellulitis also. The investigations, so serial WBCD monitoring was done, so it showed less than 20 minutes, not even a single value was more than 20 minutes, and random sugar is normal, and the serial RFT, LFT and CBC values also normal, coagulation profile, electrolytes, ECG and chest X-ray all were normal on admission. Next slide, please. So the mechanical ventilation was continued and the ASP 30 vials given totally. 10 vials was given in Arandangi GH. The remaining 20 vials completed in Pudukkottai Medical College Hospital. And a neostigmine and atropine as per the protocol is given. So antibiotics and supporting aids also are given. Next. So the patient was slowly weaned off from the ventilator. On the third day, she was extubated and cellulitis gradually subsided, and the patient was discharged on 24th, that is day 5 after complete recovery. Next slide, please. So the take-home message is, in patients with unknown bites, either unknown bite or snake bite, with a neuroparalysis or respiratory distress, so the early administration is a key here. Early administration and timely intubation and mechanical ventilation is crucial for better outcome. So we should not wait for 6 hours for next dose of ASP in case of neuroparalysis. As soon as possible, so we have to repeat the ASP dosage with the timely intubation and mechanical ventilation. So is crucial for better outcome. So thank you for the opportunity.
Is it a crate or a cobra?
So it looks like a crate, sir, but local patient had local cellulitis also, sir.
Was there any indigenous way of giving first aid in the house?
No, sir. So patient was taken to Arandangi GH. So from there they intubated the patient and they referred to, so within 2 hours patient arrived to the GH. Sir.
So in the first case, why don't we have tried post-alkaline diuresis, sir? That's the one method that you can adopt because we can prevent the hemodialysis by using post-alkaline diuresis at very early stages. Because the first value was very normal, the second day the value gone up very high.
Yes, sir.
I don't know why it's gone up tenfold
sir,
rise.
it's a sudden
That's,
rise, yes, sir.
That's the one. Is there any decrease, significant drop in the urine output during the 24 hours? If
Yes,
it
sir.
is so,
Yes, sir. Urine output is also decreasing.
so why don't we try the forced alkaline diuresis? That is in the protocol of National Snakebite Protocol treatment. The forced alkaline diuresis can prevent the hemodialysis.
Yes, sir.
That we can.
Yes,
That's the one thing that we can think it of here, sir. And definitely this is an VLCC only because it is an acute onset and more in favor of an thrombotic microangiopathy because you said there is a lot of cystocytes are present in the peripheral smear study. So the possibility for thrombotic microangiopathy, VLCC is much more than the DAC here. So we promptly
Actually, no bleeding manifestations. Actually, no bleeding manifestation. But because of the laboratory parameters, we made the diagnosis.
Yes, sir. Yes, sir. But only the forced alkaline diuresis would have been tried. So we can prevented all those other complications. We could have.
Sir, interesting case presentations and nice management, sir. I just wanted to know why the first case, 18 vials of ASV was given.
Yes, sir. Initially, the duty team gave 8 vials, madam. So followed by 10 vials. So the 10 vials should have been given on admission itself. Actually, no bleeding, sir. Sir, we took ultrasound abdomen, sir. It showed no bleeding. Maybe because of, could be because of gastritis or something, sir.
Sir, actually that case, the thrombotic microangiopathy, the nephrologist only decided. We asked for I was the professor there when so that case actually. So we asked for the alkaline diuresis only. He said, I think he will not respond, and that was his answer. And abdominal pain, he said that whenever abdominal pain is presenting, he said the many cases go to renal failure. He doesn't know the reason. He said even acute tubular necrosis would have happened. But that case progressed very fast, worsened fast, and after 5 years he recovered fast. And
we had last week we had in our college patient similarly presented this. The second day itself the patient went for a drop in urine output, and then the platelet count was dropping to 50,000 and other things. So we started on forced alkaline diuresis vigorously. The patient responded very well. We've avoided the hemodialysis. So the first thing, that is very important is the early you start a forced alkaline diuresis, you can prevent the hemodialysis. That's very important. So you should expect to start a forced alkaline diuresis in a patient who is not passing urine. That's a key information that you must take, because that can prevent the costliest or more adventurous, more dangerous possible complications can be avoided with hemodialysis. You can stop it at any time. You can stop the forced alkaline diuresis at any time. The patient is not passing adequate urine, we can stop it and you can further proceed to the conventional hemodialysis. There is nothing wrong in it. It is not that we should not go for a hemodialysis. Attempt here, successful, it's good for the patient.
Yes, sir.
And then the second, this one, why the 30 vials again given? I think this is a standardized protocol we must proceed. Whatever it is, because this can lead into possibility of anti-sine qua non serum sickness like illness. It can go for encephalitis, encephalomyelitis, and all other complications can develop if we give overdosing of anti-sine qua non. The second dose is a neurotoxic snake bite. They have given 30 vials of ASB has been given.
So
the first case is the vascular one. They are given less dose of ASB.
So actually, it's a very common practice in periphery colleges to give more ASV in case of neurotoxic snake bite, sir. But hereafter,
yes, that's only eye opener.
That is the very purpose of this meeting, this workshop, to reach a uniformity in the management. So, well done, sir. Thank you.
Thank you,
So
sir.
we learn by our experience, our errors, and our discussions. Thank you.
Thank you, sir. Thank you very much, sir. Yes, sir. Yes, sir.
Yeah, so there is one study being done in our Institute of Nephrology at MMC. They are following all the patients who have undergone dialysis. So maybe whether they're prone for any chronic kidney disease also later. It's long-term study. So I just request that young boy, is.
Yes, sir.
Yeah, so you can just follow him up. Thank you.
Sure, sir.
Thank you, sir. Please come. Professor Ratan Kumar from Tirunelveli Medical.
Good afternoon to everyone, respected panelists. So I am presenting an interesting case of snake bite from Tirunelveli Medical College Hospital. As told by the previous speaker, in neurotoxic snake bite we usually see descending type of paralysis from ptosis to respiratory paralysis leading on to intubation. Or we have presented some cases of coagulopathy producing intracerebral hemorrhage and stroke-like picture. We have also presented infarct following snake bite due to vasculitis. It is quite different case. Next slide, please. Name Priya, age 28, self-employed from Sangarankoil. Next slide. The patient went to Sangarankoil GH with alleged history of snake bite, cobra bite, over left foot around 8:30 p.m. near her residence on 25/3/2025. The patient developed complaints of giddiness, difficulty in breathing and blurring of vision on her way to hospital. On arrival at Sangarankoil GH, the patient suddenly lost consciousness and was intubated in view of impending respiratory failure and was given 20 vials of ASV and 2 doses of atropine and neostigmine, following which she was referred to TVMCH for further management. Next slide. The patient received in TVMCH in intubated state around 11:40 p.m. with left lower limb cellulitis and ptosis. On arrival, the patient had no history of weakness of limbs, no history of seizures, and no history of bleeding from the nasal mucosa or from this bite site. The patient was awake on medical ventilation and obeys commands and afebrile. BP was 100/60, pulse was 97, SpO2 was 99, and whole blood clotting time was less than 20 minutes. Cardiovascular respiratory system was normal. She was awake and obeyed commands and moves all the 4 limbs and cellulitis present up to middle 1/3 of the left leg. In view of progressing cellulitis, further 10 vials of ASV was given. The improvement was observed after 3 doses of atropine and neostigmine, which was subsequently tapered. On the day 2, the patient was extubated and respiratory efforts were normal. After that, the patient was kept in observation in IMCU. Later, she shifted to M2 medicine ward on day 5, following which the patient presented with bilateral upper limb weakness on the day 7 in the form of difficulty in holding objects, mixing up of the food and combing the hair, which was not associated with respiratory difficulty or fever or bleeding manifestation. Next slide. No history of sensory disturbance, no history of fever, trauma, or memory disturbance, or loss of consciousness, or behavioral disturbance, sleep disturbance, hallucination, or no history of abdominal pain, palpitation, headache, projectile vomiting. Next slide. No history of slipping while walking, no history of tripping over toes while walking, no history of difficulty in toe walking, no history of difficulty in clearing the obstacles on the ground, no history of buckling of knees while walking, no history of difficulty in getting up from the squatting posture, no history of difficulty in getting up from the chair, no history of difficulty in climbing upstairs and downstairs. There were no history suggestive of lower limb weakness. Next. No history of hard of hearing or difficulty in swallowing, choking spells, or hoarseness of voice, nasal regurgitation, or difficulty in turning the head, difficulty in rolling over the tongue. Next. Able to feel the bladder sensation, able to initiate the maturation, no history of frequency of maturation or incomplete bladder emptying, no history of any interrupted stream of urine, no history of bowel incontinence, no history of abnormal sweating, dryness of the skin. Next slide, please. Not a known case of diabetes, hypertension, or bronchial asthma, no history of chronic steroid abuse, no past history of any illness. Next slide. Personal history was quite normal and family history not relevant. Menstrual history not married, menarche at 14 years, last menstrual period 18-3, no history of menorrhagia or dysmenorrhea. Next is general examination. She was moderately built and nourished, no fasciculation, no external markers for syphilis, HIV, tuberculosis, no peripheral nerve thickening, no neuromuscular, neurocutaneous markers. Next slide. Local examination, swelling and tenderness were present over lower one-third of the left leg. Warmth was present, no regional lymphadenopathy. Next. Next slide. Pulse was normal. Next. Blood pressure was normal. Temperature JVP not elevated. Respiration was quite normal. Next. Higher mental functions were completely normal. Next. Cranial nerves, first, second, third nerve were normal. Next. Fifth nerve, seventh, sixth nerve, seventh nerve, and eighth nerve normal. Next. Ninth, 10th, 11th nerve, 12th nerve also normal. Next. Spinomotor system. Arm, there is no weakness, no small muscle wasting. Next. Upper limb, right and left hypotonia, and lower limb normal. Next. The shoulder joint, the power was all the movements, abduction, adduction, flexion, extension, internal rotation, external rotation were 4/5 on right side, left side 3/5. And elbow joint also and wrist joint 3/5 on the right side and left side 2/5. And finger grip, hand grip is 20% only. Next. Lower limb, the power was completely normal. Next. All the reflexes were present. Plantar was flexor. Deep tendon reflexes, biceps, triceps present. Knee jerk 2+, ankle jerk also 2+. Next. Finger nose test not able to perform in the upper limb, but lower limb coordination was normal. Next. Sensory system was completely normal, including cortical sensation. Next. No signs of meningeal irritation, spine and cranium abnormality. Next. Other system examination normal. Next.
Anything positive, please highlight on that.
Blood count analysis normal. Next. So urea creatinine and electrolytes normal. Next. And the liver function also serially normal. Next. Urine analysis also normal. CPK was 1748. Next. Coagulation profile was also normal. Next. This is the X-ray chest. Next. This is the ECG. Next. So we were quite confused where we could fix the lesion. This is not vasculitis that causes a stroke, or it is not a hemorrhage, intracerebral hemorrhage. Patient was completely all right. Only bilateral upper limb weakness where we could fix the lesion. And this case was actually kept in the exam. Balamurugan sir knows. And the final MBBS student told all the finding correctly. And we ordered for MRI immediately. MRI showed. Next. Next. So it is a toxin-induced leukoencephalopathy. Then we went for the so many references in the journals. Next. A nerve conduction study, polyradiculosensory motor demyelinating neuropathy with secondary axonal neuropathy, predominantly brachial neuropathy. That explains all the above features. Next. She was treated with methylprednisolone pulse therapy for 3 days and completely recovered and discharged. Next. The patient is currently on prednisolone 5 milligram. That was 8 milligram, 8 into 5, 40 milligram on the time of discharge. Then it was tapered and rapid improvement. Next. These are some of the articles showing acute demyelinating polyradiculoneuropathy following the snake bite. So when following any toxin exposure, when we are not able to fix the lesion at any point of time, it's cortical or subcortical or brainstem or cerebellum or spinal cord or radicals or anterior console or muscle or neuromuscular junction, the most common thing we have to think is leukoencephalopathy. It can be quite common following methotrexate and also cyclosporine, 5-fluorouracil and other chemotherapeutic agents, and also heroin-induced encephalopathy is very much reported, and a few cases of snake bite-induced toxic leukoencephalopathy is reported. So I thought when Balamurugan sir asked me to present, it will be nice. Thank you, sir. Next slide. This is another case report. Next slide. Thank you, sir.
Well done, well done, well done. We just listened to a thorough MD General Medicine internal examination.
Thank you,
So
sir.
clear.
So the CSF
CSF we have not done, sir, because one reason is patient drastically improved. So at the time of the weakness also, she was quite conscious and recovered completely from the respiratory paralysis. So the parents were not willing for CSF analysis. Now conduction study polyradiculoneuropathy, mainly involving brachial plex. Thank you, sir.
Can it be a snake venom induced serum sickness induced sometimes the encephalomyelitis can be a feature of both venom as well as the serum sickness, excessive dose of venom can induce.
Yes, sir. The
Is
report.
it
So when we go through the literature, it has been clearly mentioned as sir told, but I have not mentioned because both toxin as well as the drug per se, ASV, can produce.
Before going for a full-fledged immunosuppressants like steroids and other things, I think it's better to do a CSF analysis and rule out other infections before going for a full-fledged immunomodulation
The
therapy.
patient's attenders were not completely
Sometimes
willing.
it is concurrent tuberculosis meningitis or something else.
Yes,
Will
sir,
be
but
going on
she's on close follow-up, sir. We will convince and do to rule out other
But
infections.
it is on protocol wise, I think it's better to go for a CSF analysis at least to proceed before going for such a massive immunosuppressant therapy because it can worsen the scenario altogether. So of course, the local arrangement with the patient attenders and I think that is a different. But something goes wrong, if they ask us, we cannot answer anything. So as per the protocol, we should go for a CSF analysis and rule out other possible infective etiologies before going for the suppression. That will be better one.
Thank you, sir. Thank you, sir.
Thank you. Please come.
can be presented, sir.
I will call Professor Rajkumar from Dindigul Medical College. Well done.
Good afternoon and good evening to all of you. And the previous two presentations from Pudukkottai and Tirunelveli, they presented positive examples, but I am going to present a negative example. And number two, there was a detailed presentation from Tirunelveli, and my presentation will be very short. I hope you will appreciate, all of you appreciate me. Next slide, please. So this is the census in our college 2024. Total cases 718, out of which 3 patients expired. One from hemotoxicity, another one from neurotoxicity, the third one from acute renal failure, AKI. Next slide. This year census from January to March, total cases admitted were 135, one case expired, neurotoxic snake bite, and I am going to present this case only. All of these cases were managed in our medical college without a nephrologist. So this is a snake bite case study from our college. Next. 14-year-old female admitted at the time of 8:45 a.m. Time of bite was 4:30. There was a delay of 4 hours before reaching the hospital. And she presented with breathlessness and partial ptosis. Next. A neurotoxic snake bite diagnosis was made. Emergency management was given using anti-snake venom. 20 vials administered, 10 vials 1 hour, at 1 hour interval. There was no adverse reactions to anti-snake venom. And the supportive measures were also given, neostigmine preceded by atropine, and she was intubated because of worsening neurological status. Next. And the clinical course of the patient, on day 1 there was some improvement with the ASV and neostigmine, atropine, etc. But on day 3 suddenly she deteriorated and succumbed to refractory hypoxia despite timely intervention and protocol adherence. So we do not know why the patient suddenly deteriorated and expired on day 3. So these could be the possibilities. Next slide. So some antivenom may not work against some of the snakes. The previous one. Previous slide. So there may be some geographical variation in venom and antivenom properties. Next slide. And toxin kinetics. There may be some possibility of delayed release of the toxins. Some patients may develop a delayed or occult coagulopathy or neurotoxicity. And in this patient, only one possibility, the patient came 4 hours after bite. That was the only thing we made. But in spite of that, we followed the conventional treatment protocol. And as I promised earlier, I conclude my presentation.
Thank you. Can this be due to some endotracheal tube block? Common things are commoner.
Yes, sir. But patient was treated in IMCU, but there was no signs suggestive of any tube-related problems, sir.
Right. Because the patient who was on intubation and mechanical ventilator support and they adequately given ASV, why she should deteriorate and die?
Still possible, sir.
Possible, possible.
Sir, can you just tell me whether patient came directly to your hospital or did he go to any primary care somewhere? How was a patient presented to your hospital?
Patient was not taken to any private hospital or any other peripheral hospitals. They did not apply any traditional methods.
So they came directly from home to your
Yes,
hospital?
sir.
Because that is one of the problem in crate, they bite painless in the night, so we may not even know the time of bite. Morning only they recognize they got some weakness, something like that. So that's, you're talking about the delay in arrival, not only
Yes,
in
sir.
arrival, because recognition itself may
Yes,
be
sir. The time of bite was at around 4:30 a.m. and she went to sleep. And probably there might be a delayed recognition of the symptoms.
No, she knows that it was bitten and she went to sleep.
No, sir.
She's not aware.
Yes, sir. Early morning snake bite is
No, that
almost
is
always.
what, but yeah, right, yeah. Okay.
Bleeding manifestations plus with neurotoxic features. Initially, I exactly remember one particular case where the lady went for plucking some flowers. She was not aware that she was bitten by a snake. She thought it was a thorn prick. She was brought to the hospital around 4 hours later, around 11 o'clock. While she was brought, she was having some dizziness. That was the initial complaint. But there was ptosis. When we were examining, we found that there was some bleeding from the gums. she had both features of both chemotoxic as well as neurotoxic. Later on, we found that it was a case of crite. It is present certain particular type of snake variety is present in that locality where it is presenting with such features. And our ASV is not effective. Thank you.
So, but one thing that is on both the cases, Tirunelveli and here, why the acetylcholine is given when after intubation, sir? Is it only adjuvant therapy? It is not a therapy to improve, or does not improve the outcome also. I think acetylcholine can be used as a tool. Suppose in case we are not able to intubate the patient to prolong, sometimes take some time for you to go. That time you can give an acetylcholine. Otherwise, once intubated, giving an acetylcholine, sometimes the patient, there is a mistake that every dose of neostigmine was administered along with one dose of atropine was given. That is not the correct. I mean, this is only for discussion, sir, not for this one. That is also not the right way of giving the neostigmine with atropine. I know. It's a whole fuss. It is not for a particular one. So there is no need for a neostigmine to be administered after intubating the patient, because the
that too, especially when you are suspecting treating it as a crate.
Crate, yes. And another thing here, sir, there is no other complication. The myocarditis and other possible complications should also be kept in mind. We always think that only the respiratory paralysis is the only cause for that. Sometimes the myocarditis, we have seen a lot of myocarditis suddenly going for a pulmonary edema and going for an arrest. So these sort of echo, cardiac evaluation also sometimes throw lights on what type of possibilities. So these are to think in your mind, not only respiratory cause, the myocarditis is also very, very important forerunner for a sudden death in snake bite patients.
Yes, so the lesson is we have to be very careful when you give neostigmine and atropine.
Yes, sir.
Any patient where it is indicated also. When you have the patient on intubation done, there is no necessity, number one. Number two, it could have caused excessive cholinergic crisis and excessive pulmonary congestion, a non-cardiogenic pulmonary edema, and blocked the tube. That's where I raised this doubt. Right, sir. Thank you.
Thank you, sir.
Thank you, sir. It was an interesting, short and sweet discussion, as you promised. So, all three colleges, I think they have presented very well, and the take-home would be, we would start with 10 vials ASV start, and if your WBCT is more than 20 minutes, do it again repeat again after 6 hours, because when I went to Chengalpet Medical College, I did notice that PGs were giving, one WBCT was more than 20, and then they were giving 30 vials at a stretch. I was very surprised. I was asking them why at a stretch at emergency medicine.
Not more than 10 vials at a time. So let that be the carry home message.
So I think with this, I think we thank the NHM for this wonderful opportunity of bringing all of us together, and thank you, Lydia, especially for that. And
thank you, madam. Thank all the participants, panelists, and the professors.
We'll end this session and we'll move on to the next session.
Thank you, ma'am. Thank you. I call upon the next panelist and the moderator. Our moderator will be Professor Dr. Raghunandanan, sir. I request sir to kindly call the panelist and start the discussion, please.
Good evening. We'll start the next panel discussion. I think coffee and snacks are being served inside the hall, so we can continue our panel discussion. I request Dr. Ramesh, professor from now Stanley Medical College, Professor Sendil Kumar from Stanley Medical College, and Dr. Mohan from CMC Vellore. And we have got case studies from 3 institutions. First, I request Professor of Medicine from Salem Medical College, Professor of Medicine, Dharmaburi Medical College, and Professor of Medicine from Karur College to come to the dais. So please. Good. No. Okay, you are the panelist. Here the speakers are sitting. So I request HOD sir from Salem Medical College. We are going to have some interesting different aspects of snake bite management. I hope we'll be getting some interesting cases from the institutions.
Good morning. Good
And
evening
if
to
there's
all.
any question from the audience also, we'll be welcome, most welcome. Yes, sir.
Good evening to all. My presentation is similar to our Pudukkottai presentation. So, next slide. So, snake bite discussion from Government Mohan Kumar Medical College, Salem. As our TAI initiative, our incidence of snake bite deaths are reduced. Yes, already pointed out by the previous speakers, almost all the periphery government hospitals and hospitals, they are giving anti-snake venom, but not up to the adequate dose. Still, we are facing the problem. Last year, we arranged a snake bite and poisoning management classes by the TAI Center through all the medical officers. I think we can arrange some follow-up studies also for this year also. Next slide. So this 56-year-old male admitted in the Namakkal Government Medical College Hospital on 13/4/25 at 9 p.m. in view of unknown bite around 11:15 a.m. near his residence. Site left upper limb ring finger with swelling and pain. Whole blood clotting time was more than 20 minutes and he was given 10 ASV vials. Followed that he developed hematuria and again he was given 10 ASV vials as per the protocol. But in the subsequent events, he developed a decreased urine output and acute renal failure of 46, urea 46 and creatinine 2.8. The patient was referred to Salem Medical College next day, 2:15 p.m. in view of the swelling, persistent swelling with multiple episodes of vomiting with the features of hematuria and elevated renal parameters. Next slide. The past history, patient doesn't have any comorbid illness. The general examination was normal. RS only, the few scattered crabs and the vitals are stable. And at the receiving time, the whole blood clotting time are 20 minutes, less than 20 minutes, but he has a cellulitis along with hematuria with a decreased urine output. Next slide. So this presented at the time, the total count was elevated, INR was elevated 1.82, urea 85 and creatinine 5.3. So he is having acute renal failure with less platelet count and increased total count. Next slide. So these are all the serial evaluation. The hemoglobin was 10.3 to 8.7, 7.5, 6.8, 6.3, 6.8, 8.3. The peripheral smear study done was normal. Total count was, initially it was 14,400. Now it was 8,800. The platelet count started from 0.59 to, now it is increased to 1.33. The urea creatinine was steadily declining, steadily increasing 85.5.3 to 195. And the creatinine value was 9.3. Next slide. So the patient was, after receiving, we gave another 10 vials of ASV in view of hematuria, and the ASV, with the ASV, the nephrologist opinion obtained and the first cycle of hemodialysis was done. Subsequently, next day, in view of persistent hematuria, we gave 4 units of FFP. Since the 30 vials of ASV is given, so the urine output was only 100 ml. He underwent second cycle on next day, 16th. And subsequently, so far he went 5 cycles of hemodialysis. And now, day before yesterday, the urine output was steadily increasing and he is having clear urine. But the creatinine value was still, it was high, 8.9 only. It was shown by the previous slide. Next slide. So the investigation which shows 15/4 urine albumin 3+ and RBCs was done. Urine albumin, subsequently the RBCs shown 17th also 5 to 6. Blood culture, growth of Klebsiella pneumonia was there. Ultrasonogram abdomen which shows increased in cortical echoes and mild minimal pleural effusion with the fluid in the peritoneal cavity. And the chest X-ray, bilateral blunting of costophrenic angle, evidence of pleural effusions. Next slide. So the treatment so far given was 30 ASVs with 2 PRBC transfusion. It was given at Namakkal Medical College itself. 4 FFP transfusion and injection piptas, metronidazole, ranitidine and chimeral fort and serratiopeptidase and other conservative managements. So the next slide. The diagnosis was made as snake bite with left-hand cellulitis, chemotoxicity, capillary leak with acute renal failure. But the patient is clinically improving with increased urine output and with clear urine, but the renal parameters were still not settled. He is under observation in our medical college still now. Next. So currently the patient on further monitoring and treatment dialysis is going on up to 22. Patient parameters and urine output is steadily improving. This was the presentation, sir. It's almost similar like our Pudukkottai presentation. We are getting cases in the nearby medical colleges with Sir Mohan sir told that the compartment syndromes and all, nowadays we are getting very rare and things. Even the last year itself we have got several compartment syndromes, especially we are getting cases from Kallakurchi areas, Sinnasalem, Kallakurchi, like that areas, the snake bite, which they are referred. Most of the cases are going for compartment syndrome. We did fasciotomy for some of them, and that patients are also having very high mortality, sir.
Sendil.
It's a very good case and very good so management, sir. So probably this patient also had, as discussed, thrombotic microangiopathy. So probably if a peripheral smear study, if it was done, it would have.
It was normal, sir. That's what
So normal. Yes, sir. Probably that VECC component along with the pigment component would have aggravated this patient, sir. Very good approach.
So regarding this patient, sir, you told the comorbidities was not there in this patient. So considering local envenomation with sepsis, cultures are also positive. So whether any renal involvement other than snake venom induced can also be considered like acute rapidly progressive glomerular nephritis where nephrologist.
That's what in the previous case also, then the Pudukkottai also, the similar presentation. Some of the cases are producing rapid progression of the elevated renal parameters. So we don't have any previous data like that. According to our knowledge, the patient doesn't have any previous history of renal involvement. We inquired that also. Because till now, the creatinine value was 8.9.
Yes, sir.
Patient was not improving. Some of the cases after not improvement or the 15 days, we are going for renal biopsy, shows acute tubular necrosis and the findings are not reversible also.
So with the renal biopsy, you have evaluated the case.
Yes, sir. Planning for renal biopsy, the patient was not, the parameters are not improved.
Yes, sir.
We are waiting for that.
We can have a series of cases like this where we can have, it can throw light.
Yes,
on
sir,
what is
definitely,
happening to the
definitely,
patient.
sir.
Yes, sir. Said the direct venom toxicity on the glomerular, probably that is a case, and there are studies that literally less than 5% of these cases can progress into CKD.
CKD, yes, sir.
So,
yes.
so biopsy is very much important.
Biopsy is
Sir.
very much.
Sir, we gave FFP, no, sir? Indication was INR was 1.8.
INR 1 and he having persistent hematuria also.
Persistent
That presented
hematuria
the patient referred from there, Namakkal Medical College, it was itself a multiple episode of vomiting with a progressive cellulitis with hematuria, with elevated renal parameters. So already 30 vials given, so persistent hematuria, we gave 4 FFP on the next day, 16th. After that
improved, sir?
No, it was improved, sir. Now he is having clear guidance.
So after listening to your case, you are talking about a capillary leak syndrome, especially they say in Malabar pit vipers, because when we go to Kerala conferences, they say one of the feature of this is periorbital edema. So was the periorbital edema was noticed in this case? Only a pleural effusion was noticed. So sometimes in the Western Ghats area, districts closer to that, whenever a snake bite comes, look for periorbital edema. It may be early sign of capillary leak syndrome. That is one thing. And yeah, okay. Okay, that is one thing, sir. Regarding FFP, because many times, after completing 30 vials, still the WBCT may be prolonged. I think Dr. Ramesh can throw some light. We have given FFP for them also when still the whole blood clotting time is not there.
Yes,
I mean, with
once
the-
we have completed the maximum dose of ASV, still the patient is having coagulopathy or multiple etiologies can be there to persistent having coagulopathy, where FOP can be the management for preventing organ bleeds.
Because I have seen, being working at tertiary care at Madras, we have seen sometimes people referring to us with 60 vials given outside because WBCT was prolonging. So everywhere they go, they have been giving 20, 20, 20. So when they landed in our hospital, they came with 60 vials also. So the message is when if you after 30 vials, if it is still not clotting, go for FFP. Can we suggest that, or you have any comment on that?
Sir, it depends on, suppose if it is a known Russell's viper or Saskil viper, then the scenario is different.
Yeah.
Where we have given 30 vials.
Still,
we have seen the snake confirmed.
Okay, yeah.
Or some lab parameters suggest of probably Russell's viper or Saskil viper. 30 vials we have given. Still patient is having 20-minute WBCT positive. We can give 10 more, 40, 50. So very, very rare that is. FFP role will come only if there is a significant large cavity bleeding, that is after you have given 30 vials of ASV. If there is no bleeding, only test is positive, in confirmed case of Russell's viper, Saskil viper, you can give ASV more than 30 vials.
So one more doubt, if there is any other indications for giving excess of ASV other than this prolonged clotting time? You said that after the clotting time was prolonged, even after 30 vials, you are proved that the patient is having classical Russell viper fight.
Yes.
So you can go for 40 or 50
Yes,
vials, depends
sometimes.
upon the condition. I am
Sometimes,
asking
right.
about whether there is any other indication other than this prolonged clotting time.
CR wants to add, please, sir.
No, I don't think we are justified in giving more than 30, sir. Because the maximum venom quantity that can be injected by a adult, healthy, active as a first bite on a victim, definitely the 30 itself is more than sufficient. So this kind of neutralizing capacity of this polyvalent anti-snake venom and its efficiency against the viper, I don't think we need to give more than 30.
Correct, sir. Because on an average, it can give from 4 to 157 mg.
Yeah, that's what.
On an average 63 mg, that is the maximum amount it can be injected into the body.
yes.
Each vial going to neutralize 6 mg of
Yes,
venom.
yes.
So based on that only 10 vials has come.
Yeah.
Maximum you can give up to 25 to 30 vials. That is been calculated.
yeah.
But sometimes where you are given 30 vials, still patient is having 20-minute WBCT positive. Coagulopathy is still present. Rather,
You manage it like any other coagulopathy rather than going on increasing the dose of ASV. That is our
but for the
kind
blood,
of
blood
understanding.
products to be given, sir, there are specific indications written. That is, if there is a always bleeding, clinically significant bleeding, we can give, sir. Just based on the PT INR, may not be advisable to give blood
Actually,
products, sir.
this is where we don't have a strong evidence for or against. So this kind of forum can bring out some data and you can practice whatever you are finding. I think Dr. Sendil wants to add before.
One minute, sir. Why I asked this question means, my previous nephrologist in our hospital, he said in his experience, even after 30 vials, if you are giving more vials, that will be useful for acute kidney injury. That's what I asked for this question.
Yes, sir. Yes, sir.
So basically, as explained, VACC is going to happen, and basically there is going to be exhaustion of all the clotting factors. So there is bound to be a bleeding tendency. So we may not know whether the venom component is causing the bleeding tendency, or there is an exhaustion of these clotting factors that is responsible. So whenever a patient is having an active bleeding tendency, as in this case, patient had an hematuria, so you may start ASV along with FFP. So we have seen many cases who have developed an ICH or something like this when such patients probably after 24 hours. So probably this may help us. But if we have some assays to assess the unbound toxin fraction, probably in EIA, we may be able to justify the exact dose of ASV that has to be used. But usually when we have used a maximum dose as required, probably a 20 or a 30 vials, I think so that is far more enough. After that, if needed, probably the FFP has a role in the management whenever a patient has bleeding tendency.
Yes, sir. So regarding this, so we all know that the venom, the anti-snake venom acts on the circulating venom. Once it is fixed to the tissues, there is not much role for the further anti-snake venom for that. And another interesting scenario we also had is, so we have given the initial dose, we are waiting for 6 hours. In between time, there is active bleeding. So we are, actually we are waiting for 6 hours. So we are not going to give the another next dose of thing before 6 hours. In between also, any actual bleeding is there or organ bleed, we have envisaged. There comes a role for FFP in between period also.
Okay, at this moment I want to add one more dimension. Already one of our speaker was mentioning anti-venom is not acting against some snakes in that area. I think it's a very crucial, important concept that we have to understand. At present, how our ASVs are being manufactured, I think most of you may know that, but it's worth repeating. We are taking venom or we are catching snakes in and around our crocodile bank along the ECR road, and those snakes from our southern or some Chennai, near Chennai, they are the source for manufacturing of ASV across India. So we don't have a pan-Indian snake venom to be used as anti-snake venom production. So definitely the venom from a snake caught in near Mahabalipuram may not work in Theni, or it may not work in Jammu and Kashmir. So that is another, that's a point Dr. Ajay Shelve was also morning mentioning. We are going to have a region-based anti-snake venom production based on the local snakes, and also every snake has its own enzyme. So many components are there, and we do not have antidote for all the specific things. So there are a lot of challenges in the administrative. What is available right now, only we are using it. But there are many things that we have to understand regarding the mechanism of action of these enzymes, and whatever we are talking about, FFP, all these are only supportive care we are trying to establish, and ultimately saving the life is the ultimate goal. You are going to give one more case?
Sir,
or only one?
Sir, considering that point, that's the reason why, sir, because as I said, we don't know, once 30 vials are given and it is not working,
okay.
I don't know whether it is a responsive snake or non-responsive snake.
That's what.
One thing, after scientifically we have neutralized the venom that has gone into with the 30 vials. After giving that, if we are going to dilute the protocol like that, giving another 10 vial or 20 vial, it will become like something anybody can do, anything like that. I think keep it around 30 is sufficient to
generally.
And then start with an FFB is an ideal one rather than increasing the dose of an.
Okay, I think we had a very good discussion. We'll go to the next case presentation. Yes, sir. Time limit for?
There is a condition called late envenomation, as you are rightly telling, where the patient can present late. In that case, what actually this anti-snake venom is doing, it can only neutralize the circulating free venom in the blood. When the venom gets fixed with the tissues, it is not going to act anymore, the anti-snake venom. So if you are getting after 24 hours or 48 hours, what we teach and practice is give 110 vials, first dose, that's it. There is no need to repeat. If the patient is coming to you or identified, already 48 hours are over, the venom is not in circulation, it is already gone to the tissue level, so it is not going to act. But still we give the benefit. There may be still some venom, may be in circulation, so we stop with giving the first dose. That's our teaching.
Actually, sir, I highlighted this, the duration of action of venom. They have said up to 30 seconds a clinical presentation can be developed in case of crite and 24 hours in case of a cold. So naturally we can go ahead with after 1 day also we can have the patient present you with more than 20 minutes clotting time, and the neurological presentation is there. As sir said, to neutralize only the existing venom that is present in the circulation, we can go ahead and give. There is no need for going further doses. That's what I'm saying. Even 24 to 36 hours, we can go ahead.
Yeah. That's a point we were discussing. No,
So
after.
the T half of snake venom is only 14 hours, sir. After that, probably after 24 hours, if the bleeding is happening, it is probably because of VICC. And you will have to give a safe dose of, as sir said, 10 vials is probably in good faith that still there is some more unbound venom that is circulating. After that, it is only FFP.
If it is a neurotoxic snake bite, your mechanical ventilation take over it and take it off. Only if there is for example, if it is a hemotoxic snake bite, as I said, the VICC is going to play a role. And again, the venom is not, antivenom is not going to be there. It's already the damage has happened. I think.
Okay. Yes, sir.
Yes, sir. It's a very good unit to all. My case is also similar like Pudukkottai and Salem GH cases. The capillary leak syndrome following the Russell Viper envenomization. The Russell Viper is known as neurotoxic and hemotoxic effects. Rarely it causes capillary leak syndrome. It is characterized by hypertension, hemoconcentration, hypovolemia, and edema. Our case is 36 years old female, alleged of snake bite at left foot, presenting complaints, blood vision, bilateral ptosis, hematuria, swelling and pain in the bite site. Initial assessment, vital stable, local swelling is present, bilateral ptosis present, other system normal, WBCT more than 20 minutes. Blood test normal, urine analysis, plenty of RBCs. Initial management, 30 vials of AAC given for neurotoxicity, hemotoxicity, local cellulitis, supportive care, IV fluids, IV antibiotics given, other supportive measures given. At 24 hours, the hematocrit 37, platelet 2.5 lakhs, urine output reduced at 800 ml per day, urea 60, creatinine 1.5, INR 1, WBCT more than 20 minutes after 30 vials of ASP, as like previous case. So after 48 hours, so patient developed tachycardia, periorbital edema, parotid swelling, oliguria, hypotension, reduced SpO2, increased heart rate. The patient is patient has periorbital swelling also there. Periorbital swelling also there. So 48 hours, hematocrit 49 raised, platelet reduced 55,000, urine output reduced 400 ml per day, urea 99, creatinine 4.5, drastically reduced at 24 hours. INR 1.68, WBCT still more than 20 minutes. So increased hematocrit, reduced platelets, hypovolemia, hyperkalemia, ultrasound shows minimal ascites, bilateral pleural effusion. So clinical suspicion based on edema, hypotension, hemoconcentration, hypovolemia, evidence of third spacing, pleural effusion. Rare but known complication of is capillary leak syndrome. Started inotropics, nasal oxygen, FOP 4 units given, hemodialysis 2 sessions done. After that, improved urine output, stable vitals, lab investigation normal, resolution of edema, parotid swelling, local cellulitis was noted. So hematocrit after hemodialysis 36, platelet 1.96, urine output 1800 ml, urea 25, creatinine 1.2, INR 1, the WBCT less than 20 minutes. So conclusion, capillary leak syndrome is a rare but serious complication of Russell Viper envenomization. Early recognition, aggressive supportive care is essential. Hemodialysis and FOB may be beneficial. High index suspicion is required for deteriorating patient with post-ASP after 30 hours of ASP. Similar case like the Salem case.
Actually, this patient also had a neurotoxic.
Yes, sir, neurotoxic.
So that is another area we have to, even though we traditionally say crates and cobras are neurotoxic and vipers are thing, I think this overlap syndrome is very common in our practice. So especially when we are sensitizing our primary healthcare doctors, they should be also taught that there's a lot of overlap syndromes in our practice. Yes, sir.
Thank you, sir.
Thank you. Only one case only, no, sir?
Yes, one case.
Thank you, sir.
Yes. In this patient, initially the renal parameter seems to be okay on the first day and second day. Yes, sir. So like these patients, as we have seen in dengue-like picture, so before the capillary leak presentation, how was the hydration managed for the first 2 days? That also have a better role on the renal management. Whether that if it is taken care of that hematocrit rise, everything, if it is occurred after that adequate hydration management, then it is okay. The first 2 days, the fluid management also plays an important role in this.
So before we request the next speaker, because from morning we have not discussed about the sea snakes. Anybody in the audience have managed any sea snake envenomation? Okay, so in our Rajiv Gandhi hospital, we had around 6 cases of sea snake envenomation. The first case was a fisherman who was fishing in the sea. In the net, along with the fishes, he saw the sea snake. So when he was trying to put it back, it was bitten and he was admitted. And in fact, when he came to our hospital, he presented with neurotoxicity, with bilateral ptosis, with respiratory paralysis. So that was our first experience also. So when we referred the literature, normally we know sea snakes are notorious to cause rhabdomyolysis, myotoxic, but literature says it can be neurotoxic also. So we managed that case with ventilation, and he had some rhabdomyolysis, and myocarditis also, he had some enzymes were elevated. So in fact, that case was well managed by Dr. Sendil and got published in AP. So why I'm telling is, subsequently to that, we had 3-4 cases, and 2 people were bathing in the sea near Kovalam beach. There was no history of bite at all, but they had a bath in the sea for more than 2 hours. After going home, they had a severe muscle pain with myoglobinuria. So they didn't know what is due to. They went to a PSC and they thought something else and they referred to us. But again, that's why the history of bathing in the sea in the evening and going back and developing severe muscle pain and rhabdomyolysis. And we used FAD cycles for those cases and record. Yes, before we next case.
So good evening, one and all. I am Dr. Karthikeyan, coming from Government Karur Medical College. I am going to talk about the case which we couldn't save in spite of full-fledged treatment measures. Even though the patient presented a little bit earlier, within 45 minutes he came to our hospital. We can go to next PPT, sir. These are census, sir. Next slide, please. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide, please. Next slide. Next slide. Next. 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 The next one. Next PPT, please. Next slide, please. So the patient Subramani, 65 years male, he has admitted on the day of 16/2/2025 at 9:10 p.m. The bite time was 8:30 p.m. The time taken to reach the hospital is around 40 minutes, and the duration of hospital stay is 24 hours. The bite site is right foot, and he was died on 17/2/25 at 9:33 p.m. The duration of stay is around 25 hours. Next slide, please. So Mr. Subramani brought with his alleged history of snake bite over his right foot when he was farming at around 8:30 p.m. with complaints of pain over the bite site. There was no other clinical manifestation such as swelling or bleeding manifestation or neurological complications. He is a known case of diabetes. Other than that, there was no comorbids. Next slide, please. So general examination, patient is conscious oriented afebrile. The WBCT was less than 20 minutes. It was clotted, and only there was a bite mark without evidence of cellulitis. His investigations, all investigations were found to be within normal limits. Next slide, please. Next slide, please. So on the time of admission, his clotting time was less than 20 minutes, which was taken at 9 p.m. and 11 p.m. and 2:30 a.m. the next day. At around 5:30 a.m. early morning, when the clotting time was done, it was around more than 20 minutes, where we started with 10 vials of ASV. After that, by 8:30 a.m., the patient went for sudden cardiorespiratory arrest, for which he was intubated and put on ventilator support. It may be due to neurotoxic manifestation, I think so. So the clotting time at that time was also more than 20 minutes. After 6 hours, we have done a repeat clotting time, which was found to be more than 20 minutes with bleeding manifestation was started. Sir. He had bleeding over nose, mouth, for which we started with 4 units of FFP with the 10 vials of ASV. Then by 8:30 p.m., again his clotting time was prolonged with coagulation profile abnormalities, for which we again infused with 10 vials of ASV with 4 FFPs, 2 platelets and 1 whole blood transfusion. And we are the patient was also in inotropic support. Next slide. Next slide, please. So this was the history. The patient was admitted on 17/2/2025. He went for arrest on 17/2/2025. The duration of stay was around 24 hours. As per, we resuscitated under ACLS protocol, but we could not revive the patient. So the cause of death for this patient is snake bite right foot, cellulitis, hemotoxicity with neurotoxicity. Since his creatinine value was a little bit raised of initially of 0.9, the second one was 1.7, acute kidney injury, probable DAC and shock will be the cause of death. Next slide, please. So we have infused him with 30 vials of ASV with 12 units of FFP, 4 units of platelets and 1 unit of whole blood transfusion. Next slide, please. Next slide. Next slide, please. So this was the post-mortem report we got from the forensic medicine department. His lungs showed both lungs was edematous with petechial hemorrhage. Left lung was adherent to the thoracic cavity. His thoracic cavity was fluid filled. His kidney showed evidence of acute tubular necrosis. His heart was enlarged, which was due to snake bite and its complications. Thank you, sir.
Actually, I just want the panelists to throw again 30 vials, whether was it needed in this particular case also, when they already started ventilation, FFP also was started. Still, should we go again with further ASV?
So they didn't bring the snake, no? Which snake it was, no?
Species was not identified.
So we gave ASV, then only we gave the FFP.
Yes, correct. Started with ASV.
So completed ASV, then only we gave the.
No, sir. Intermittently we started with FFP.
Oh,
Since
side
he
by side
got-
we started.
Side
got
by side
bleeding-
they were starting.
bleeding from nose and oral cavity, hematuria.
Nose and oral cavity hematuria. Sure.
So again, this brings another important point in clinical management of snake bite is whether we can estimate the venom in the blood. So the technology is now, research is going on for many years, still we have to find the answer.
So I would like to ask you, sir, because the King Institute, I think they started this project
Yeah,
of
that's what
enzyme
I'm saying.
immunoassay of doing this venom assay in all the snake bite patients. What was the status of that
Yeah,
study?
that's what I'm saying. See, this is a poor man's disease, snake bite, so they need further lab facilities and other things and all. It's being done for any national conference on snake bite. Always this toxinology group one is there. We are toxicologists. There's a group called toxinologists. They are still finding out answer to this point of having a kit to detect the presence of venom in the blood, so that we don't wait for the manifestations in the form of prolonged WBCT or a neurotoxic. So that is where early diagnosis can be achieved maybe in days to come. Otherwise, still we are going to depend on our traditional neurological examination and other things. And I understand your point, but still we have a long way to go.
Yes, sir, because that project, I believe it was started some 8 years back.
Yeah, that's what I'm saying. It's not only in King Institute, it's happening in multiple sites. In Mysore also they have a very big study group is on that particular, and throughout the world they have been doing, but still answer is not achieved.
Yes, sir. So coming to this case, this patient was given an ASV and the WBCT was prolonged by 5:30. Probably a repeat WBCT was done within 3 hours, probably when the patient had an arrest. So here, the timing is very important, sir. So probably this is the early morning, the 7:30, the time where there is a changeover of shift, especially the staff nurses and also the doctors. The point of care is here is the care of the patient. Usually it goes down during this shift change, especially the 7 o'clock, where the staff nurses will be busy with their handing over and also the doctor's
I
shift
do
change.
understand,
So probably this patient was not witnessed, probably he could have had some hypotension or an arrhythmia, which is also more common with snake bites because the cardiotoxicity is quite there, which is more common with cobra as well as here it is a hemotoxic. Even viper has cardiotoxicity or a hyperkalemia, so and acidosis. So these four can cause an acute cardiovascular collapse in
Yes.
snake bites, sir.
Yes.
So probably this, if a prudent clinician who was there, especially the shift change time, very common with arrest. So not only snake bites,
Not only
any critical cases.
Not only that, I think I've done that clotting time repeatedly every 30 minutes. Once a patient arrives to us, clotting time every 30 minutes for 3 hours, for another 1 hour duration for another 3 hours, and then every second hourly for another 6 hours, and then fourth hourly for another 6 hours. Still there is nothing. So that's the protocol that you make, because you patient went into arrest, there is an increased clotting time. Is there any clotting time already there? Suppose we have tested much earlier, we would have started the ASV.
So we have done 4 times, sir.
Sir, actually,
Clotting was normal.
at this moment, I want to ask Dr. Sindhil, because he did a small study in this. We are promoting 20 minutes whole blood clotting time because it can be done at the primary care also. Suppose the patient is in a tertiary care hospital, can we do other coagulation parameters, which you also did a small study?
Yes, sir. Basically, the WBCT is for the peripheral setup. If you are in a tertiary healthcare setup and if you want to diagnose venom-induced consumption coagulopathy or hemotoxicity, basically the indirect test of doing a coagulation profile, the PT, INR, and then the D-dimer or fibrinogen, especially fibrinogen, has a critical role in identifying presence of hemotoxicity even before the patient develops a deranged 20-minute WBCT. So we did this study in Madras Medical College, and fortunately or unfortunately, all the hemotoxic cases who presented to us after 4 hours, because everyone had to travel literally 4 hours from the periphery sites to our center, so all of them had a deranged coagulation profile, and hence the significance value was not up to the mark, and hence we could not publish the study. But we found that all these patients had a deranged coagulation profile, especially fibrinogen is more sensitive, and then the D-dimers.
So can we suggest, if the patient is in a tertiary care hospital with these facilities, these can be done along with WBCT, something like that?
Yes, sir, because in this current era where everybody is asking for evidence and literature, probably if this study is done in a peripheral center where the patient gets access to the center within an hour or probably within 2 hours, so that's what the statistician says, we could arrive at a probable significance. So if this study is done in multiple centers in Tamil Nadu, yes, definitely we can publish this.
So I think we'll identify something like Theni or Tanjavur or Kallakurichi where this incidence is more. Anything you want to say?
Yes, we can have a
Identify a study center where these facilities can be given.
zonal centers can be given the facilities to do the tests.
Okay, I think we are running short of time. Yes, madam.
Question, sir. Can ROTEM be done, sir, in a tertiary center like RGGH? We have thromboelastogram and ROTEM now.
That's all.
So if WBCT is normal, should we go and
Madam,
do
since
the-
you are now in MMC, I think you can start.
As policy decisions, if it comes-
Yes, ma'am, we
Yes,
can do ROTEM, but only thing is availability, and then you need an established center for it. Probably we have it in RGGH.
Yes, sir.
Other centers, I'm not sure if they are available.
Some of the peripheral D-dimer facility and continuous supply of the reagents are not available.
Madam, you can start a study, madam. We will, because NHM can support, definitely we'll try to find out that. And
So these, regarding sir's query, we can use MDRU. If our facility has MDRU,
Multidisciplinary
they
research unit.
They fund studies, sir. We can ask for MDRU, or if possible, at least 50 cases.
Yeah.
So there are some kits available which may be cheaper, and at least from our CMCHS fund, we can arrange for a 50 kits or something like that. At least for fibrinogen assay. If that may be taken for assay, yes, we can do and we can publish.
Okay, I think we had a very useful and detailed discussions. So before I conclude, there's only small request, because we have representatives from all medical colleges. Just like in morning we saw rodenticide hub and spoke model. Similar to that, for even snake bite referrals, if a patient is referred from a secondary or a primary care to a tertiary care, this is a medical college, they can have a hand holding with your nearby PHCs. So already it is there for rodenticide. The same thing can be followed for snake bite also. Yes, Ramesh?
So regarding this patient also, there could be a direct venom-induced cardiotoxicity, and myocarditis also is a possibility. So serial ECG can also play a role.
Yeah, I think this point, I think it's not only just hemotoxic or neurotoxic, you should go beyond that, including cardiotoxicity and electrolyte imbalance, diabetic and comorbid sepsis, all those things has to be addressed, including the capillary leak and other things. So I think we'll go to the last panel discussion. Thank you all. Thank you.
Thank you, Raghunandan sir, for that excellent moderation. I request Professor Dr. T. Shanti ma'am from MMC to kindly moderate the last session for the day. Ma'am, please.
Good evening to everyone. Thank you for the opportunity given by NHM. On behalf of Director RGGH, I have come here and I am representing Dr. Hariharan sir. And I am inviting the panelists Dr. John Christopher from Kanyakumari Medical College, Dr. Marimuthu from RGGH, Dr. Ravi Shankar from KMCH to take part in this panel discussion. And case studies will be from Chengalpet Medical College, Tiruvannamalai Medical College, Tanjavur Medical College. I call upon the doctors or HODs to proceed further. Actually, whatever it may be, the methodology to be followed, because at RGGH we are receiving many referrals at the fag end, and we could not say many success stories. But we could observe a lot of flaws in documentation, starting from the history and examination, and partially treated, and the response to the treatment is not revealed in the referral slips. Lot of fallacies are there. So kindly look into all aspects. This is our request on behalf of MMC, because we are receiving at the fag end, and at most hope is lost. So that is again one of my requests. Okay, we will proceed with the discussion.
Good evening all, I am Dr. Jayalakshmi from Chengalpet Medical College. Next slide. These are all census. In 2024, from Jan to December, total number of snakebite admissions were 922. Out of that, 27 death cases. And from January, February and March, 64, 57, 84. Out of this, only one case died due to snakebite. Next slide, please. This is a 55-year-old came to Thai ward on 21/3/25 at 4:20 p.m. Patient was referred from Tirupur GH in unconscious state with alleged history of unknown snakebite at his left foot. In view of poor GCS, his GCS was 3/15. Patient was intubated and connected to mechanical ventilator. Next slide, please. History obtained from his relative. A patient was apparently normal till 2 p.m. Then he had alleged history of snakebite over his left foot while he was in his field at Tirupur around 2 p.m. on 21/3/2025. Immediately he rushed to nearby Tirupur GH around 2:30 p.m. with history of blurring of vision and pain over the bitten side. Injection TT alone was given at Tirupur GH and patient was referred to Chengalpet for further management. Next slide, please. On the way to the hospital, patient had history of bleeding at the bitten site and blurring of vision, drooping of eyelids, giddiness and slurring of speech. There was no signs of hemotoxicity except bleeding at the bitten site. Next slide. Known comorbidities. Personal history also is a known alcoholic for past 20 years. History of binge drinking previous day and night. Next slide. On examination, patient was unconscious, poorly responding to painful stimuli. GCS was 3/15. Nefebrile, his vitals were BP 100/70. Pulse rate is 80, SpO2 was 80% in room air, respiratory rate 10 per minute. Local examination, there was a left foot bite mark and mild swelling was there. Next slide. On systemic examination, CVSRS, everything normal. CNS patient unconscious, bilateral sluggishly reacting light pupil to the light 2.5 mm, bilateral plantar no response, whole blood clotting serial manifestations are normal. Next slide. The provisional diagnosis, unknown snake bite with signs of neurotoxicity, respiratory failure, alcohol use disorder on mechanical ventilation. Next slide. The treatment given was patient is on mechanical ventilation, injection ASV 10 vials in 100 ml of normal saline given over 1 hour. As there is no clinical improvement, another 10 vials were given. Antibiotic injection ceftriaxone was given. Supportive measures were given. Then patient shifted to IMC for further management. Next slide. His investigations were total count 9,800, hemoglobin 12.6 grams, platelets 1.74, LFT, RFT and ECG everything were normal. Next slide. Day 2 around 5 p.m. he regained consciousness and slowly weaned off from the ventilator. Day 3 around 7 p.m. he was transferred to toxicology ward. Day 5 patient there is increase in the left leg cellulitis. Surgery opinion was obtained and advised to change over the antibiotics to piperacillin tazobactam 4.5 grams with other supportive drugs. Next. Day 8 with worsening of left leg cellulitis he underwent a left foot fasciotomy. On day 11, he got discharged with successful recovery from snakebite innovation and advised to review at surgery OPD for regular dressing. That's all. The case was presented in Tirupur GH. They should have given the ASV. Without ASV, they have referred the patient to our hospital. In around Conjuram district also, we are getting from the GHS referral, they are either not giving the ASV or on inadequate dosage they are giving and sending the patients. That's why I presented
atropine and neostigmine was given?
Yes,
for
ma'am.
this patient?
It was given, ma'am.
There was response?
If
Whether
patient
you
was,
repeated the doses and what was the
no,
response?
patient was unconscious, ma'am. When he arrived to our department, he was unconscious. Next day only he regained the consciousness.
So the pitfall in this case is, first thing is patient rushed to Tirupur GH. Whether patient himself rushed to or he was taken to Tirupur GH, that's a very important point you should note.
From the field, he rushed.
Yes, he rushed. Then the awareness should be imparted to the not only to the doctors, not only to the public, and also to the doctors. Dose of adequate dose or first dose of ASV in the Tirupur GH could have done.
They have not given any ASV. They have only TT and sent the patient over. It was delay from Tirupur to Changalpur GH.
Have you given regular training, monthly training for
Yes,
BKS
sir, we
medical
are giving
officers?
from the emergency department. We are regularly giving training to all the GH and PHC staffs.
Have you talked with that medical officer, madam?
Yes, sir, we are telling them to.
Why is not given? That is should talk, madam.
Okay, sir.
In one of the case which was referred to RGGH, the patient is a known hypertensive patient and had actually a bleed, but by then drooping was there. They have given neurotoxic. It is not a vasculotoxic, but he had accelerated hypertension. On probing into, substance abuse was there. So, and on taking a CT brain, there was a huge hemorrhage with mass effect, and he had all the features because of the stroke rather than the
snake
bite. But it was an unknown bite. So actually, it is not at all. But ASV has been started at a peripheral center, and he had anaphylaxis. But whether he was revived there with all the measures was not mentioned. By the time the patient could reach, nothing was there, and brain death, nothing was there. So these sort of cases, we land up in a difficult situation. And it is actually a hemorrhagic stroke because of systemic hypertension. And what about the reality of ASV and how they have done the treatment for anaphylactic shock ASV induced? It was not revealed in the referral slip. So it is better if we have the contact number of the referring person, so that immediately we can contact them and clear few of the doubts which will be of use in managing the patients.
Okay, madam. Thank you, madam. Thank you.
Good evening. I am Dr. Dr. Senthil Kumaran, Associate Professor of Trivandrum Medical College. So I am going to present a case of snake bite which was associated with the complication of TMA. So next slide, please. A 60-year-old male patient was brought to the hospital with history of snake. It was a Russell viper bitten over his back on 28/8/2024. There is 3 episodes of hemoptysis following the incident. History of giddiness was there. Next slide. The patient was conscious. Vitals are stable. So next slide. So on 28/8, on day of admission, his whole blood clotting time was more than 20 minutes. So he had 2 episodes of hemoptysis. So we have given completed the 30 vials of ASV as per conventional protocol. So next day on 29/8, his coagulation profile got corrected, but we have started his platelet started decreasing. It was 34,000 on 29/8, and 38 it was 35,000, and his renal parameter also got elevated. Next slide. So his bilirubin was total bilirubin was elevated on 29/8. It was more of indirect fraction. The peripheral smear showed plenty of cystocytes, and the manual platelet count was less than 40,000. So treatment given was injection ASV was given, IV fluids, IMC care, and 2 cycles of hemodialysis was given. Luckily, the patient recovered from renal failure and got discharged. Next slide. This was his serial RFT and WC count. Next slide. So the patient was present with anemia, thrombocytopenia, and evidence of hemolysis in the way of increased LDH, and indirect bilirubin fraction was elevated. So peripheral smear also showed plenty of cystocytes. Next slide. So here the open to forum is this case is a case of snake bite with the TMA which responded to hemodialysis. My doubt is in this case is whether if the TMA is not responded to supportive management or conventional treatment, whether we can go for plasma exchange, or it is necessary to look for serum complement levels, whether there is activation of alternate pathway and we can go for any anti-complement factors like eclusizumab, or we can go for, it is mandatory to check for ADAMTS in these cases if it is not responding to the conventional treatment.
ADAMTS test will be only for, not for acquired TMAs, it may not be of use. Okay. Only for congenital it will be of use. So there is no role for estimation of ADAMTS 13. Whether you have given any steroids?
No, ma'am, not steroids. The patient responded well to ASV, and only we did 2 cycles of hemodialysis. With that, the patient recovered, ma'am.
So what differentiates this from a DIC?
They say here PTT and APTT was normal, sir.
So that's not mentioned in the
it's not mentioned
presentation.
here, but coagulation profile was normal.
And no manifest bleeding?
No, sir. First, there was 2 episodes of hemoptysis was there. That time, that whole blood clotting time was more than 20 minutes. So we completed 30 vials of ASV. Next consecutive days, the whole blood clotting time was corrected, and there is no episodes of further episodes of hemoptysis also. But only thing was thrombocytopenia, anemia, and cystocytes, and indirect hyperbilirubinemia, and LDH was elevated.
So in snakebite, initially there will be a venom-induced consumption coagulopathy, and later that thrombotic microangiopathy. So sometimes in a short duration of the course, there will be overlap of these, and these 2 things will combine together to mimic a disseminated intravascular coagulation. So snakebite as such will not produce DIC, and very commonly it can produce a TMA.
Okay. So in literature also congenital ADAMTS 13 also there needs a precipitating factor to get exposed, ma'am. Here it may be due to snake bite getting exposed of congenital RMTS13 or.
The patient is improving, so you can wait. You can be slow on that, which is a very rare investigation.
Have you done
If
Adams,
there is
sir?
no improvement, you can
Have you
try.
done Adams?
No, sir, not available in our
Is
center.
there any hematuria? No hematuria.
No, hematuria.
What
Only
about
hemoptysis was there,
only.
sir.
What about fibrogen level?
Fibrogen was normal, sir. Fibrogen, PT, all coagulation probable was normal, sir. Okay, sir. Thank you.
Presentation, and patient has improved in spite of all this.
Luckily, the patient survived.
So the basics things and supportive measures
Yeah.
to be done, so the patient recovers also. Very rare cases we see rare diseases or rare situations. So common things are always common, and in many of the cases even IV fluids are not sufficiently replaced, which may worsen the renal status again. So all those basic comorbids, attending all those things also has a good prognosis and outcome. Okay, thank you. Next I call upon Tanjavur Medical College, HOD.
Good evening to all of you. I'm Dr. Kannan, Tanjavur Medical College. Next slide. These are statistics. Around 82 total cases were treated, out of which 246 poisonous cases, 28%. Next slide. And the 74 cases are cobra bite and kite around 37. Viper constitutes around 135 cases. Next slide. This is just month-wise split up. Next one. Total death from total cases treated from Jan 24 to March till date is 882. Total death is 17 cases. Next one. I think the repetition of taken 2 cases, repetition of previous discussions only. One, for example, for VICC, venom-induced consumption coagulopathy. Another one is capillary leak syndrome. First, next one. This case, a male 27 individual presented a hemotoxic snake bite. Time of bite 7/4/24, 7 p.m. It's referred from Viruthachalam GH on 8/4/24 around 11:30 p.m. So referral for indication is progressive cellulitis. Door to needle time is 1 hour. The number of vials given is 30. 10 vials given at Viruthachalam GH and 20 vials in our institution. So patient went into acute kidney injury. HD was initiated on 10/4, 2 cycles HD done. And the blood products replacement, there is no improvement in the patient status. A progressive renal failure, patient developed DIC and pulmonary alveolar hemorrhages. So decided to do one flux. Next one. So flux initiated on 12/4, 4 cycles completed. So our diagnosis for this case is probably a Russell Viper bite with cellulitis, venom-induced capillary leak, the AKI, neuremic encephalopathy, and diffuse alveolar hemorrhage, coagulopathy, and shock. So in spite of routine management with other antibiotics, and even though flux is not a routine indication, we have tried 4 cycles of flux and 68 FOP and cryo, everything transfused, but we couldn't be able to save the patient. Next case. Another case is 37-year female, neuroparalytic and hemotoxic, probably kite. Time of bite 12/9/24 at 11:10 p.m. It directly came to our institution. Door to needle time is only 1 hour. Number of vials, maximum dose we have given. Diagnosis at the time of presentation is neurotoxicity, probably VICC, and toxic myocarditis, acute kidney injuries. So routine management given. In spite of hemodialysis, antibiotics, and adequate FOP and cryo, this case also we couldn't able to save. Next. So already the capillary leak phenomenon, leak syndrome is already we discussed in the previous discussions. It's around 43 to 67% mortality, it's highest mortality. The clinical features, as mentioned in one of the journal, is facial or periorbital conjunctival edema, bilateral parotid enlargement, pleural and pericardial effusion, pulmonary edema, hemoconcentration, hypotension, and the shock. Next. So this is the probable mechanism for venom-induced capillary consumption coagulopathy. It's the VAP1, which is the toxin in the viper, which is the responsible for all these inflammatory cascade and leading on to the increased capillary permeability. Next one. Next one. So this is a presentation which is given in the journal. Actually, it's done, the study is done by Thomas and Kumar et al. They have formulated criteria to diagnose the venom-induced consumption coagulopathy. Presentation itself with hypotension, hemoconcentration, the protein creatinine ratio of more than 1, and hypoalbuminemia, and the third space fluid collection. So all these criteria have been fit into these previous cases. Next one. So even though the routine management are not able to address this venom-induced coagulopathy as well as the capillary leak syndrome, so we need to introspect this aspect, how to approach this patient. I will leave this the scenario to the panelists. There are some anecdotal reports, case studies. It suggested that there is whether there is any role for PLUX or any role for pulse methylprednisolone. So that will address the cytokine-mediated reactions, or terbutaline, aminophilin, and IV immunoglobulin have been tried in some of the few case studies. There is no RCTs to use these kind of drugs. We don't know. Next one. So these are some of the references for the capillary leak syndrome. It has been published in the Kerala, Trivandrum. So they have tried PLUX, some of the cases, but in few cases showed some improvement, but they didn't say it's a definitive management for this capillary leak syndrome. Next reference is from the role of plasmapheresis in snake venom, systemic review. Also they have tried the plasmapheresis in some of the cases. Next one. So another journal from the ISN, is there any role for early institution of therapeutic plasma exchange in patients with capillary leak syndrome following snake envenomation? So these are some of the references, but we don't know whether these things, these PLUX and other drugs, will it benefit for these patients? I don't know. We need to go for a long-term trial to include in the routine management. Thank you.
All these studies you have referred, what is the outcome or what is the conclusion? So that
in most of the cases, few cases only, they showed some improvement. They don't have a 100% improvement following PLUX as well as steroid and other things. Some of the cases with methylprednisolone, the study shows some improvement. But they don't have a definite role. Whether can we go ahead with this kind of treatment or not, we need some extensive study for this.
So in the first case which you have projected,
yes, ma'am.
The case has come after more than 16
From
hours or 14 hours?
Virthachalam GH,
Why they have
gave
stopped
10.
with only 10 and you have given 20 after 12 to 14 hours? Why not they have repeated the other 10 after observing?
They referred here for progressive cellulitis and renal failure.
There is a lapse of the second dose.
There itself they have to give full dose of ASV and they have to refer it. They didn't try further doses beyond 10 vials from the local GH. So that is a delay in the referral and also delay in completing the ASV for the particular individual. So that may be the reason for the ongoing coagulopathy that leading on to the complications.
Is the referred for progressive cellulitis or raised RFT values?
A reference is only for progressive cellulitis as well as
that you can refer to real or GH okay, sir. Arigal Medical College. Arigal Medical College nearby.
So most of the newly started medical colleges also, they will refer cases to us only.
Suppose if you need nephrologist opinion, Tanjavur is okay. Only progress is showing RFT almost normal values.
They might have referred to nearest Ariyalur Medical College, but instead they referred here. Maybe
That will more time.
Yes,
Here,
sir.
to Tanjavur, I think around 4
Yes,
to
sir.
6 hours.
But as such, Tanjavur belt has high incidence of bites because it is a basically farming area, and
Yes,
you
ma'am.
have more experiences when compared to
And also,
other
as
things
already
also.
discussed, maybe the snake venom, whether this 30 IL is adequate, or the venom which is manufactured in the Madras here, in the here only from Chennai only they are manufacturing with the locally available snake venom. So probably region specific venom
Why
toxin
you have stopped
preparations.
30 with that? There are few cases where you can give up to 40, 60 or the discussion. So we should be substantiating the evidence to give higher doses. So everything is evidence based. Even toxic myocarditis you have given as a final diagnosis. Is there any evidence by echo?
Yes, ma'am.
Any,
Echo. Echo
everything
also
should be
showed.
revealed so that it is known to everybody. So you can measure the IVC dimension and adequately
Echo and the cardiologist also opined that the patient is having tachycardia and EF also very low.
Because at times
And
we
they
are
have-
giving atropine and other things also. So what about the...
Atropine we didn't give, ma'am. For this patient, we didn't give any atropine and other. Only ASV. And there is no response, then we given with other blood
What about
products, FOP and other.
CPK, MB and other enzymes?
These
So
things
being a tertiary institute, it is better we complete all the investigations so that it will be of use for
Yes,
future references and research purposes.
Okay. Thank you.
So we can conclude if there is no further questions and discussions. We thank all the presenters having highlighted various presentations. Thank you very much.
Thank you, ma'am. With this, we complete the case presentations. Thank you all the hospitals for enlightening us with all your case presentations. Now I call upon Mr. Nyaneshwar from Madras Crocodile Bank Trust to present on prevention of snake bite.
Good evening, everybody. I think most of you have been sitting here for 8 hours now, so I suppose your level of attention might be a little less. So this is how prevention models also work, is that we get to work with students and children when they are at the end of the day. So it gets often difficult to engage with them. So what I'm going to do is, I'm going to do exactly what we do at a level of engagement. I'm going to show you, I have 15 minutes supposedly. In that I'm going to take 4 minutes to show you something that I hope that will increase your level of engagement. And the video mattu podinga.
Safest sound is the bomb is so nice. The snake is good for the ecosystem. It eats the rats and mice. Some snakes they can be dangerous, but the humans are too. Show respect to the bomb. It will respect me and you. Make sure you do. Open your eyes for the bomb. Get off the Facebook. Make sure you see. Do this be in harmony. The bomb you and me. Do this be in harmony. The bomb you and me. Very good. Do this be in harmony. The bomb you and me. Cobra, cobra.
Still, some of you are looking very seriously into this. But before I head into the presentation, I'd just like to remind you that public engagement or prevention models that I'm going to be talking about are not biological products. These are social engagement skills, or rather social science-driven models. So for the last 10, 15 years, we've been actively working in the space of snakebite mitigation. For those who have not heard about us, we are the Madras Crocodile Bank Trust. It's a zoo based out of Chennai. We actively work in the space of reptile conservation. How many of you are here from Chennai? Chengalpattu, Chennai. Have you ever visited the Croc Bank? Yeah, we are on the ECR, so we're right close by to the Chengalpattu side. So we are a reptile institution, and some of you who have talked about anti-venom throughout the day, as you know, anti-venom is prepared from venom. And venom, for the entire country, the 100% of venom that is supplied for the anti-venom manufacturing comes from this one institution called as the Irregular Cooperative Society, which is again situated there. So we've had roots back from 1977 when we had conducted the first snakebite conference along with the Madras Medical College back then. So I'm going to quickly run you through preventive models that we work on across the country, and especially in Tamil Nadu. Tamil Nadu has been one of our primary piloted grounds where we have experimented a lot of kinds of techniques and we have taken it to other states. General outreach sessions are done for school students, agricultural workers, people who are women self-help groups and things as such. And it often so that we don't really get that time when we want them at the ideal point. We get them when they are very bored or very tired. So it often requires, outreach cannot be very easy. So it requires various kinds of mechanisms with which we can talk to them about prevention models. And what we teach to them about is preventing snake bites, right first aid, and promotion to go to a hospital. So if you are getting victims coming to hospital, it often so happens that someone has told them to go to hospital, because as you know, there is a lot of myths and misinformation that floats around in the society that people don't really think that hospitals are the right places for snakebite treatment. These are some posters that we've developed, and 2 years ago, the Honorable Health Minister has actually launched them, and we have sent them about 2,500 copies across the PHCs. I don't know how many of you have received, but PHCs, we have sent a lot of them. Thanks to Dr. Raghunathan, Lydia, Dr. Gerard, Dr. Professor Saktivel, who has been actively involved in creating these posters. And some of the books that you're seeing about snake bites and bites and stings were also co-developed during the same time. So to be institutional, you need to have a lot of tools. You cannot just have materials that will not talk to children or talk to communities. And films have been one of the easiest way to teach science to, or preventive science to communities. Like the song that you have just seen was a music song that was created to talk about snakebite prevention. The lyrics of the song is entirely about snakebite prevention, but I don't know how many of you have really understood the lyrics. That's the intention behind these songs, is that not to really focus on the lyrics, but to get people hyped up for the first 5 minutes so that you'll have their attention for the next half an hour. That's how preventive models work, is that you can't expect, especially when you have a captive audience like this who are attentive to us, it's not the same condition when we are at a school. Children are willing to leave at 5 p.m. and we are holding them back for another half an hour. So you need to have a sense of entertainment or reciprocation that they would understand from. So tools like this act as a means of communication which would rather be a very boring lecture can turn into a fun interactive session. And making it hands-on, giving them storybooks. As you can see, one is a storybook about a person and a snake, and the other is a comic about snakes and how do you make distance with snakes. All these materials are used, and there are board games, and all these materials are used to make people feel more tolerant about snakes, and this encourages them at a time of a snake bite or at a time of a snake spotted that they should opt for right measures. It is very easy for a person to get confused if they should cut or if they should not cut. And these are the kind of preventive measures that we often talk about, and if we just tell them every day, it might work, but because we just meet them once a year, it's important that we tell them in a very creative manner. And if we don't teach them in a creative manner, they'll forget it the same day. So people need to be engaged. It cannot be easy. Yeah, even some hospitals and PHCs were willing last year that we have put information about snake bites there. Very important thing, I think, going forward as a state which will propose an action plan, it is important to understand that there are several challenges that will come and pose. And this is where we really want to work together with the government in understanding how do we standardize these tools, because there are a lot of information that could be irrelevant. We want to understand how logistics works, how sustainability works, and it should not be a one-time activity. It should be a sustainable program. So for that, it requires a lot of government and institutional reach. And in addition to that, we do a lot of training programs for the Forest Department, some of which you may have heard about an app that tracks snake bites or snakes in a state and tells them where the snakes are and helps people to come and catch them. For example, you see the lady in this picture. She was a forest watcher, and she wasn't really willing to catch. Everybody were taught about snakes that day, and everybody's fear was that snakes bite. And this lady very openly came to us and said that, no, I'll catch the snake. And she held that snake and she told the rest of the men, look at them, they're all fully built up, but they're all afraid. But this lady, when she picked up the snake, everybody started talking and everybody were telling about the fact that yes, snakes are harmless. Similarly, as a picture below, you can see that a group of ASHA workers and primary healthcare workers were trained about how do you access to the people and what kind of questions and data that you can gather from it. It's amazing how a majority of this work we have done in Tamil Nadu that has been reflected in the rest of the country where we work. And this is a preventive kit model. Oftentimes when a person comes with a snake bite case, we tell them you should wear a shoe, you should wear a gumboot. And it's very easy to tell this to the people. So what we have done is we have given them for free of cost to a bunch of 300 people. And we have tested something called as acceptability nature. So just because you give something for free of cost doesn't mean people will use it. For example, we see a lot of materials that we get in a conference like this. Just because we get it, it doesn't mean that we use it. Similarly, when we gave these for free of cost, we realized that a lot of people were unwilling to wear gumboots even if they've gotten it for free of cost. A lot of social factors. One of the biggest social factor was that they relate to the farmland as holy sites or as their mother or their home. And as you know, in Indian cultures, we don't really wear footwear into our homes. So similarly, people were reluctant that wearing a shoe might actually be unholy. And some of them were also telling how before the harvest season, to feel the softness of the soil, they use the back of their sole to feel it. So these kind of social structures and social enigmas are present, which we often oversight them and we give them advice at a place of privilege, and we often end up having an ineffective prevention method. This is a mobile application called as Serpa, which is very active in Kerala and Odisha right now, which is like a snake rescuer lab. If whoever have come to this venue today using an Uber or an Ola, you know that if you put your location, it will give you a taxi nearby. Similarly, in Kerala, when we launched this app, you can click a picture of a snake and it will tell you the nearby snake rescuer who will come and pick up or rescue that snake from that site of bite. And it has become so popular in Kerala for the last 5 years that it has become a government policy right now. It's been entirely handed over to the government of Kerala and they're doing fantastically well. And Kerala is also going towards the zero snake bite policy. One of the biggest reasons is because of this app. of course, we are not very proud of many things that we have done in the past. So then the reason why we are not very proud of it is because we have continuously assessed our work. We have understood that a lot of times what we teach may not reach to the roots of the community. And these are all done with the kind of surveys that we do. We do post and pre-evaluation surveys and a lot of impact assessment surveys where we ask people about their opinion about local hospitals. A lot of people have very negative opinions. And that's because of the social enigma that is present, is that they think if they go to a hospital during a time of snake bite, they may not survive. Those who come to hospitals could be one of the 3 people, because it's in several studies it is accepted that only 1 out of 4 or 1 out of 3 people attend hospitals in the case of a snake bite. So this is still prevalent. So to increase the amount of, because there's so much good work happening, hospitals are developing, there are more doctors, more trained nurses, and for this to be more useful, you need people who could help the community to understand the pathway. They should know that they should avoid going to a traditional faith healers and then go to a hospital. And how does this marketing work? Is when you work with NGOs and NGO partners. So, so I think working with snake bites has helped us a lot of things. Firstly, it helped us to unlearn a lot of practices that's often told anecdotally. And then comes the part of learning. This is very important, I think, as we grow as a society or as a community in this, where a lot of information that is you see about snakes or snake bites is locally relevant or most cases is false. We've been talked about how tourniquets needs to be applied. Now there is an option that tourniquets are not required. They spoke about how by looking at the bite marks you can say it's a venomous or snake bite, but now we have learned that that is not the right way. So there's a lot of challenges ahead, and we feel that a lot of this needs to be unlearned first so that we'll be in a space to learn again and cause better impact. Next slide, please. Yeah, I think that's my time. Thank you very much for being patient with us, and we are hoping that we could work together at some point of time. Thank you.
Thank you, sir, for the enlightening presentation. Now I welcome Dr. Sandeep Kumar sir, Joint Director, Communicable Disease, DPH and PM, to give the notification of snake bites.
Good evening. So good evening to our project director TNHSP, our additional director NHM, our joint director NCDC, Dr. Ajit sir, and also our members of this August gathering here. Myself, Dr. Sendil Kumar, joint director Communicable Disease. I am looking after IDSP part, Integrated Disease Surveillance Project, as a state surveillance officer also. So I am looking after this snake bite envenomation reporting to the NAPSA, International Action Plan for Snake Elimination also. In this context, just I want to highlight what made us to notify the snake bite envenomation as a notifiable disease under Tamil Nadu Public Health Act. We all know that Tamil Nadu Public Health Act is one of the oldest act in the country, which was enacted by the British government in 1939 actually, and it has gone various amendments in the subsequent times. So come to the next slide. So actually, you all know it, actually the basics were already dealt by our Joint Director NCDC. I don't want to go in detail. As we know that the snakebite envenomation was classified as a priority neglected tropical disease under WHO in 2017. So the actual burden, since as already our previous speaker told that 1 in 4 only the reporting to the government or private health facility, we don't know the actual burden of the disease in the community. So that is why it's made us to pass on a legislation. Next slide. So I'm just skipping the slides actually because already it was done by our joint director. Just to highlight is in India it is almost 3 to 4 million snake bites occur annually in India, out of which around 50,000 lives are lost. So as usual we know common crate, Indian cobra, Russell's viper and small scale viper are the commonest snakes in the community. Next slide. So in Tamil Nadu, snake bite cases reported in IHIP IDSP portal in this year, this current year from January to April is 4,007, out of which 0.9% were reported by the private health facilities. And this is districts with high burden will be Thiruvannamalai, Krishnagiri and Viluppuram share the first top 3 burden in the state. Next slide. So as we all know, National Action Plan for snake bite elimination envenoming, the goal is halving the snake bite deaths by 2030 and to strengthen the surveillance of the snake bite. Next slide. So in this context, when we see this, the last 3 years trend, 2022, 23, 24, and 25, we can see the trend. Actually, this is all almost like a, actually actual incidence is being reported here. But only thing is that we can see the seasonal pattern. So in the month of June, we used to have a southeast monsoon, followed by in the month of October, November, we used to have a northeast monsoons. So during this monsoon season, we used to get more number of cases that is being captured here in the IDSP data. Next slide. So again, the government facilities and private facilities comparison, actually that's only the less than 1%, almost 1% of the cases or incidents were reported in the private health facilities, rest from the government side. Next slide. Next slide. Just year wise, I'm just comparing, but again, the overall is 1% is the private facility reporting. Next slide. Next slide. Yeah, when coming to the highest burden of the burden in the state, we can see this Tiruvannamalai, Viluppuram, Tanjavur, and Krishnagiri. We all know that these are all basically agriculture districts, and also some terrain. Terrain also plays a major role in getting more number of snake bites in these districts. Next slide. Next slide. There's a geographical distribution. Next slide. So, when Government of India has asked all the states to notify snake bite as a notifiable disease in the month of October 2024. 23rd actually, 23rd October 2024. Even before that, we just notified it. Next slide. So in the month of October itself, we got the GO. Actually, this GO was proposed in the month of April 2024, and we got the GO enacted by the government of Tamil Nadu in the month of October, and also the gazette notification also made subsequently. Next slide. So this is the justification for the notification. So despite the severity of this issue, snakebite is often underreported, lacks sufficient system attention. So making snakebite as a notified disease will drastically improve the data collection, resource allocation, and prevention and for treatment purpose. As we all know, DDMS portal, Drugs and Diagnostic Management System, which is run by TNMSC, we used to stock adequate number of medicines. So just we want to highlight which area should need attention, high risk districts, and which PHC or which village or which is urban area which needs our attention. We need to know it so that we can just resource allocation can be done based on this. And again, the huge gap between the number of snakebite deaths reported from the direct service and also official data. That is also one reason. So in any health facility, every medical practitioner in the course of practice should notify the snakebite cases in the legislation. It should be done to the public health authority through IHIP portal only. We are getting daily from morning 8 a.m. to next day morning 8 a.m. Every day we are collecting the data. With the least practicable delay, there is no time delay was mentioned here, but only the least practicable delay we should report to the public health authorities through IDSP portal. This helps in tracking snakebite incidents and identify the high risk area for deploying resources like anti-snake venom. So we all know anti-snake venom, which is available in two forms. Actually, one is freeze-dried form and liquid form. So freeze-dried form is around 550 rupees per vial, and liquid form it's around 400 rupees per cost. 10 ml vial cost 400 rupees. So next slide. So these are all the notifiable diseases. This is overall notifiable disease. In Tamil Nadu Public Health Act, we have around 30 diseases notifiable, as we all know, including corona, the recent entrant, and the other things are mucormycosis is also the latest one. So apart from that, snakebite also included as a 29th disease conditions in the Tamil Nadu Public Health Act 1939. Next slide. Next slide, please. Yeah. This is the only one platform which is available to capture the data, IDSP, that is Integrated Disease Surveillance Portal, Integrated Health Information Platform. IHIP is a universal platform for snakebite notification, where it starts reporting from HSC, PHC, and GH Medical College. Everything is included in this portal. Next slide. I hope you all having the user ID and password. In the P form, you are supposed to report to the snake bites. So this is a portal for snakebite information entry. Next slide. So surveillance, we used to do a monitoring and surveillance of the snakebite cases reported in the district surveillance units, which is headed by the district health officer, and the state surveillance unit is headed by our directorate. So we are ensuring that minimum 10 vials of AHV should be maintained in any given point of time in all the PHCs and CHCs, and 24/7 it should be available, and this is ensured by the district health officer at the district level. Next slide. So effect are being taken to enroll all the private hospitals under Clinical Establishment Act with the support of DMS. Our team is also here. So we are ensuring it, and the data entry should be ensured in the IHIP portal also. And then communication on mandatory notification of snakebite to all health facilities, we already made it. We have made a social media advertisement also, so that it should be reached from all the facilities in the state. Next slide. This is a protocol for initial management, as Raghunandan sir knows it. Actually, from the nook and corner, we have disseminated this activity. Next slide. So this is a DDMS portal stock availability. So this was taken on yesterday, I think. It's 16,932 anti-snake venom vials are available throughout the state in the primary healthcare setup. That is also being captured here. And freeze dried is 4,163 is available. Next slide. So district-based stock positions also here. So as and when the stocks are replenished, we used to refill the stocks as per the availability. Next slide. Next slide. So thank you. Thank you all for patient listening. So I request all of you to please report it. So if you are not reporting, we cannot get the data, adequate data to properly plan and resource allocation. That should be a mandatory things to prioritize this activity. Thank you all, sir. Thank you.
Thank you, sir. I now request Professor Dr. Shaktivel Vayapuri, Reading University, United Kingdom, to present on the novelty in snake bite treatment.